So this is now the deanery of Palermo University. But in 1300, when it was first built, was actually the house of the Prince of Chiaramonte and his family. And as you can see, he has got a very classic Norman style with what is the influence of the Arabic architecture. And you can see this particularly in the arches, both outside and particularly this window. But what is very classic of 1400 of Sicilian architecture and other parts of Italy is this type of ceiling, which we call a cassettoni, which I think is cofted in English. And in those days, many people could not read, especially in Sicily. And so this kind of figurative art was the way to tell stories about events who were happening in those days. And so some of these, which is actually very, how can I say, avant-garde, are actually celebrating women. So you will see there are lots of female faces depicted in a modern way, because during the Normans' domination of Sicily, women had a very important role in society. Things went bananas later when the Spanish took over, but you will hear about this later. And also you have some stories of the era of the Carolinge cycle with the knights fighting and heroic gesture, and even King Arthur is, unfortunately, I think the King Arthur one are not as visible as the other are towards the back. This has been actually recently restored, so you can see it at its best after, I mean, I haven't seen it as well as this for 30 years, so we're quite lucky to be able to be in this room. Unfortunately, when the Spanish took over in 1600, this was taken away from the Chiaramonte family. And in fact, earlier on, actually, I should say, when the Aragona won the first battle of the beginning of the Spanish domination, took over this palace from the Chiaramonte family, and the Prince of Chiaramonte was decapitated in the square that you see outside, which wasn't as beautiful as it is now. It was a swamp at the time. And this became then the actual headquarters of the Spanish Inquisition. So any bad behavior is not tolerated in this building. Since 1400, you went down in the prisons, very bad things happen afterwards. So it's very interesting, because although the Spanish Inquisition is called Spanish Inquisition, this is where it all began, because at the time we were under the Aragona family. It wasn't a very friendly Spanish. Any Spanish here? One. Sorry about this. But I mean, you can be Sicilian. Not many Sicilians are very fond of the Spanish domination, but also you have contributed to wonderful history and architecture. So you've done something very good as well. So don't worry too much. So I hope you enjoy being in this palace, because it's also the deanery of the university. Of course, there are offices, so we need to be, mindful of that when we go up and down. And you will hear more about me, but now it's my pleasure to actually hand over the microphone to our host, who represents the Dean of Palermo Medical School, who is the king of the castle, as you would say. Professor, buongiorno.
Buongiorno a lei. Thank you very much. So, good morning to everybody. My name is Ada Maria Florena. I'm Vice Rector for Working Well-being and Livability in this university, and it's my honor and privilege to welcome you all on behalf of our Rector, Professor Massimo Midiri, who's not in Palermo today, for the opening day of the Faith Mediterranean Maudsley Forum. I'm a pathologist in my first and real life, so I had a look of your activity. I've seen that since 2007, the forum has organized many meetings focused on the updates on all the branches of the psychiatric and psychology disorders. And so I know you have a very strong program in these 3 days. So, and you're, of course, it's time to start. So just a few minutes. Welcome. I had prepared something on this seat, but I know which is we are lucky, because having the privilege and the chance of working here in the Palazzo Steri is really a privilege. Palazzo Steri has a long history. It was a seat of the Inquisition, the Tribunal of Inquisition, and so there are the jail, the prison, who are, this is a museum, so it's, if you have some time, perhaps the opportunity of visit the whole complex, it could be a fun idea. And then it was, it hospitals the La Dogana, the officers for the custom officers, thank you so much, in the past century. And so, and now it's of the university, in the own of the University of Palermo, and the seat of the rectorate. So just really to welcome you all. I hope the weather will be fine, better than last days. Everybody was very worried, but hopefully we'll have some good weather now. And so please enjoy, because meetings are enjoyable also, than instruction and educational, but not enjoyable. Enjoy Palermo, naturally, and please, and welcome once again here in Palermo. Thank you so much. It's up to you. Yes.
Thank you.
So toilets, this is a very important topic usually at conferences. So if you come out and you go round the courtyard, you'll see a green sign that also indicates stairs down. That's where the toilets are. So they are on the same floor. These are the toilets we'll be using, because there are toilets potentially on other floors. If you're desperate, tell me and I'll direct you to upstairs. But ideally, we should use this one, because as I said, there are also offices. You get coffee break. People have asked me for water. We try to be environmentally friendly, so I'm not producing hundreds of thousands of plastic bottle of water. But a coffee break, you would have coffee, water, and things. If you don't have your water bottle, there is a bar in the square, happy to direct you. If you're desperate, you might share it with the speakers, but don't share the glasses, just use the water you need. Anything else, feel free to ask me. The IT staff is at the end, and now soon we will show the password that you can use. And remember, this forum comes with a cognitive test. There is a different venue for the first 3 days. So you get the date wrong, that's a low score. So if you haven't read my email, I will recommend you go and read it, and make sure that tomorrow you don't turn up here, because this is not where we are. But I'll say this again throughout the day. And then Erika, Professoressa Lacascia, is actually our host from the Department of Psychiatry. Erika.
Thank you, Marta. Good morning. Welcome to everybody to Palermo and to University of Palermo. I bring you greetings from Professor La Barbera. He is the head of a psychiatry unit of General Hospital, and he is out for family reasons, but he is very happy to host you again. Every year we are happy because it's a moment of instruction, of education, and to develop new joints and a new friend. I really want to thank Robin and Marta, because we are friends and we are colleagues, and every year is a new moment to stay together. For anything you need, you can ask me, and I will be happy to help you. Enjoy Palermo and enjoy Maudsley Forum. Thank you very much.
Where is he? Hi, I'm Robin Murray, and also welcome you. We've actually had a first this morning, because usually the dean of the medical school says he's going to come and open it, and never comes. And we always wait for him for ages. But we had the vice dean who actually came and welcomed you. So, and spoke English. So this is great progress. So this is the 8th forum, and that has not happened before. So you know, we're in 3 venues. That is because the palace, which we usually use for 2 or 3 days, the mayor owns it, and he decided all of a sudden that he wanted it. We had booked it and everything, but strange things happen in the Mediterranean. So that's why we're going to go to the University Department of Psychiatry tomorrow, which will be interesting, because we can also see the old mental hospital. So we have our first speaker, who is Alan Young. Alan is the Professor of Affective Disorders and the Vice Dean of the Institute of Psychiatry at King's College. He's a great expert on affective disorders, particularly bipolar disorder, and has been chairman of or president of most of the bipolar and affective disorder international organizations. So, but without further ado, and he has also the advantage of being Scottish, which is so. But as well as trying to understand Italian accents, you have to try and understand Scottish accents at this conference.
Grazie, Roberto. So thank you very much to the... Oh, no, yeah. Well, my linguistic skills have their limits, Marta. So thank you very much, and thank you to the organizers, and a particular thank you to Marta for doing everything. Oh, I've got it. Right, I'm going to stand here. Right, okay, I'll move back and forward, actually. So today I'm going to be talking about the future of mood disorders. I brought my wife to Palermo because we take every opportunity we can to come to Sicily. And we were sitting having a coffee yesterday, and this couple of British tourists sat beside us. They'd come off a cruise ship and were doing Palermo in the afternoon, and they were somewhat lost, so we were able to direct them. Having been here for 24 hours longer, we felt like locals. But that's a bit like my talk, what they were doing. They were doing a compressed view of Palermo, and I'm going to do a compressed view of the future treatment of mood disorders because it's particularly interesting at the moment. But some background is in order. So these are my disclosures. So firstly, what are mood disorders? Well, crucially, there's a difference between mood and affective disorders, at least in my mind. This is mood disorders with the great dichotomy between bipolar and depressive disorders. Bipolar disorder, a group of disorders. Depression, and I'll come back to this, is dominated by major depressive disorder, but crucially, this splits into recurrent and single episode. And this is almost always glossed over. To my mind, it's a very crucially important point. Affective disorders, in my mind, have a wider meaning and include anxiety disorders, and particularly generalized anxiety disorders. So if we look at the WHO studies about the burden of disease, this is the one graph that sums everything up from 0 right up to 95. So that covers almost all of us. And you can see that depressive and anxiety disorders are the absolute heart of the teardrop of mental ill health, and indeed dominate it in terms of quantity. So depressive disorders, about 37% of the burden, anxiety about 23%. If you add in bipolar, it's over a third of the deleterious impact of severe psychiatric disorders is due to affective disorders. Now, this is present across all age groups, although it varies by age. You can see it starts in childhood. Indeed, we have very distinguished child psychiatrists here hiding up the back who are going to tell us more about this. And then it goes through to old age. To my mind, there's two real markers in the age distribution. One is puberty, where I think things change. And the other one is the onset of old age, particularly late life depression, which I think is different from more regular depression. But the key point is that depression and anxiety, and indeed bipolar, are very important. They are, of course, correlated. Now, I was a bit worried about showing this slide because I was sitting in front of Marta and Robin and their postdoc, and they were talking about this on the plane, and I wasn't sure if I was out of date. But the point is, from this paper in 2020, and this field does move very fast, that there are correlations between these disorders. So you can see major depression here correlates very strongly with anxiety. This is particularly generalized anxiety disorder. So the two are almost like Romulus and Remus. Their correlation is weaker with bipolar disorder, but bipolar disorder correlates strongly with schizophrenia. And then there are important correlations, particularly, for example, with ADHD. And this is something that we're perhaps just realizing, that lots of the treatment-resistant depression has a comorbid ADHD, which is very often not recognized or treated. So what is a major depressive disorder? Well, I've put the ICD-10 criteria here because they differed more from DSM-5 than ICD-11. They had a third hallmark symptom of reduced energy, which has been dropped. But really, it's depressed mood or anhedonia, plus a parcel of other symptoms for about 2 weeks. Now, the problem is that this is a very low threshold to reach and includes lots of people. There's a very nice critique by Ed Shorter, who's a very distinguished historian of psychiatric disorder, in the British Journal of Psychiatry in 2014, about the DSM-3 concept of major depression. And the DSM-3 concept is essentially the same as DSM-5. And what Professor Shorter says is that Spitzer and others in DSM-3 parceled in lots of different things into major depression. And because DSM is atheoretical, the old notion of a reactive depression was lost. So it's a big bucket, to use current management speak, and there's lots of different things in it. Now, when we think about the difference between single episode, recurrent, and unremitting, the study by Eaton et al. Is particularly instructive. This is from Baltimore in Maryland. It's a prospective population-based cohort study with 23 years follow-up of about 3,500 people. And 50% had no further episodes, lasted between 9 and 16 weeks. Now, this is obviously a very different group to the recurrent or unremitting group. I continually say when I'm advising about trials to companies, take away first episode, only look at unremitting or recurrent. They don't necessarily want to do that, but this group who've a high spontaneous resolution rate fuel the placebo response in studies. 35% have recurrent episodes, 15% have an unremitting course, which is really very, very depressing, if you'll excuse the pun. Risk of recurrence increases after each subsequent episode. If you've got 3 episodes, it's a 90% chance of recurrence. And only younger age of onset significantly predict recurrence. So this is what's happened with psychiatry slowly over the past 10 or 15 years. We've gone from looking at depression in the round, the big bucket from DSM-3, to thinking about treatment resistance, because this is a more defined population. Now, a third of patients will develop treatment resistance according to the definition of a failure to respond to adequate treatment with 2 standard treatments. Some people include psychotherapies here, some people don't. But this is still a big group of individuals. Now, the whole field of developing new therapies is focused in this area. This has come very slowly. It's a bit like an oil tanker turning, but it's a very good development in my view. There's also, this notion of treatment-resistant depression comes from a 1997 paper by John Rush and Michael Thays. John Rush, and here's the reference here, has produced a number of papers. This is one that I'm on with Hamish McAllister-Williams, about reconceptualizing TRD as difficult to treat depression. Now, just to make clear, this is not an opposition to TRD. TRD is a definition that's used in trials and studies. Difficult to treat depression is a clinical approach. And this is essentially more or less what we do in the clinic. We confirm the psychiatric diagnosis. We assess adequacy of prior treatment recommendations, including dose and duration. Look at adherence. Pharmacogenetics are coming in, and therapeutic blood monitoring. Look at concurrent psychiatric and medical conditions, and look at environmental stressors. So it's pretty simple, but John Rush has a real eye for spotting something that needs to be said. And I think difficult to treat depression is a very good concept. So good that the slides have vanished. So, yeah, sure.
In these groups that you have described, how common psychotic symptoms are?
Well, that depends what you mean by psychotic symptoms. With psychotic depression, there's two schools. There's a very narrow school, which says that you've got to have almost Schneiderian first-rank symptoms. And then there's a broader school, which say that even negative cognitions would count as psychotic. So it depends on your definition, as in all these things. If you look at the very narrow concept, it's really quite rare. If you look at the broader concept, which actually gets so broadened as to almost be meaningless, it's really quite common. So psychotic symptoms are, psychotic major depression is one of the subdivisions. One of the others is, of course, bipolar depression. Now, one of the things that's very often not fully realized by trainees is the diagnostic criteria for a major depressive episode are the same for bipolar depression and a major depressive disorder. The only difference, of course, is that in bipolar disorder, you have a history of mania or hypomania. So that's a crucial point. The other subdivisions, which to my mind are important, are, of course, the recurrent, the unremitting, and also the so-called atypical group, the group who, instead of having reduced sleep, have increased sleep, instead of reduced appetite, have increased appetite, and so on and so forth. This is called atypical, but it occurs in maybe 35% of people with depression, and even more in bipolar depression. So we're just gearing up again.
Yes, I think he's the projector of that. As you know, I'm a psychosis person, but psychosis can come with mood disturbance. But if I think about my training in psychiatry, the most severe cases of depression, that's why I ask about psychosis, with very pervasive delusion of guilt and nihilistic delusion, were actually postnatal depression.
Oh, absolutely. Postnatal depression can be incredibly severe. You also get lots of psychotic depression in the elderly and lots of psychotic symptoms. And of course, our use of ECT, which I'm going to come on to, is increasingly in the elderly. Okay, well, maybe I'll just carry on lecturing. We can do questions now.
Yes, we can do some questions. Thank you.
Thank you so much. Until this point, at least. Maybe in the beginning you said that in your opinion, depression in the elderly differs significantly from depression in the young. Can you elaborate on that a bit?
We've been doing work on this for about 3 or 4 years, maybe longer, and it comes from initially the observation that the risk of a dementia is increased if you have a depression. But paradoxically, or so it seemed to me at the beginning, that this is not related to a lifetime of having depressive episodes as strongly as it is to having a late life onset. Now, late life, some of us will be pleased to hear, has a definition which seems to float about depending on the age of the definer. But it's probably, I'm sorry to say, somewhere in the 50s. We've looked at this in terms of therapeutic studies. There's a body of literature suggesting antidepressants don't work as well in elderly depression. ECT does, but antidepressants don't. When we've looked at some of the data from the trials, it seems as though the therapeutic signal is much reduced in individuals who have their first episode of depression after the age of 50. Why would that be? Well, it's likely to be a prodrome or in some way related to the long onset of depression. In bipolar disorder, we've also looked at people with a first episode after the age of 50. So no depression before, no mania before. And they have much less of a family history, suggesting less genetic loading, and a much higher rate of organicity. So it looks as though somewhere around about 50 to 65, depending on your definition, the first onsets of depression are different. And this is important for trials as well. So one of the studies that I'm going to show you is about ketamine, nasal S-ketamine. In the initial study in the elderly, nasal S-ketamine didn't separate from placebo. the definition of depression didn't take into account age of onset. In the most recent study, which is not yet fully published, the definition of elderly depression, the first onset had to be before the age of 55. You could be 65 or 70, but you had to have your first onset before 55. And there was a much clearer and significant separation from placebo. So I think this is important, particularly for therapeutic studies. Again, defining the population of depression is absolutely vital. Just taking it as one big bucket doesn't particularly help. Okay, I'll carry on, and I'll carry on with my memory of the slides. Oh, Robin's going to help me here.
No, I'm going to apologize to the people online about the. Well, people here know our difficulties, but the people online are wondering whether their electricity is not working or their internet.
I think it's actually Alan's fault, because we always started with psychosis, the forum. Whenever we opened the forum with psychosis and schizophrenia, we never had any technical problem.
Well, my first professor of psychiatry on a ward round used to say to the trainee, put the notes down and tell me what you really know about the patient. So this is a challenge. So I will attempt to give my lecture without the slides until the slides appear. So shall I do that?
And then we'll mark how successfully.
Thanks, Robin. Okay, so there's a couple of other factors in terms of looking at studies which I think are important. One is the placebo response. Now, this has been taken to be nothing more than an irritant, but in actual fact, I think it's extremely important and therapeutically potentially beneficial. So Professor Phil Mitchell from Sydney years ago produced a paper called Placebo Effect, Boon to Therapy, Good for Therapy, but Bane of Research. But that means that we should be researching into the placebo effect. Now, the placebo, the spontaneity of the illness, if you include lots of first episode depression that a likelihood of lasting, say, 2 to 3 months, in a trial, there's going to be spontaneous resolution. So that's not really a placebo effect. That's a regression to the mean or so on and so forth. The other component, apart from the active therapeutic component, is the placebo effect. Now, we've tended to dismiss this as being nothing more than an irritant, but in actual fact, not only are there psychological factors which may be of great importance for thinking therapy works, but also at play. When I worked in an increase in dopamine turnover, may have a psychobiological as well as a purely psychological one. The other thing that we can do is we can look at the placebo effect by blocking studies where we have already achieved a response. So one of our colleagues in Center for Affective Disorders, Luke Jellin, who's doing a PhD, he has a study looking at ketamine responders and doing a double-blind placebo-controlled blockade of this with an opiate antagonist. And I think we should be doing more research looking at placebo responders and blocking of effects. The other factor, which I think is extremely important in thinking about trials, which almost never gets addressed, is patient preference. So there's good work from Massachusetts suggesting that if you really want psychological treatment, talking therapy, and you get drug treatment, your response rates are much lower than if you get the therapy that you want. And if you really want drug treatment and get psychological treatment, the same is true. We never examine patient preference for therapy in studies. And I think this is particularly true for some of the talking therapies, where the patients who are recruited really want talking therapy. So those are two background main factors. Then my slides, which you can't see, neither can I, are going on to look at hot topics which are arising in mood disorders. Now, the first one is rapid intermittent treatment with antidepressants. So at the moment, the paradigm is you get CBT or SSRIs or the combination regularly for a prolonged period of time. If your first episode of depression, you get that for 6 months after you're well in terms of the medication. If you're recurrent, you get it for at least 2 years. We're moving to a model where people get a one-off treatment, and this started with ketamine but has gone on to psychedelics, and there's other treatments coming in that may have enduring effects. Now, I think it's very unlikely that people with severe mood disorders will get one treatment and that will cure them for life. But we may be entering an era where people get intermittent treatment every few months. And indeed, some would argue that that's what people have been doing with psychedelics on the street. Now, we're going to hear a lot more about psychedelics from James Rucker, who's sitting there, who's in our group, and is fondly imagining himself giving one of the subsequent lectures, but with slides. So I'll leave the psychedelics to James, apart from to say that it's a very interesting area, but it's in danger of being over-promoted. So in the last few days, we've seen another flurry of interest in psychedelics, with politicians telling us that this should be made available because it will cure depression. Now that is ridiculously early, in my view. We need to have a medical, scientific approach to evaluating the benefits and harms of all new treatments, and that includes psychedelics. So going back to ketamine and S-ketamine, so of course many in the audience will be aware of glutamate and the NMDA receptor with psychosis. I first came in contact with the NMDA receptor in the late 1980s doing my PhD, when my lab was next door to Professor Richard Morris's lab, which was looking at the NMDA receptor in learning and memory. And even back then, there was a notion that the NMDA receptor was going to be important for the mechanism of action of antidepressants or novel antidepressants. Indeed, Ian Reid, another psychiatrist who was working with Richard Morris, Ian sadly died years ago, produced a whole theory about ECT working via the NMDA receptor. So this had a long, slow burn until Husseini Manji joined Johnson & Johnson and really led the whole program to make S-ketamine a licensed treatment. Now, you might say that we know that the racemic mixture is efficacious, but the total number of people in trials with the ketamine infusion is about between 200 and 300. That would never be accepted by the FDA or the EMEA for licensing purposes. S-ketamine, the racemic mixture, went through all of that and has a license for treatment-resistant depression. It's not being taken up very widely because it's very expensive, but nevertheless, it's the first really new treatment that we've had for treatment-resistant depression in really decades. So I think it's the first of the new. Now, a key question of any new treatment is where it fits into the treatment pathway. So S-ketamine is very expensive. Is it any better than our standard augmentation options? Now, the first thing to say is that I'm just looking in case my slides up here. Professor Tony Clear and I have done a study called the LQD study, funded by our National Institutes of Health Research. This is really Tony's study. This looks at people who failed 2 antidepressants, and then we've augmented them with lithium or quetiapine. Now, I'm a great lithium advocate. I was firmly convinced that lithium would beat quetiapine, but across the board, quetiapine beat lithium on every outcome. Why is that important to ketamine? Because Johnson & Johnson have done a study with the same design. Remember, we did failure to respond to 2 antidepressants, lithium or quetiapine. The ESCAPE study is the same design, but quetiapine or S-ketamine. And S-ketamine beat quetiapine, put very simply. So it looks as though there's a hierarchy here.
Sorry about that. The good news is that you can, rather than sleeping tonight, you can actually, you will have a link where you can access Professor Young's slides. And then I will quiz you tomorrow to see.
It's MMF final. So in the ESCAPE study, S-ketamine beats quetiapine. In the LQD study, quetiapine beat lithium. Now, it's still possible that the final recommendation may not be for S-ketamine, because if you look at the health economics related to the expense and so on, then it may well be worthwhile going through a number of other steps first. But James is going to do psychedelic digital. Oh, Oliver.
Just on your lithium quetiapine study, can I ask, was that augmentation?
Yes. So they were both augmentation studies. So they're both studies where people filled into antidepressants. They're very pragmatic, because what clinicians tend. I'll repeat the question. So the question is about ECT. Now, one of my slides is our current depression treatment pathway, which includes ECT. And when I get down, it was probably about 40% better. Yeah, it was quite, than quetiapine. Yes, it was. Yeah. It was enough to be clinically significant, I would say. Question here?
When I started doing psychiatry as a registrar, I was told that you had to have a 4 to 6 week wait to see if an antidepressant was going to be effective. And later on it emerged there was a subgroup who would have a response earlier, perhaps 10 days into it, and that correlated with variants of the serotonin receptor, whether they had the long tail or the short tail. Can you comment on that, please?
I'm not sure the long tail and short tail of the serotonin receptor has been replicated, but the burden of evidence is, and this is a meta-analysis by Zagedi, that if you don't show at least a 20% improvement on your depression scores by 2 weeks, then you only have a very small likelihood of responding. Now, there are late responders, and I'll show you, if I ever get to it, a slide that shows that in the ESCAPE study. But the point is that clinically, people leave patients far too long. So patients will be left for 6 months. I mean, we did a survey in South London, Roland Zahn and I, and discovered that the commonest thing that happened after people were started on antidepressants was to do nothing more. People hadn't responded. They were never even reviewed. So we should review early. Here we go. Do have TRD. We have standard treatment strategies that we do at the moment, including augmentation that we examined in the LQD and ESCAPE study, combination, so on and so forth. These strategies are common in clinical practice, but evidence supporting their efficacy is limited. Now, the lady at the front made a very important point about when you should consider changing treatment. But we all say, the BAP guidelines, all the other guidelines say, review between 2 and 4 weeks. Active review is important. First 2 week presence. So this is strategies for major depression. Screen and diagnose SSRI or SNRI. Inadequate response. You should be looking in the APA CANMAT guidelines for that very early. After 2, then it's a carousel of treatments. So it's not a series of treatments that you have to go through like a Via Dolorosa. It really is an option where you can personalize it. You can add CBT or other psychotherapies at any point. Indeed, you can do these initially. You can combine antidepressants. There is some evidence for that for particular antidepressants. Or we augment with atypicals, lithium, and quetiapine, and that's what I've just spoken about. With inadequate response, people talk about ECT, TMS, and VNS, but I'll leave that till I come on to those slides, hoping that they don't disappear again. Get minimally adequate treatment. This is from Graham Thornycroft, and in low and middle income countries, it's 1 in 27. So although we do have treatment paradigms, we have a treatment pathway that's accepted, we're really poor at doing this. Now, this was a study by Graham about 6 or 7 years ago. We did this again for the European Brain Council with Jonas, who's in the audience, was one of the group here, Jonas Ebhard and others from across Europe. And these are the headline results across Europe. Now, the UK was not particularly good, it was not particularly bad. It was somewhere in the middle. So I'm afraid we're unexceptional. We probably would get a B-, but no one would get an A. 52% detection of depression. Of that 52%, 62% were treated, 33% had good follow-up, and access to secondary care, which means psychiatrists, 19%. Access to psychological treatments was even lower. So although we have a theoretical treatment pathway, putting that into effect is very difficult, and we're arguing against other areas of medicine. We're arguing against childhood cancers and so on and so forth. If we say to our government, we need more money to be spent in mental health, our Chancellor of the Exchequer would say, well, what do I take it away from? So this is the future treatments. I want to talk about digital first, and I can deal with that. I've gone on to rapid acting, so you can tell my memory is not perfect. I'm going to talk about neuromodulation, different types. I'm going to talk about probiotics and the gut, and I'm going to talk about lithium. And hopefully, I'll still finish reasonably in time. This is what I was saying about the placebo effect. This is from a nice paper very recently that Luke Jellin sent to me. This is the perceived placebo effect, spontaneous remission, and so on and so forth, Hawthorne effect. The true placebo effect, which may have a biological component, if you think about the Parkinson's studies, and then the active treatment. Now, the clinician and the patient benefit from the totality of this. And I actually think that we've been rather foolish by not maximizing the placebo response for our patients. A key to this is a good therapeutic relationship with the same healthcare professional. But I think looking at this is a real focus for further research. And this is the patient impact. So this is what I was saying about patient preference. If you're someone who really wants the new talking therapy and you are put in a trial for the new drug, your likelihood of response is very low. So this is from Papakostas and Koskis. These aren't randomized between the groups, but if it's a medication trial and you receive, for example, psychotherapy, and your preferences for medication, your response is much lower than if it's medication or combination. Look at the difference between if your preference is psychotherapy and you receive psychotherapy compared to receiving medication. We never talk about this in studies. This is incredibly important. We should be thinking about this and trying to take away this source of variability in studies. Right, digital. Now, this is quite quick because this is probably the area of greatest uncertainty, at least in my mind. The possibilities for digital are huge, but in actual fact, we don't know how it's going to pan out. I was at a dinner party a couple of months ago. A lady sitting next to me didn't know I was a psychiatrist. I asked what she did. She said she had a new mental health app that was going to cure depression. Her and her husband had worked for an airline, were made redundant, and went into setting up a depression app. There's thousands of these out there, and their efficacy is questionable. So here's the potential things that might happen in the future. There's mental health apps, of which there's many. These are going to be good for monitoring, but they're essentially going to be unregulated. Whether they will really aid the detection of depression or produce a lot more false positives is questionable. Robotics, I'm quite looking forward to robotics and having a therapeutic companion. Gaming has got both disorders and potential therapeutic uses. Virtual reality, there's been a bit of this done in the Institute, both in terms of assessing people, particularly neuropsychological function, but also delivering therapy in a virtual reality setting. Who here is a Star Trek fan, apart from me? Right. Well, you'll all know about the holodeck. And conceivably, you could be getting your psychotherapy from Dr. Freud at some point in the future. Artificial intelligence, in terms of research, prediction, prevention, and diagnosis, is undoubtedly going to be huge. The rate of development of AI, I think, has reached a crucial stage and is really, it's like a rocket taking off. Where it's going to be this time next year, we don't know. Never mind 10 years' time. Social media, this has very deleterious effects on mental health. If you have teenage children, you'll perhaps be aware of this. This is, I think, behind lots of things that are happening in child and adolescent psychiatry, including increase in self-harm and so on and so forth, exposure to pornography. Digital phenotyping comes with AI. And then we've got neural implants, which is associated with Elon Musk, but may well happen. We may well have things like this. It may be led by things like Parkinson's, but it's going to come to our field as well. Of course, one is to deliver psychotherapy. This is just the evidence that CBT added to antidepressants give an extra boost, or vice versa. Indeed, my colleagues in the Netherlands say that they are considering making the first-line treatment for depression the combination of CBT and antidepressants. Now, that would certainly be evidence-based, but it's going to be very expensive. In Germany, a year's SSRIs cost 80 euros, a session of CBT costs 80 euros. So I suspect it's still going to be SSRIs first. This impacted our own research. We had a grant for doing mindfulness-based CBT in a group setting, which was due to start in March 2020, but something else happened in March 2020. So we had to rapidly change it to an online setting. And the online group delivery of the MB-CBT seems to have worked very well. Now, we don't have the full data yet. We haven't quite finished the trial, but the format seems acceptable. So there's going to be big changes in detection and delivery. Now, I've been through this. This is just to show the pharmacological therapies for mood disorders. I was going to ask Robin, because Robin likes putting me on the spot, so I'm going to put Robin on the spot. This is one of the first trials in mood disorders in a randomized controlled way between Davies and Michael Shepard, Lancet, 1955. Robin, what was the medication?
The medication must have been chlorpromazine.
Perhaps not a surprising answer. It was reserpine. And reserpine showed a therapeutic signal for depression. And we've just done a meta-analysis of all the reserpine studies published in the Journal of Psychopharmacology. Not, they were all published, but we published our meta-analysis. Reserpine, every medical student will tell you, causes depression. If you look at the studies in the round, there's just as many showing it helps depression as causes depression. But from then on, all of the antidepressants and treatments were basically in this mechanism of action paradigm, increasing serotonin, noradrenaline, blocking dopamine, and so on and so forth. This is a very simplified version of the glutamate type approach with the GABA inhibitory neuron, the glutamate surge, the AMPA receptor, perhaps finally affecting BDNF. So this is a new model, if you will. And there are numerous treatments working on this, different parts of this diagram. Brexanolone works here. There's ketamine effects, S-ketamine effects here, and there's new drugs being developed by others. So this is the background. This is the S-ketamine data showing that compared to a placebo, now they were, going back to Oliver's question about augmentation, in the S-ketamine studies, they were all on new antidepressants plus the S-ketamine nasal spray or placebo. And you can see it separated, perhaps not that impressively, but this was maintained over following a year or so. This is the ESCAPE study that I mentioned. Now, the LQD study that Tony Clear did, same design, but instead of quetiapine versus S-ketamine, it's quetiapine versus lithium. Quetiapine beat lithium. In this study, S-ketamine beat quetiapine. Now, you asked about the magnitude of the effect, and you asked about the onset of effect. This is actually really interesting in this diagram because it shows, to some extent, both. So if you look, this is the acute phase up to 8 weeks, and then the continuation phase up to 32 weeks. But also, both groups, there's an increasing benefit over. And I said about 40%, so it's roughly 40% extra. we'll have to look at but maintaining it. And that's a much more clinically practicable and helpful measure. So this is psychedelics. I'm just handing this over to James. And in case you can't identify James, who's sitting in something like the 6th row, this is him here. And this is the rest of the attractive, charming, and clever psychoactive group. Right, I'm going to talk about neuromodulation here. This, to my mind, falls into two camps. There's ECT and vagus nerve stimulation. Now, ECT, Julian Mutz, who was our master's student, who's a PhD, I think he's a postdoc now in SDGP, did a nice review in the BMJ in 2019, showing that bilateral ECT is the most effective treatment for depression. Despite all of the stigma and attacks from the anti-psychiatrists. Vagus nerve stimulation, which is widely used for treatment, I'm unconvinced about this. There was a recent headline about new super effective treatment for depression, for treatment-resistant depression from Stanford, from Nolan Williams, who I know patients, the other had 13 patients. So this is no more term. Registry studies show good effects, but because it's so expensive and because it's invasive, it's going to be used very sparingly. This is the flow neuroscience. This is the TDCS. I should say that I'm on their scientific advisory board, and Cindy Fu has done a very nice trial, which is not published yet, but shows that this is antidepressant convincingly. Nevertheless, if any of you can bear to read the Sky news story, which came out yesterday, I was preparing these slides and my wife said, "Oh, have you seen this?" And this is the link here. The claims that are being made for this are really almost too good to be true. So it's more effective than existing depressive treatments, and it keeps people well in the long term. I doubt that's true, but because you can go online and order this right now, if you can pay the money, then people will be treating themselves with this. So it's a very scalable therapeutic intervention. Indeed, the chairman of the company, who's a very nice young Scandinavian man, wants to treat the whole of the population of Greenland, because Greenland has the highest rates of depression in the world, with this device. Okay, probiotics. Given that we're in a part of the world that's so good for food, I thought I'd introduce this. So the gut-brain axis, bidirectional communication, partly through the vagus nerve, which has got a strong component taking signals from the gut to the brain, and this may be related to VNS action, the immune system, and the endocrine system. Now, this is a review that was done by Victoria Nikolova, our PhD student in JAMA last year, and she reviewed all of the composition of the gut microbiota and psychiatric disorders. Quite a lot of evidence, evidence of transdiagnostic patterns of alteration in MDD, bipolar disorder, schizophrenia, and anxiety. So there's something here going across psychiatric disorders. Now, if you're old enough, like me, you'll remember there were lots of spurious findings, I'm sure, interact with the genes. Probiotics treatments as being a bit like Coca-Cola or Pepsi. So you can't patent the individual components of the composition, but the blend is actually secret. So that's how it's monetized by the companies. But this is the updated review, and she got 50 people. We definitely expected it to show nothing because it's only 50 people. Victoria doesn't want me to say what the results are because they're not published, but it's going to be published in a high-impact journal, JAMA, which you don't usually get with small negative studies. So very interesting piece of work. Okay, I want to finish up with lithium. I haven't talked much about bipolar disorder at all, despite the fact that the two main components for psychiatrists of mood disorders are treatment-resistant depression, which I've majored on, and bipolar disorder. Lithium is our oldest treatment by a long way because it's an element. It was created just after the Big Bang by God or nature, depending on your belief system. And it's in all of our environments. Remember this when people scoff at the effects of environmental lithium on suicide rates. It's there from before conception right through to death and can alter brain function, undoubtedly. But as a therapeutics agent, it's fallen into disuse by psychiatrists, especially in North America and increasingly in the UK. Now, this is a great shame because lithium has its disadvantages. It can have effects on the kidney and the thyroid and so on. But for many people, it's a game changer for the patients. Now, this is a review which is not yet published. It comes out in the next month or two. It's rather small print, but we looked at the entire world literature comparing mechanisms of lithium treatment efficacy in people with bipolar disorder. Well over half of the people treated in all of the trials had a good outcome. Now, that is incredible. And the reason that we're not using this more is mysterious. The reason that the MRC and the other funding agencies aren't putting major funding into trying to work out how lithium works really baffles me. But the European Union has done this with us and with Franck Bolivier and colleagues across Europe, and some of whom are in the audience. Jonas again. This is the R-Link study. This is an attempt to look at personalized medicine, identify the individuals who will show an excellent response to lithium. Now, when we wrote this grant, we didn't have the benefits of the review, which we've not published, but looking at the literature, about a third of people with bipolar 1 will have an excellent response to lithium, a third have a partial response, and a third have no response. If we could identify ab initio those who are not going to have any response, or those who are going to have an excellent response, it would be a great advance. And it's really the first major attempt to do personalized medicine in mood disorders. And it was a reasonably large grant. Tony David was the head of academic psychiatry at the time. And I swear when we got this grant, Tony almost smiled. And these are the individuals who are helping us. It's really headed by Franck. There was a debate about whether Franck or I should be PI, but as Brexit was happening, we thought it might maximize our chances to have someone who was actually a European. And this is a very simple schematic of what we're doing. We're doing biomarkers of lithium response, actimetry, ecological-based measures, pharmacogenetics, molecular signals, and brain lithium distribution. David Cousins, who trained with me in Newcastle, still in Newcastle, runs the MRI unit. Lithium's response may be as simple as the people who get decent levels of lithium in the brain. David's work so far shows there's a very poor correlation between peripheral lithium levels and brain lithium levels. Now, that would be too good to be true were it that simple, but one never knows. We've finished the study. We're analyzing the data, and we'll be reporting on it soon. So, going back to my current treatment strategies, this is our Maudsley pathway. This bit here is going to change greatly. I think we're going to see lots of detection of depression with apps and so on. You can already get the PHQ-9 for your phone. Whether this produces more false positives, more people talking about their mental health who are not actually suffering from mental ill health, remains to be seen. We're also going to see a lot more treatment here with things like the flow neuroscience device, probiotics, and so on. That's not that new. Remember, in parts of Europe, people are advised to take St. John's wort first before they go on to formal treatment. It's going to be a different kettle of fish when you get to treatment resistance. We're seeing new treatments related to ketamine and so on. It's possible that some of the other areas I've mentioned may be important. I mean, what they may actually do is reduce the amount of treatment-resistant depression. If it's detected early and treated, it may well work. Some treatments we're not really sure where they're going to fit. James will talk about psychedelics, which have been looked at in TRD, and VNS and ECT remain important. And lastly, this is a whole area where we as psychiatrists need to not only understand conceptually, what's going on and the evidence base, but we need to advocate for it in the public forum. In mood disorders, we are seeing increasing misuse of meta-analysis and systematic reviews. Perhaps the most egregious was Joanna Moncrieff's serotonin debunking in molecular psychiatry, where they'd left out important positive results, for example, the PET studies. So we've got to be aware that we've got a huge amount of information. This feeds through to knowledge, but really we need wisdom to understand the field and to try and help our patients best. Thank you very much.
Thanks, Alan. One, for an excellent lecture, and two, for overcoming amazingly well the difficulties with the slides. First of all, an online question. Could you please specify the dose of quetiapine for non-responding patients?
300 to 600 milligrams daily XR. It was, in the ESCAPE study, it was 300 to 600 milligrams, between 300 and 600 milligrams of the quetiapine XR. It doesn't really matter to my mind whether you use the XR or the IR. The dose that you use of quetiapine in augmentation is much less than an antipsychotic dose. Years ago, Joe Calabrese and I looked at the data for bipolar depression, which was looked at 300 and 600, and you get about 95% of the effect of 600 with 300. So there'll be the odd patient who needs more than 300, possibly they're fast metabolizers, but generally the lower doses work.
And then, Alan, the same person is asking, what about evidence for mirtazapine or trazodone in add-on to SSRI or SNRI?
So in South London, that glorious oasis where we all work, or many of us work, it's very common and very common throughout the UK for GPs to do combinations of antidepressants. The combination that's evidence-based is mirtazapine plus a reuptake inhibitor. Combining bupropion and an SSRI hasn't been shown to have any extra benefit, but mirtazapine or mianserin, which people don't use very much because of the blood dyscrasias, plus an SSRI is the evidence base, and that's fairly effective. We almost never do that in our clinic because they come to us usually on that or having tried that. Of course, there is an increased side effect burden, especially with weight gain and sedation from the mirtazapine.
Could you comment on augmenting with agomelatine, which has got a different way of functioning, with a SSRI, for instance?
So agomelatine, it's a real, I mean, it's almost like some biblical parable of drug development, because this is a drug that's got a novel mechanism of action. Basically, it's like a combination of trazodone and melatonin, so it's melatonergic, and it's got 5-HT2 action. The trials show that it's really very well tolerated. It's actually very good for sleep, but with no hangover because it's got such a short half-life. Its side effect overall profile is about the same as placebo. It always seemed to me to be the perfect GP antidepressant, but it had a tiny increase in, a tiny percentage of the patients in the trials showed an increase in liver enzymes, and for that reason it's got a requirement on the label to do serial blood tests. That killed it in the UK and many other countries, although it's still used quite commonly in France. I'm not aware of any trials of augmentation of other antidepressants with agomelatine, but I know that my colleagues in Germany and Austria do that quite a lot, and I've inherited some patients from them where, based on what the patients say, it seems to be helpful. But I don't think there's much of an evidence base.
Another question from online is, what about modafinil? Oh, excuse me. Right.
So it's your line manager, Robin. Yeah, we use a lot of modafinil to augment antidepressants. Modafinil is actually really well tolerated. We particularly use it for augmenting where there's more of an atypical pattern, so fatigue, sleepiness, and so on and so forth. We find it very useful, and it does have somewhat of an evidence base.
Hi, it's Alex Butt from St George's. We're still keen on the biopsychosocial approach. What about social interventions like debt advice or social prescribing?
Well, I mean, I think lots of things work, and that's why I like to remind, we're all keen on the biopsychosocial model because the biopsychosocial model was invented by psychiatrists. We all look at those things as part of our formulation. If you look at the group of people who are first episode or likely to spontaneously remit, they'll respond to anything. I think they need to have decent trials. I mean, this is one of the frustrations of the way the media treats depression. We get people saying, well, you know, I was depressed and I took up yoga and that helped me and I've never been depressed since. Well, you were lucky because you fell into the group that had one episode only. That's very different from the group that has the recurrent. And for the group that has the more recurrent, more severe, I'm afraid to say the more biological part of the biopsychosocial model pertains. And I can't see that changing.
But what about if you have an alcoholic spouse or you have a child with chronic leukemia? Do any of these studies take into account the social pressure that the sufferers are under?
Not really, and there's lots of problems with the trials, especially in North America, where people are rewarded on recruiting. There's professional patients and so on. There's certainly studies, and we took part in some of these, that looked at carer stress. And if you're caring, for example, for someone with dementia, then your level of stress hormones is as high as the melancholic depressives. So there's no doubt that this is a significant. And if you go back to John Rush's difficult to treat depressive model of how to help these patients, there's clearly an aspect of what you're saying in there. I mean, I've got a patient who's generally quite well, but he has a relapse every time his mother-in-law comes to stay. I've been unable to change that, but it's clearly an association. Sorry, Robin, I wasn't talking about you there.
When you started off characterizing the different subtypes, I didn't quite capture if you had PTSD within the mood disorders and how much that would also potentially confound the tapping into the other types and affect outcome.
Yes, I mean, the genetic correlation one did show a relationship with PTSD. We're increasingly seeing a lot of PTSD in bipolar disorder. I do worry about PTSD and ADHD because they're in some ways quite easy to understand or perhaps easy to misunderstand. People are self-diagnosing a lot with them. But certainly PTSD is a comorbidity, yes. One of the problems with the trials, and you'll know this better than I, Jonas, because you worked in pharma for a prolonged period of time, is that people with comorbidities tend not to get into the studies, and therefore this very important group, which may even be the majority of patients, we've got a very meager evidence base.
I'm wondering if you can comment on the use of Cytomel T3 as augmentation.
Comment on what?
Cytomel T3.
Oh, T3, yes. So there's a T3, T4 debate. Certainly, Michael Bauer, we have a link up with Dresden from King's Transcampus, and Michael Bauer has done lots of the studies with T3. It was actually in my Maudsley pathway. You could see there was augmentation with thyroid hormones. It works for both bipolar and unipolar depression. The evidence base isn't huge, but it's there. It also seems to be helpful if you give supraphysiological doses of thyroid for rapid cycling. The problem we have in the UK is that T3 either isn't very readily available or costs an awful lot of money. Therefore, most of us are happy to use T4 because the two are converted. But some purists, I won't say Professor Tony Clear, but it is him, feel that T4 is not as good. However, the people that did the T3 research are quite happy to use T4 rather than spend €3,000 a month on T3. So it's a reasonable strategy.
Last question.
That was a great talk. Thank you very much. I've always learned a lot. I have lots of questions. I'm going to ask you them afterwards, but I have one in particular. In my field, in young people, we see a difference between anxiety and depression in terms of the efficacy of most treatments, psychological and pharmacological. It seems to me to be similar, at least in psychological treatments in adults, and in some of the pharmacological ones. So they're bigger for anxiety than for depression. So is this what comes under the placebo response? Would you agree, first of all? Why is that? Does that change your treatment strategy at all? Thank you.
Yeah, I'm sure we could have a long chat about this, Gareth, but I think in terms of anxiety disorders, the one that really is the twin of MDD's GAD, there's a 90% lifetime co-occurrence, but I do agree, things like CBT seem to work better for anxiety than they do for depression. I suspect that maybe just that the therapies actually does have fundamentally greater utility in the anxiety disorders. But of course, lots of the pharmacotherapy works for both. I would actually, for trials, and no one's ever listened to me with this, but for trials, I would certainly include anyone with a comorbid GAD if I was investigating MDD, because I think they're so closely allied. Okay, I think everyone's had enough.
Well, actually, I have a question about sleep.
Oh, yes.
So sleep is difficult. I mean, of course, you can start people on antidepressant, you can do the augmentation, but often you don't have a quick effect on sleep, which is something that is very disabling. At the starting of treatment, Alan, do you use any add-on which are specifically targeting sleep, including some, now the Royal College is going up for sleep hygiene, which with patients with psychosis I see doesn't seem to work very, very well. But do you believe in sleep medication? Do you use any specific pharmacological approach for sleep?
So, for patients who have sleep problems, I tend, and who haven't been through loads of different steps. So I do see people early in the treatment pathway, particularly doctors and so on and so forth. I do tend to start people on a regular antidepressant and trazodone. And trazodone actually works very quickly. It helps sleep, helps anxiety, and is very useful. There is the Sleepio app, which is quite hard work, and people do use it.
Engage with it.
And of course, you should tell people about sleep hygiene, but you've got to be careful you don't patronize people, because very often you know these things. There's also sleep deprivation as a therapeutic modality. This is actually quite popular in parts of Italy. Sleep deprivation does appear to be quite powerfully antidepressant. It goes in and out of research fashion. When I first went to NIMH in the 90s, there were 6 groups researching on sleep deprivation and antidepressant mechanism side by side in parallel, but no one is really looking at it now. David Veal has done something called, that we helped him with, called triple chronotherapy, which is sleep deprivation, bright light in the morning, and the sunglasses that block certain parts of the spectra. Now, this was an open feasibility study, but it had really powerful to interfere with your, that's common underlying. It's one and the other, we don't really know. That's something we need to be looking at more carefully.
And because you talked about this relationship, when I was an SHO, I worked for a psychiatrist. You might know Dr. Penrose, who was one of the all called sleep therapy.
Yes.
So he had access to a nurse, so he could put them on heavy benzo for 48 hours with the nurse checking on them, waking them up, giving them food and hydration. I've never seen anything like this. I haven't seen anything like that again.
I think most people would go the other way and look at sleep deprivation.
But No, you haven't spoken enough. I actually wonder, Argyris, I know you had more questions. You can ask one more question.
Blocks the ketamine response with placebo or with the naloxone. In terms of actually investigating response, people have done open studies of placebo. So you tell people they're going on placebo, and then you look at the response. And placebo responders with various pharmaceuticals get placebo or the blocker, and you look and see if there's a difference. And that will tell you, if there's a component of
Alan, you mentioned in passing. Alan, you mentioned in passing German and cholinergic abnormalities in depression. So my question to you is, does that matter in the sense that they implied that antidepressants shouldn't be prescribed because there's no evidence that there's an abnormality underlying them? And I think, does Oliver maybe also have evidence relevant?
Well, absolutely. We had personal friends who were on antidepressants who, after the headline, said, "Oh, I should stop this. There's no evidence they work." Now, first of all, it's a category error to confuse the evidence of efficacy with the evidence about the etiology or the biology. So first of all, that's totally wrong. Secondly, this had a big impact on patients who because they were hearing it from august scientific journals, thought, well, why am I taking this stuff? You know, there's no reason. So, I mean, I actually went to a lot of effort to convince patients and indeed friends that they should stay on people that are using them to their own ends. So basically, if you leave out D1A receptors, postsynaptically reduced, Paul Grasby and so on, were very worried that they hadn't changed the because these are recurrent, severely ill patients who still have underlying biological diathesis. Now, that was left out of the serotonin hypothesis review by those authors entirely. And to my mind, if you do a partial analysis of the evidence and present it as a complete story, that is nothing more than a perversion of the process.
Yeah, I think I would agree with you regarding meta-analysis. In relation to CBT studies in psychosis, there are something like 25 CBT RCTs in psychosis, and there's something like 53 reviews and meta-analyses. And the people against CBT leave out the ones where CBT is positive. The people in favor of CBT leave out the ones where CBT is negative. So it's very difficult to tell the truth sometimes from meta-analysis. Oliver, do you not have a study on serotonin in depression?
Is this working? Oh, it is. Yes. So when that review came out last year, actually they just beat us to publishing the first study with PET that tried to test whether release of serotonin was altered in people with major depression, and that was led by David Arizzo at Imperial, and that actually showed that people with MDD and also with Parkinson's depression showed blunted serotonin release to a releasing agent in cortical brain regions. So that's evident, as Alan said, in the post-synaptic of the system. So that's the first time it's been done with PET. We need to replicate it. But yes, already that review is completely out of date, apart from everything else.
Did anybody else have issues with the patients who had read the paper debunking the serotonin hypothesis?
I do. And my one also have psychosis, but it was very interesting because they saw also some headlines, and I know James will cover these, on psychedelics, and said, well, this is SSRI, I'd rather use psychedelics. Well, to me, the psychedelics, if they are effective, if anything, compound the serotonin hypothesis. If anything, they are very strong sort of activating of the serotonin system, as we will hear. So there you go. Alex, sorry, you had a question.
Alex is the one person who announced his name with questions, and it was my fault, really. I should have suggested to you at the beginning that when you ask a question or make a statement
Although he said, and I come from St. George's, where? St. George's in
I thought everyone knows in Tooting. It's in South London. Yeah, the other thing about, I guess, serotonin or SSRIs was the anxiety around the increases risk of suicide. I've had several patients that are really anxious about that and won't take them.
Yes, I mean, this was a big furore a few years ago. The FDA produced an analysis showing that there was no increase in suicidality age 26 and older, but a possible uptick in suicidal thoughts, but not completed suicide in 18 to 26. That's been followed up by an analysis by Professor Elias Eriksson from Gothenburg, who got the entire 6,000 patient database from all the SSRI phase 3 regulatory studies, and he's published a series of papers on it. If you look across the 6,000 individuals compared to placebo, there is no increase in suicide as measured by the suicide item on the Hamilton. So you got to remember that people with depression have suicidal ideation. You know, it's very common, and people will kill themselves in trials. So I think at the moment we've got to be careful about it. If you go back to the beginning of the antidepressant era, it was always said that there was a vulnerable period early on in treatment when people were more activated, but their mood hadn't fully improved, and they were at greater risk of suicide then. There's also an issue about suicide and the psychedelics, and this is one of the things which needs to be determined in larger studies, but James will talk about that, I'm sure. But generally, I think we can be reasonably reassuring to our patients about that. But, you know, if you actually go back to what happens in the clinic, both in primary and secondary care, the guidelines all say that when you start people on antidepressants, you should see them between 2 and 4 weeks and then see them serially to monitor adverse effects and so on. Potentially that can be done by digital means, very, very practically. If you actually look at what's happening for very understandable reasons relating to the mental health services being in crisis, that just doesn't happen, by and large.
Could I just ask a question of that? One of the things that always perplexes me in the UK is that most people with depression don't see a psychiatrist. They are treated by general practitioners who have a varying knowledge or interest in depression, and we don't really know how well they are treated. Is that the same in most other countries, that most people with depression are not treated by a psychiatrist? Anybody from a country where most people see a psychiatrist?
Eric, what happens in Hong Kong?
I think, sorry.
Treated by GPs. Yeah. I suppose that is the question. Is that a good thing or a bad thing? So it's...
Yeah. So hi, Eric Chen from Hong Kong. So people with depression actually mostly are not treated at all. So we had a recent epidemiological study of young people. So going back to Alan, so we look at MDE. So not just the persistent depression. MDE is about 13% in young people. And I think if you take the same sort of proportion who would end up in a persistent depression, maybe about 1/5 of them. Now, of all the young people with MDE, only about over 10% are treated by a psychiatrist or a clinical psychologist. The rest are not treated, not detected, most of them. So, so there's a huge access and recognition problem. The primary care in Hong Kong is not like the UK, so people don't usually access primary care for mental health problems. So mainly they will be treated by psychiatrists. That's right, yeah.
So if you look at the European study that we did, access to psychiatrists is quite limited across Europe. I think we do have a model of the way the care should be. And this is not unique to psychiatry. It occurs, for example, with diabetes, which is a collaborative care model, which is that you need to detect the abnormality. Primary care doctors treat it, but then if that's not working out, it's escalated to secondary care and then to tertiary care. I have a very good friend who's a diabetes consultant, and the similarities between diabetes and mood disorders are always striking to me. Collaborative care doesn't really work in the UK. It works in large HMOs in the US, which are one organization. But the escalation from primary to secondary care is actually very sadly lacking in the UK. And I don't think we can really necessarily blame the GPs. We can't really blame the psychiatrists either, because the psychiatrists have to prioritize the very limited resources to dealing with the most extreme cases. But that means that depression very often falls in the middle and gets neglected, I'm afraid.
I have two questions, sorry. I'm Naresh Button from South London Maudsley Trust in London. You spoke about stress, cortisol, and depression. Has there been any research done to control the cortisol and treat the depression? And the second question was about seasonal affective disorder. Seasonal affective disorder.
Seasonal affective. Well, let's start with the cortisol first. I've spent probably about 30 years looking at this. There's really two patterns to our minds of the cortisol abnormalities. There's a group which are more Cushingoid with high levels of cortisol, even though this is quite subtle. And the reason they don't appear Cushingoid is because they've got blunted glucocorticoid receptor function. So that's the classical high cortisol group. And they have been treated with drugs that block or reduce cortisol. And there's some work in psychotic depression about that, because that's the subgroup with the highest cortisol. The other group is the Addisonian group with low cortisol. And Tony Clare has looked at this in chronic fatigue and so on. And the group with atypical depression appear to be on that side of things. So again, depression isn't simple. There appears to be different aspects to it. It's also an area which unfortunately has become deeply unfashionable. And if you want to spend 6 months writing a grant and not get it funded, unfortunately do it in this area. But I think it's still very important. The other thing is about seasonal affective disorder. Well, there's a seasonal pattern which is more evident the further you get from the equator in terms of all of our biological rhythms. So you go into hibernation pattern in Scotland in the winter, for example. You eat and sleep more, and so on and so forth. This is very often superimposed upon depression. So you get almost a seasonal exacerbation of depression. Now, there's very good evidence that bright light works. So people have done placebo-controlled studies with the same boxes, but with different frequencies. Bright light appears to work for seasonal affective disorder, but it also works for seasonal exacerbations or even non-seasonal depression. I, however, have abandoned this in the clinic because I bought a series of light boxes years ago and I never got them back because the patients liked them so much. So I now give the patients the website and they go off and buy it themselves. It's not a miracle cure, but it's helpful for some people.
Last question?
Just a comment to, I think, Robin, you asked who is treating depression. I think in Sweden, I'm from Sweden, Jonas Eberhard, and we have a study done in the late 80s, early 90s of the deceased Wolfgang Rutz, who passed away recently, only a month ago. And Wolfgang, he did the educational program for the GPs on the island of Gotland. And one could then see a significant decrease in suicides there. And there was a lot of interest in this study. And I think educating the GPs about depression was one successful way of dealing with the problem, but it needed a boost, so it sort of wore off after a while. So.
Thank you, Jonas. No, there is another one as well that I promised. Last but.
Thank you. I'm Rose Anderson. I'm a child and adolescent psychiatrist from Sydney in Australia. And I just wanted to ask another question about treatment, because young girls would rather do anything rather than put on weight, and quetiapine puts on weight. And is there any efficacy for using aripiprazole or brexpiprazole as augmentation and antidepressant, because that also doesn't give you the sedation that sometimes you want with someone who's agitated?
Yes. So all the atypicals augment antidepressants. They all use more or less the same mechanism, which is blockade of the presynaptic autoreceptor for dopamine, which increases release. So in some ways a similar mechanism to using a stimulant or modafinil. We choose it on the basis of side effects. So if people are anxious and not sleeping, we give quetiapine. If they are worried about weight and so on, we give aripiprazole.
Last question. Thank you.
Anna Clara from Sweden, Stockholm. Could you just say something about the correlation between ADHD and recurrent depressive disorder, but maybe also bipolar disorder, and the challenges in diagnostic and treatment?
Well, I've actually just been, not in Sweden, but in Denmark with colleagues lecturing about this. There's a strong comorbidity between ADHD and mood disorders. I come obviously from the side of the mood disorders, but it's clear that there's probably a significant proportion of our patients who've got complex or difficult to treat depression or bipolar, where there's an underlying ADHD. There's a screening tool for it, which, like many screening tools, captures too many patients, but there is a diagnostic interview, the DIVA, which we use. We're actually doing a trial of stimulants in people with bipolar or schizophrenia with ADHD. So I think it's there, it's important. I think you probably are justified in using stimulants if you're clear in the diagnosis. Personally, I'm very worried about the concept of adult onset ADHD. That doesn't really make sense to me at all, but we're beginning to recognize, a bit like we're beginning to recognize a lot more that there's a lot of autism and anorexia. We're recognizing there's a lot of ADHD in complex mood disorders. Now, we're seeing an overdiagnosis of ADHD, perhaps. I mean, you could go online in the UK and get diagnosed and treated for ADHD if you filled in a questionnaire. That's a different scenario from someone who presents with a clear-cut, complex and difficult to treat psychiatric disorder. In that case, if it's a mood disorder, you should be looking and considering ADHD in your differential list of comorbidities.
And what about the treatment, like the steps? Would you consider antidepressant, like begin with it or parallel with
Well, interestingly, when we were lecturing in Denmark, that was a key question from the audience, and the consensus seemed to be that you treat the area of greatest clinical need first. So you certainly do treat the mood disorder with your standard treatments, but you can also treat the ADHD, and it's up to the clinician's discretion about the order in which you do it, or you may even do it contemporaneously. Well, the one that's likely to do that is bupropion. Yeah, but I mean, I wouldn't think you could necessarily, I mean, bupropion pharmacologically is very similar to atomoxetine or vice versa. But we have problems with getting bupropion. But many people with depression and comorbid ADHD really don't do well on SSRIs. So you may need to think out with the usual box of antidepressants.
Thank you very much, Alan. This has been a marathon. So I would like to thank you by clapping rather than I can't do with the microphone. So thank you very much. And thank you for all the questions and interaction. So now the good news is time for coffee breaks. Technology can't go wrong with coffee break, especially when it comes to Sicily. So it also gives you a chance to stretch your legs, Julia, Eduardo, and other colleagues will be at the door and will guide you, because you're coming downstairs and going literally round the block to this lovely courtyard. I would be very grateful if you can come back on time. So if you can get your coffee, tea, cakes, you see some cakes, and begin then to gently come back. I will come and summon you anyway to make sure we're all here at 11 o'clock. Thank you very much.
And for the people online, we're going to break for half an hour, and so you can also go and have your coffee and back in 30 minutes.
Thank you, Alana. Sorry about this little slide. Well, no, it's the stupid medical school projector that's went bananas. No, the computer was fine, so that our guy switched everything off. You look at your pen drive.
Yeah.
I think it's I'd be anxious to remove. Can I ask the guy to? I'm going to get. Look, you go down with Alan to get refreshment. The problem with the projector. No, but they had to go and reset the projector. Hello, everybody. I know that some of you, or maybe one of you who spoke to Robin, had problem to link with the internet password and username that were displayed just before we broke for coffee break. Is there anybody who's still having problem? If you do, don't ask me because I'm useless, but you can go at the back to our colleagues who are running the audiovisual and you can show them why you're struggling to connect and they will sort you out. But this phantom person, Robin, you sure haven't dreamt of him? Or you can pick on her or him. Anyway, most of you are back, and thank you very much for being on time. I'm sorry for the lack of tea, but in this part of the world, tea is not considered a drink worth of any notice. But I've asked to bring more cups, and I brought M&S Earl Grey from London. You can have from tomorrow and share it with me, because I'm a mutant Sicilian. I only drink tea, I don't drink coffee. So I'm with you. Apologies for that. Anyway, without wasting any more time, it is my great pleasure to introduce Dr. James Rucker to you all. James is a senior lecturer at the Institute of Psychiatry. He works with Professor Alan Young at the Affective Disorder Unit, but also has been pioneering different projects. He will be talking about psychedelics, but also James and I have been collaborating about some of the work he does on prescribing medicinal cannabis in one of the main cannabis clinics in London. And so you might want to ask him questions about his experience in that respect. So without wasting more time, James.
Working? Yeah, and I think you can use this one. Okay. Can you hear me? Okay. Yes.
Use this one, James, because maybe that needs to be switched on.
Okay. Can you hear me? Yes, definitely you can. Thank you so much, Marta, for the kind introduction and for the invitation to speak here in this wonderful venue. It feels slightly appropriate to be talking about psychedelics given their rich history. This was an area that I was catapulted into really about 7 or 8 years ago. I ended up prescribing psilocybin for the first person in a clinical trial for treatment-resistant depression when I was working at Imperial back in 2015. And I became involved in a field that it is almost the epitome of biopsycho and social. Psychedelics seem to sit at this sort of nexus between all of these different things. They have pronounced biological effects on the mind, which I will talk about later, but they are intensely psychological, experiential things, experiences, and narrative is incredibly important in understanding them, something that clinical trials obviously try and pick apart. And yet they come with huge cultural heritage, and over the past 50 years have been heavily criminally sanctioned and stigmatized. And all of that comes into the mix when we are trying to work out this question of whether or not they have a place in psychiatry. I'm very equipoised about that question. I'm going to tell you a little bit about the work that we've been doing at King's over the past 6 years, a phase 1 and a phase 2 trial in treatment-resistant depression, and also just try and contextualize all of that within some of the history. And talk about a little bit about what psilocybin therapy in particular is, but what it is not. Alan has alluded to some of this at the moment. We should not think of these drugs as panaceas. I do not even know if they have a place in our treatment armamentarium yet. They need to be thought of as not just drugs. They are drugs that make people sensitive to context, and therefore the control of context is very important. Just some disclosures, no shareholdings in companies developing psychedelics or any of that business. I want to start with a few quotes, if that's okay. One from our forefather, Sigmund Freud, and it was clear to me that the idea of drug-assisted therapy was on his mind. He made this quote in 1938: "The future may teach us how to exercise a direct influence by means of particular chemical substances on the amounts of energy and their distribution in the mental apparatus. It may be that there are other still undreamt of possibilities of therapy." At the same time he said that, Albert Hofmann discovered LSD. He discovered it by accident, and its pharmaceutical properties or its psychoactive properties didn't become apparent to him until 5 years later. But at around the same time, a man called Eric Gutman, a psychiatrist at the Maudsley, was experimenting with the psychedelic mescaline on some of his patients. I don't have a slide to illustrate this, but he published what was essentially the earliest case series, a study of mescaline given to people at the Maudsley. And he concluded at the end of his observations that this drug was useful to act as a catalyst in the process of psychotherapy. And that's exactly really how we are considering it now. And the question in my mind is that possible to implement? Is it testable? And is it possible to implement that within mental health care infrastructure as it exists at the moment? Fast forward to 1988. This is a psychiatrist called Stanislav Grof. He's a Czech psychiatrist. He probably has given the most number of LSD-assisted psychotherapy sessions in the world. Czechoslovakia didn't ban LSD until much later on, so he was able to work with it for longer than US psychiatrists. But he made this crucial observation about how psychedelics work in his mind. All that they do in and of themselves is activate the psyche and mediate emergence of unconscious and superconscious contents into consciousness. Whether this process will be therapeutic or destructive and disorganizing is then determined by an entire spectrum of other influences that have nothing to do with the pharmacological effects of these compounds. Since the factors of set and setting are of such paramount importance, no magic results should be expected from a simple administration of psychedelics. They should always be used in the framework of a complex psychotherapeutic program. Now, I absolutely agree with that, whilst also pointing out that they are biological drugs and they have biological effects. And I'm going to show you some of the correlates that seem to exist with existing antidepressants later. But the critical distinction and why this is not just another drug is that these drugs make you sensitive to context, they activate the psyche, and this needs to be managed within the context of any sort of therapy using them. This was a British psychiatrist called Ronald Sanderson. He persuaded the UK government to fund a hospital building dedicated to LSD psychotherapy in the 50s in Powick in Warwick. And this was his comment about LSD. About 10 years before his death in 2010, he said, "It doesn't behave like any other drug in the pharmacopoeia. Its effect varies not only from one person to another, but in the same person on different occasions. It's not a drug in the specific sense of other remedies. I saw it as a tool for the promotion of psychotherapy, and I still maintain the same opinion." Today, when LSD is regarded by its protagonists as a recreational drug, it's difficult to understand the esoteric nature of this remarkable substance. Those of us who use it in clinical practice developed a reverence for its properties, rather as the shamans of old regarded their magical plant. I'm not sure whether we should think of drugs as having reverent properties, and evangelism over the years, and to us, a political debate that was happening in the UK about whether or not we should reschedule psilocybin. And there's a lot of hype, even within the House of Commons and amongst people who are debating this in high places. We really need to stick to the evidence and not trip up. There are 3 different types of classical psychedelics. Amphetamines. Mescaline is an archetypal example. Used naturally in this cactus, the peyote cactus, but also in San Pedro. History for the use of mescaline stretches back thousands of years that have attracted the most interest in modern times. We're most interested in psilocybin, which being pushed through the standard clinical trials pipeline at the moment. And you can see how structurally similar this is to serotonin here, along with dimethyltryptamine here. And these are broad serotonergic partial agonists. So they stimulate a wide variety of serotonergic receptors, all of them, in fact, except for the subtype 3. But the subjective effect, as I will go through, is mediated by the type 2A serotonin receptor. Again, both produce naturally, both have long histories of use by various geographically distinct cultures from antiquity. In fact, the only compound here that is not natural is the tryptamine. You can see the tryptamine here. The reason why I've got an ear of wheat here is for this slug-like structure hanging off it, and that is a fungus. It's a fungus called Claviceps purpurea, and it naturally produces ergot alkaloids, two of which are useful in medicine, ergometrin, which stops postpartum bleeding, and ergotamine, used as a treatment in migraine. And it was for this reason that Albert Hofmann, the chemist who discovered LSD in 1938, was investigating derivatives of chemicals produced by this fungus, one of which is lysergic acid. And lysergic acid diethylamide was the 25th derivative of lysergic acid that he synthesized. Because he was looking for drugs with effects on blood pressure, he shelved LSD, didn't seem to have any interesting properties, but then he resynthesized it on a hunch 5 years later, in 1943, contaminated himself with a small amount, it's incredibly potent, and had the world's first acid trip. He then intentionally took 250 micrograms, millionths of a gram, to see what the effect would be, and had the world's first bad acid trip. Because 250 micrograms is a high dose of LSD. It's a remarkably potent substance. But he was working for the pharmaceutical company Sandoz at the time, that's now a part of Novartis. And he recognized very quickly that this drug would be of considerable interest to psychiatry. And I suppose you have to remember that at that time, psychiatry had very little indeed. We had ECT, insulin chemotherapy, certainly no chlorpromazine antidepressants. But I think you've also got to remember that at the time, the formulations of psychiatry, and particularly of schizophrenia, were psychoanalytic. And yet here was a drug that mimicked some of the effects of acute psychosis. So it's ironic that this drug is so heavily criminalized and stigmatized, because LSD, in a sense, ushered in the era of modern psychopharmacology. It showed that here was a chemical cause for psychotic symptoms, which were the great mystery of psychiatry back around that time. So it quickly became of great interest, as I say, because there was very little else out there, and there were asylums overflowing with people with mental illness, which we didn't know what to do with. But it also became of considerable interest because the pharmaceutical company Sandoz gave it away for nothing. So as a psychiatrist, you could write to them and say you wanted to try this out on your patients, and they'd send you a box. And this was the basis of modern research, well, not modern research, but research from the 50s and 60s using LSD. It was initially tested on people with schizophrenia. It didn't work, it made them worse. But it was then tested on people in depression, anxiety, obsessional neuroses, and alcoholism. And here, in the context of ongoing psychotherapy, it seems to act as a form of catalyst by disturbing the mind, by amplifying the psyche. It seems to allow the emergence of material that could then be used in ongoing psychotherapy. And that is the basis of what we are doing with psilocybin now. So this is a timeline of psychedelic therapy. I won't spend too much time on this because I've kind of mentioned it already. the Western history of psychedelics actually goes back to before the 1900s, when the first description of mescaline was described in the BMJ. As I've talked about, LSD was synthesized in 1938 and then marketed as Delicid by Sandoz in 1947. And the first publication with LSD was in 1952 by Charles Savage. Ronald Sanderson established the first LSD therapy clinic in the UK in Powick in 1953. It's lesser known that Hoffman also isolated psilocybin, the active component of magic mushrooms, also working at Sandoz in 1958. By that time, LSD was quite prominent. So psilocybin didn't get much of a look in. It was marketed under the brand name Indocybin, but I can't find really any research using it. And around this time, psychedelics diffused out of the clinic onto the street and became caught up in what was essentially a moral panic about drug use that also became embroiled around the Vietnam War, the battles against communism in the United States, etc. And it was because of these political concerns, but also because of concerns about the toxic psychological effects that psychedelics can have when taken in the wrong context, that Sandoz ceased supply and production of LSD in 1966, and then psychedelics were added to Schedule 1 of the Controlled Substances Act and the UN Convention on Drugs in 1971. And that schedule meant that all research stopped because it prevented medical prescription without a special government license, which governments weren't willing to give around that time. We then had 40 year pause in research, and then this very tentative re-exploration of psilocybin this time, with the first trial in treatment-resistant depression appearing in 2016 out of Imperial College, London. And then a trial I'll tell you about in a little bit that we published late last year, a multi-center phase 2B trial. This was the sort of prevailing media view of psychedelics around the 60s and 70s. And you could be forgiven for thinking that these drugs were highly dangerous. And of course, they can be. They're physiologically rather benign, but psychologically they can be very toxic in the wrong circumstances. But nonetheless, it just gives you a flavor of the message that was being promulgated in society at the time. I've already mentioned this, how the drugs were caught up in this sort of political fury about what to do about recreational drug use, and how this became embroiled in conversations around communism and the battle against it. But actually, when this is a picture of people under the influence of psilocybin in our research facility, this is the reality of people being given 25 milligrams of psilocybin. They lie back restfully and trip, but they are not violent or difficult, generally speaking. It's very much an internal process. I don't, generally speaking, worry about signing prescriptions for psilocybin when it is contained within this sort of environment. So I just wanted to illustrate that in terms of what we're dealing with here. And I want to make a very clear distinction between psychedelics used recreationally and psychedelics used medically. It is a completely different thing, and we should be careful not to conflate the two things. So this is what we're talking about, and this is what we're testing at the moment, the psilocybin-assisted therapy paradigm. So you have an ongoing process of psychotherapy, and really keep that front and center in your mind. This is not just, the emphasis shouldn't be on the drug, the emphasis should be on the underlying psychotherapeutic process within which the drug is embedded. And this is an intermittent drug treatment. Previously, prior to prohibition, LSD psychotherapy might have been used once every 3 months, 6 months, even a year. you would certainly never give these drugs less frequently than once every 2 weeks. Why? Because you develop tolerance to the effects, so there wouldn't be much point in doing it. But as I say, this is a drug process embedded in an ongoing process of psychotherapy. You never give people psilocybin to take home. The drug is always contained within the clinic, and that, again, a reason to disambiguate between recreational use and medical use. So it's very similar to what we were thinking about prior to 1971, but embedded in a modern context. And some people are worried that these drugs are going to spin off out of control, just as they did prior to 1971. And that's possible, I acknowledge that. What I would say is that the law and the regulatory frameworks around the development of treatment and the delivery of treatment have changed. The irony about the Controlled Substances Act, the Misuse of Drugs Act, is that they do allow a legal framework within which we can do this research in a way that governments and the wider public can understand. And that wasn't possible really before. So that's what we do. Right, so I'm now going to test the technology to its limit by attempting to play a video. And it has some nice music, so I'm going to shut up. The reason why I play this video is to give those of you who have never taken a psychedelic a little bit of an insight into what taking a psychedelic might be like. But what I'd like you to do, obviously this is visual, but what I'd like you to do is imagine this process applied to all forms of perceptual experience and thought experience, about how it might apply to sound, smell, thought process, etc. That gives you a sense of how psychedelics change things. This is from a phase 1 trial, the picture of which you saw a few slides back. And round the circle here, you can see how people rate different facets of experience under the influence of psilocybin. This is on a visual analog scale called the 11 Dimensions Altered State of Consciousness Questionnaire. And you can see those 11 dimensions plotted around the circle there. I think the most concise description of a psychedelic I ever heard from one of the participants in our trial, it was like a waking dream. So it was like I was dreaming, but I was aware I was dreaming and I could remember it afterwards. So I'll play the video now. I always love playing that because it gives me a bit of chance to breathe and to it's sort of, it's not words, you know, so many words and presentations, and here's something slightly different. I hope that gave you a bit of a feeling for what the psychedelic experience is like. I'm going to turn to some more hardcore science now and talk a little bit about the biological effects that these drugs are having on the brain. As I said already, they bind to a subtype of serotonin receptor called 5-HT2A. They also bind to all the other serotonergic receptors except 5-HT3. But it is the 5-HT2A receptor that is responsible for this subjective experience that people experience on psychedelics. Whether or not that's responsible for any therapeutic effect is another question that we can't answer yet. The reason why this is interesting is because it illustrates a pharmacological concept called functional selectivity. So not all drugs that bind to the 5-HT2A receptor elicit psychedelic effects. Why is that? It is because of the precise way in which psychedelics bind to the 5-HT2A receptor and the precise conformational change that elicits in the receptor. The 5-HT2A receptor is attached to two downstream second messenger systems. This is as complex as it gets, I promise. Attached to two downstream second messenger systems, and relative to serotonin, when serotonin is bound to this receptor, when psilocybin and other psychedelics are bound to this receptor, it biases the balance of activation between these two second messenger systems. And that has a variety of molecular cascade effects downstream, and it alters the permeability of the neuron to certain ions. And that changes the phase and timing of firing of the neuron within a canonical microcircuit. And we don't know beyond that really what is happening within the brain. We know that psychedelics are analogous in some way to ketamine in their mechanism of action. Alan spoken about another drug with fast-acting antidepressant properties. And we know that both these drugs appear to lead to a surge in glutamate release in the prefrontal cortex and an increase in BDNF production in layer 5 pyramidal neurons. And these may be associated with effects such as this, increase in dendritic arbor complexity, the sprouting out of neurons to form new connections. So some evidence to suggest that psychedelics have similar biological properties to existing antidepressants, ECT, lithium, etc. They seem to be doing different things, but unlike classical antidepressants, they seem to be doing it rather quicker. And that may be because they are the mechanism of action is closer to the sort of final common pathway of resolution of depression, perhaps. Sorry, I'm skipping about a bit. How do we know that it's the 2A receptor? Well, there's a couple of studies here which really confirm it. The first on the right is a randomized controlled trial in which people were randomized to receive a psychedelic, a placebo, and a psychedelic plus catanzarine, which is a drug that blocks the 5-HT2A receptor. And the critical point here is that people who receive placebo cannot tell between, there's no difference between people who receive the psychedelic and the 2A blocker. So that suggests very strongly that the 2A blocker is responsible for the subjective effect that people are experiencing under psychedelics. On the left is a PET study that was released from Copenhagen a few years ago, and that tied the subjective experience to plasma psilocin concentrations. Psilocin is the active metabolite of psilocybin, and tied that to the occupancy of the drug within the 5-HT2A receptor. So you had this nice conceptual link between people's subjective experience, the amount of psilocin in their blood, and how much occupancy there was of that at the 5-HT2A receptors. So really good evidence that it's the 2A receptor that's causing the subjective effect. As I say, whether that's responsible for the antidepressant effect is not known. Where is this receptor? Well, it's in bits of the cortex that we're already interested in when it comes to depression, the anterior and posterior cingulate, for example. But also you can see it, hot colours in the visual cortex, and this presumably explains why people tend to misperceive and hallucinate when they take psychedelics. This is an interesting study out of Imperial, a chap called Chris Timmerman, who gave people a psychedelic whilst they were having an EEG. And what you can see here is the plasma concentration of DMT, dimethyltryptamine versus placebo down here. And these are the frequency of different brain waves as measured by the EEG. And you can see how this frequency is obliterated according to the concentration of DMT. And this is in the alpha frequency. So just an indication of the sort of macro effects that this functionally selective action of the 5-HT2A receptor is having on the brain. And this is not dissimilar to people when they are in deep states of meditation or dreaming. And when we look at brain connectivity under psychedelics, so that is the extent to which different bits of the brain are talking to each other, we see this difference here. And what you're seeing here is different brain regions plotted around the circle. The lines in between represent the degree of crosstalk between those two regions. So under A, placebo, under B, psilocybin. The message here is not that the amount of activity is increased, but that it's deconstrained, a little bit like a dream. So increased crosstalk between brain regions. And this may be related to just an increased element of disorder within the brain. And the theory is whether or not this leads to a therapeutic window of opportunity during which, in the right context, a sort of reappraisal of mental health problems can be introduced. Okay, so I'm going to talk now about a couple of clinical trials that we've done over the past 5 years. This is where we are in the development process of psilocybin, right at the end of phase 2 now. We're probably starting phase 3 by the end of this year. Just to illustrate, MDMA or ecstasy is further along the way. That's now in phase 3 trials as a treatment for post-traumatic stress disorder, again embedded in the process of psychotherapy. But this is a process that takes many years and costs, the median cost is about $1.1 billion these days. And many drugs fail, and it could be that psilocybin fails, it could be that MDMA fails, we will see. I'll talk a little bit about the safety signals from the phase 2B trial in a while. So this is the first trial that we did. It's a phase 1 randomized controlled trial of psilocybin on healthy participants. And really the only point of this trial was as a basic safety test and to look at the cognitive and emotional functioning objectively on healthy participants. So these were the inclusion criteria. It was an 89 participant trial. They were randomized 1:1:1 to receive 25 milligrams of psilocybin, 10 milligrams of psilocybin, or a placebo, a single dose of. They couldn't have had any prior psilocybin use in the past year, obviously no current substance misuse, basically healthy. They received a single dose of psilocybin on day 0. Prior to that, they had baseline measures of cognitive and emotional functioning. And then they were followed up day 1, day 7, day 28, and then the end of the study, day 84. I already showed you that, but that's a couple of the participants. This was how they were randomized. So 30 and 30 into the 2 psilocybin groups, 29 into the placebo group. We lost 4 of the placebo group to follow up, and I suspect that's probably because they were disappointed. This was the schedule of assessments that we did. I'll go through these in a bit more detail in a minute. We essentially used the CAN-TAB, which is an established cognitive and emotional functioning battery. What we also did in this trial, which actually was unique, was that we gave psilocybin to more than one person at a time. No one's done this before, and we were slightly tentative about doing it. But we actually gave psilocybin to up to 6 people at a time. You saw 2 of them in the photo there, but actually 2 of them were behind them as well. But we had a maximum of 6, and that worked out fine. We didn't have any particular problems. Let's say about 50% of participants had sessions with 4 participants. So it was a good general test of dosing people simultaneously with psychedelics, which may be important if the drug ever gets to the clinic. These were the adverse events in the 25 milligram arm, ordered by incidence. So hallucinations, as you imagine, illusions, altered mood, headache, common with psychedelics, and various other things, as you can see, stretching down there. The key thing to understand is that the vast majority of these adverse events were expected psychedelic effects. Because it was a phase 1 trial, we reported everything. Even if people had a great time, we would report it as an adverse event. Subsequently, the MHRA have told us that we do not need to report these expected psychedelic effects. But nonetheless, that was part of the point of this trial, was to start to develop a sort of rational list of expected psychedelic effects. The vast majority occurred on the day, resolved on the day. Very few hung over onto subsequent days. And this just illustrates that here. So if you had an adverse event on day 0, how long did it last? For the vast majority of people, it had finished by day 0. For a small proportion of people, the events carried on. These events that did carry on were not psychiatrically concerning issues. We categorized all the adverse events that concerned altered mood. 11.2% of all AEs were coded as mood altered, but 96.5% of those were reflected what could be perceived as a positive mood change, and 3.5% reflected what could be perceived as a negative mood change. I'd only say that obviously that's biased by our own subjectivity, so take that into account, but nonetheless, not a concerning picture. So no serious adverse events in this study, and there were no adverse events that led to a participant withdrawing from the trial, which was the main message when it comes to safety. 92% of psychedelic effects resolved by the next day. The remaining were most usually positive. There was 1 instance of negative mood on psilocybin, 10 milligrams. So a fairly good clinical safety profile when the drug is delivered in a safe and supportive context. People had psychotherapists sitting with them whilst they were given psilocybin. Right, so I'm just going to quickly go through the cognitive tests that we did with the CAN-TAB. We focused on tests of global cognition, episodic memory, working memory, executive function, sustained attention, emotional perception, planning, and cognitive flexibility. Sorry, it's an old slide. This has all been published now and peer-reviewed. This is the paired associates learning task. So I've just got videos here so you can see exactly what happens. The boxes on the screen are opened in a randomized order. They contain a pattern, and participants have got to remember where they are. So that's just a test of episodic memory. Spatial working memory, quite easy really. You just pick out the yellow boxes and put them in the tower like that. A test of working memory and executive function. Rapid visual processing, so you have to identify the sequence of digits and press the button when you see it. So that is a test of sustained attention. Emotional recognition, so you get a sort of flash of someone's face and you have to identify the emotion, and you're essentially timed on how quickly you take to correctly identify the emotion in the face.
Well done.
And then the one-touch stocking Cambridge test is essentially you have to mimic the pattern at the top by flipping the balls around one ball at a time, and that's a test of planning. Within the patterns. So you have to identify common between the different sets of that you're being shown. So over time, you'll work out that it's this funny little building symbol that's the common theme. And these are the results. So on the left, you have baseline, then you have the scores at day 8 and scores at day 29. In the green, you have the 25 milligram group, in the blue, the 10 milligram group, and in the grey, the placebo. You can see there's no significant changes in episodic memory, no significant changes in spatial working memory, no significant changes in executive function and working memory, and no significant changes in sustained attention. And this is a composite of 3 of the tasks, which is used as a sort of general cognitive ability. Again, no difference between the groups. This is possibly the only result of much interest, although it's not significant. You do see this sort of dose-dependent effect on the emotional recognition path, so people seem to be able to identify emotions a little bit quicker. Once
well done.
After given psilocybin, sorry about that. No difference again with the one-touch stockings of Cambridge, the planning test. So basically no difference, either positive or negative, from a single dose of psilocybin on cognitive effects and emotional effects at day 8 and day 28. Surprising? Not really. Were we expecting big pro-cognitive effects of a single dose of psilocybin? No. I was actually very reassured by it that this trial was negative. I would have been suspicious if it had been positive. It's possible that psilocybin may have pro-cognitive effects and we were underpowered to detect an effect, but I think it's more likely that single doses of a drug we should not expect magic effects from. So this was a test. This was can we give this drug safely at King's, and what were the key safety features? And we concluded that it had an acceptable safety profile. And this acted as the foundation for us to move on to the treatment-resistant depression trial, which is what I'm going to show you about now. And this was published in the New England Journal of Medicine in November last year. It was a multi-center international phase 2B trial, a single dose of psilocybin given with psychological support to people with treatment-resistant depression who'd failed at least 2 antidepressant treatments, but not more than 4 antidepressant treatments. And it was about 240 people, if memory serves, enrolled in this trial that were dosed. You can see the design here, quite similar in nature to the trial that I described before, except this is in patients. Everyone in this trial receives psychological support. They receive a single dose of either 1 milligram of COMP360, which is just the commercial company's name for psilocybin, So 1 milligram, 10 milligrams, or 25 milligrams. That design was implemented in order to try and mitigate some of the effects of expectancy and unmasking. So as researchers, we could say everyone received psilocybin in this trial, we just don't know which dose you're going to get. 1 milligram is a sub-perceptual dose, but both 10 milligrams and 25 milligrams are perceptual doses. So people will notice those. And the idea was to confuse between those two doses. And the basic question was, which of these two doses should we take into a phase 3 trial if we see a separation in responses from the control group in terms of depression scores. And the primary outcome was the Montgomery-Åsberg Depression Rating Scale, collected by geographically independent raters. So raters who had nothing to do with the research team, again, to try and mitigate some of the effects of unblinding. So this is how people were randomized. One of the important things to notice about this trial is that the vast majority of people did not have prior psilocybin experience, and that's been a problem in the earlier phase trials. It's that people who tended to think that psilocybin worked for them volunteered for the trials, which clearly is going to bias the results. In this case, the proportion of people who did not have prior psilocybin experience is matched to the population prevalence. And these were the results. You have day 2, week 1, week 3, week 6, week 9, and week 12. You're looking at the change in the Montgomery-Åsberg Depression Rating to Scale total score from baseline. And you have the 1 milligram group in grey, as before, 10 milligrams in green, and 25 milligrams group in blue. And we saw a statistically significant and clinically significant separation between 25 milligram group and the 1 milligram group, started at day 2 and remained significant until week 6. Just to remind you that everyone in this trial received psychological support, so that is a constant between everyone in the trial. So on the face of it, and I'll go through a little bit about why I say on the face of it, this looks like a nice result, a nice sort of dose-dependent effect of psilocybin. But obviously, there are other ways of interpreting that, and I'll talk about that in a little bit. This is another way of looking at it. So I don't know why this always happens. This is looking at people who respond on the MADRS, that is to say, a 50% reduction in their MADRS scores compared to baseline, and you can see the proportion of people who exhibited a clinical response in the 3 different groups, significantly more in the 25 milligram group than the 10 or 1 milligram group. Still a good going placebo response and response to the psychological therapy, which I think is reassuring. And this is looking at remission, so people who lost their depression diagnosis, essentially. Of course, percentages are somewhat lower here. But still, at week 12, you have 26.6% of people are in remission after 25 milligrams of psilocybin. And these are people who sustained a response. So that means meeting the MADRS response criteria at week 3 and at week 12, and at least one of the week 6 and week 9 visits. So they got better and stayed better. And nearly a quarter of people got better and stayed better with 25 milligrams of psilocybin. Remember, this is a treatment-resistant group. Thinking about the adverse events, mostly mild and moderate. The proportion of people reporting a serious adverse event was comparable between the 25 milligram and the 10 milligram groups, but it was more than in the 1 milligram group. So we did see the emergence of suicidal ideation and suicidal behavior in some people that received 25 milligrams and 10 milligrams of psilocybin. In a sense, it had a sort of similar feel to that which we observe with SSRIs. We had one such instance in our centre. My observation of it is that it's complicated, and it seems to be related in part to the unmasking and unblinding. So if you are aware that you've received psilocybin and then it doesn't work, it compounds depression with disappointment, and this can then lead to desperate and difficult behavior. Could also be a biological effect of the drug. I think that's unlikely because the temporal causation was not linked to the initial dose of the drug. So we weren't seeing suicidality on day one. It was further down the line. So more a sense of a psychological process mediating this. Right, so we move on to phase 3 at the end of this year and watch this space, but that's, I think, as much as we can delineate from this trial. And I just want to finish really, well, not finish actually, I have a little bit more to talk about, but just talk about drug versus expectancy effect. I don't really think that we can successfully unpick all of this stuff. You know, when we have a drug where it is so obvious that people are on it, I don't think we will ever be able to say what is drug, what is expectancy effect, what is psychological therapy, what are other factors. And in many senses, patients don't care. And in many senses, clinicians don't care. I think it's a really interesting question, but I don't think we're ever going to be able to unpick it. But I just want to show you a little bit of the problem. So this is a trial from the US, and they did a very straightforward trial of psilocybin therapy on alcoholism, looking at heavy drinking days under psilocybin. And you get this nice reduction, statistically significant difference between the psilocybin and the comparator group. And in this case, the comparator group, there was a confuser drug. There was an active placebo, diphenhydramine, to try and confuse people about their beliefs between allocation. But the critical thing about this trial was that they measured blinding, which doesn't tend to be measured either in psychedelic trials or in existing psychopharmacology trials. And this is what they found. Participants correctly guessed their treatment assignment in 93.6% of sessions, with a mean certainty of nearly 90%. And in the second session, 95% guessed correctly. And that also translated to the therapists who were with them. They could also guess which treatment the participants were receiving. So blinding fails almost completely with these drugs. And to some extent, I think that's an opportunity, although that's a different conversation and not one I'm going to go into now. But this is the extent to which blinding and masking fails with psychoactive drugs like psychedelics. Big problem in a classical sense, because what is drug, what is expectancy? How do you unravel that if blinding always fails? So then if we go back to this, this graph, as much as you could say that this is a nice dose-dependent effect of psilocybin, you could say this is a dose-dependent expectancy effect, in which the more people trip, the more they expect to get better. They didn't measure blinding in this trial. If they had, would it have helped? I don't know. I think we can probably conclude that blinding failed quite a lot. It's unclear to what extent the design, i.e. everyone receiving psilocybin, mitigated against that. This is a big problem for the field. But I also think it's an opportunity to understand more about what's going on here. So I just want to illustrate this a little bit further with a trial that was released in preprint very recently from Alan Schatzberg and his group. And this was a trial of people who were depressed and undergoing surgical anesthesia. And they were randomized to receive either placebo or ketamine. So it's effective blinding in the only way you possibly can achieve it, which is by anesthetizing someone. And what you see is very little difference between the placebo and the ketamine group. But you also see this big drop. So surgical anesthesia is a good treatment for depression. Of course, the surgical anesthesia also obliterates the subjective effect of the ketamine. so who just have the biological effect of the ketamine, but even maybe not the biological effect of the ketamine because of the effect of the anesthesia. So all sorts of ways to interpret this, but one of them is that much of what is driving the response under psychoactive drugs with a subjective effect is an expectancy effect. And if that is the case, then the question is, what are the factors in those expectations subsequently? So if they thought they got placebo, they were led to improve than if they thought they got ketamine, or if they didn't know. So again, pre-existing expectation seems to be strongly determinant of what is driving clinical response. I'm going to stop there because it just gets more muddy and complicated from that moment on. But they're happy to have conversations about how we investigate this further. But clearly, clinical trials with psychoactive drugs are not very good at disambiguating between all these different factors that are going on. So we have to bear that in mind when we're interpreting the results from these trials. Okay, so I'm going to finish just because I was asked to about speaking about harms from psychedelics. Now, obviously, we are at the end, coming to the end of a period of great stigmatization of psychedelics, and the general perception is, yes, they can be very harmful, and they can be. I have seen people in whom long-term psychosis seems to have been triggered by not just psychedelics, but other drug use as well. But what does the data show? This is an expert consensus from David Nutt's group about the relative harms to end users in society of different psychoactive drugs. Now you can see alcohol, heroin and crack cocaine are considered most harmful, but psilocybin mushrooms are considered the least. So by expert consensus, psilocybin mushrooms appear not to be dangerous compared to other drugs that we're used to. And this is data from the Global Drug Survey in 2018. This is a global survey of around 150,000 people who use recreational drugs. And they simply asked them, did you have to go to hospital as a result of your drug use? And again, you can see psilocybin mushrooms down here. Sorry, it's rather small, but psilocybin mushrooms down here. The lowest proportion of all drugs of people seeking emergency medical treatment. These are the toxic ratios, as in the ratio of the dose you would need to have a sporting chance of killing yourself versus the dose you would need to get a subjective effect expressed as a ratio. And you can see that psychedelics, along with cannabis, from a physiological perspective, remarkably non-toxic. You really, you'd have to, your stomach would have exploded by the time you took enough psilocybin mushrooms to kill yourself, to get enough psilocybin. So from a physiological perspective, these drugs are not toxic. The context in which they are being consumed. And as I say, I just want to make this clear distinction between what we're doing medically and what happens recreationally. They're medically and what happens recreationally. They're two very different things. This was just a study by my PhD student Emma Copra, who looked in a bit more detail at emergency medical treatment following magic mushrooms, and just to illustrate, there were more than 9,000 people responding to this bit of the survey. Only 19 of them reported seeking emergency medical treatment. And the survey may under-ascertain, because if you had a really bad experience, you'd be less. Survey may under-ascertain, because if you had a really bad experience, you'd be using psychedelics. So you can see a hardening of anxiety, paranoia, suspiciousness, hallucinations, etc. Kind of what you would expect given the drugs. Given of anxiety, paranoia, suspiciousness, hallucinations, etc. Kind of what you would expect given the drugs, given the mechanism of action of the drugs. But also illustrating the fact that people don't tend to use drugs on their own. So people had also used cannabis, alcohol, cocaine, etc. And then the reasons for the incident. So people tending to say that they were just in the wrong context for the experience, and that was driving the adverse experiences that they had. But still, we still get media stories like this, and I suspect we can expect this sort of thing to continue. And again, I just want to focus on the fact that we tend to hear the horror stories about psychedelics, but such things are happening with alcohol and other drugs all the time. So just bear in mind the ongoing process of stigma as we move forward in this process. And another one. Okay. At the same time, we have evangelical articles such as this. This is the founder of the Multidisciplinary Association of Psychedelic Studies, Rick Doblin, adumbrating about the power of psychedelics to change humanity for the better. We need to occupy the middle ground here. The evidence needs to speak for itself. So I'd encourage you to do that. Ignore the evangelist as much as the demonizers. Stick to the science, and we will see where we go with this. Finally, this is the death rate from psychedelics, the National Crime Survey from the UK. So you're looking at death rates from different drugs, opiates here. What have we got here? New psychoactive substances, paracetamol, benzodiazepines. Psychedelics, I actually had to ask them for the data because they don't routinely publish it, but it's very, very low. In fact, it's sort of flat lines right down here. It's basically the x-axis. And when you look at the number of actual deaths reported in this period in the UK between 1993 and 2020, this is measured by looking at death certificates. These are the number of deaths that you see per year in which psilocybin or LSD are specifically mentioned on the death certificate. So vanishingly little. So a summary, quite benign drugs. They do have the potential for psychological toxicity in the wrong circumstances. They may have utility, particularly in non-psychotic mental health problems. I've concentrated on treatment-resistant depression, but they may have a broad cross-diagnostic utility in anxiety disorders. We're doing trials in PTSD and anorexia at the moment. But they're not just drugs, and you can't just give them to people to take home and expect them to be effective. No, they have to be delivered within a psychotherapeutic framework, and for safety, they have to be contained within the clinic, in my opinion. The irony of current regulatory frameworks, and although we've stopped us from researching the drugs for many years, actually they provide the right structure in which to do so now. And I just want to finish by saying that psychedelics, in a sense, have ushered in a little bit of have given a boost to effective psychopharmacology, which I think was kind of in the doldrums a little bit. These are serotonergic drugs. They allow us to probe the serotonergic system to understand more about how mental health problems, affective disorders in particular, are related to serotonergic psychopharmacology. And that's a good thing. I don't know where this field will go, but I know that new knowledge will come as a result of it. So that's it. Thank you for your kind attention. And any questions?
Any questions for James? I've been seeing you moving on your chair.
Thank you. Thanks very much, James. This was fantastic and very educative. I have two questions. if that's okay, one concerns the unblinding, as you might expect. So this is indeed a big issue. And when we did a ketamine trial at the institute, I was the physician in charge, and the plus a co-PI, and everyone knew what they were getting. And it was very, it's very difficult to keep a straight face. I was blind to what they were getting, but couldn't stay blind either, obviously, because of the side effects that people had. So anyway, one of the things that I was trying to do when I was at the NIH was to set up a trial to give it while people were asleep. Right, so it's a little bit what Alan Schatzberg did with, but minus the anesthesia. Actually, give it when they're asleep. So this might be a way. This might be a way around it, and see what happens. Because you are right that it doesn't, in a way, it doesn't matter, but we do use the blinding as a very important component for our evidence base. Otherwise, we could say, well, it's not a problem if SRIs don't differentiate from placebo. It's kind of 2/3 of a response, so it's good. My other point is, and I'm going to finish, is the issue of the side effects and how they're estimated. So my understanding is, and correct me if I'm wrong, is that you've had very few people in trials to know for sure. So the denominator is probably less than 100. So the upper bound of your confidence interval, even for a 0 numerator, is going to be very low. The other data you presented, if I understand it correctly, are absolute numbers. So they're not normalized for the frequency of the use of the drugs, which is probably, they're much more rarely used than, I suppose, cannabis or alcohol in particular, right? Which, everyone drinks alcohol in the UK for sure, right? So, so I just wanted to point it out. I'm with you. I trust what you say, but we may change our views if suddenly many people kind of start using it. Many of whom might be vulnerable as well.
Again, this is why I delineate between what we're doing medically and what is happening recreationally. The lifetime or the past year use of psilocybin runs at about 5%. So it's not an insignificant number of people that are using it. So we will see. I absolutely accept that we need more clinical trial data. The phase 3 trials will have many hundreds of people rather than the 230 that we had in the phase 2b trial. And ultimately, we may find a concerning signal, and it may be with phase 4 surveillance that we find that this is not acceptable. That's the process, isn't it? We will see.
Thank you.
James, thanks for a lovely talk. I wanted to ask about the role of the psychological treatment in the response. So is anyone testing giving psilocybin or any of these other compounds without any psychotherapy or supportive component?
The basic answer is no.
And why not?
Because it was tried before. So pre-prohibition, there was some attempts to give people psychedelics and sort of lock them in a room, and completely separate them out from the context. And this did not go well at all. So the ethics committees report to people. So the answer to your question, no. People are not giving psychedelics without psychological support. It's not thought to be ethical.
What do you think? What do you think, given that, now we've got experience of using it and we wouldn't lock someone in a room and throw away the key, could it be done safely without a psychological therapy? I mean, obviously, people would have to have, the usual kind of safety monitoring that you would have.
I wouldn't be happy to do it, actually. Yeah, I wouldn't. Not with particularly people who are naive to the drugs.
I think there's another way of looking at it, which is, at the moment, we seem to have a model with ketamine where when we give it, we give support, but it's much more medicalized. It's like a trip to the dentist. I always say it's like a trip to the dentist for a checkup, not an extraction. And, it's very medicalized, and that's considered to be, the correct modus operandi. The psychedelics, it's a different, like it was ketamine. You could give ketamine like it was psilocybin. I suspect that there is a model of psychotherapeutic support that is optimal for maximizing the therapeutic benefit, but that's also got to be generalizable.
Yeah, so the pharma company that's developing psilocybin has essentially developed a psychological support package that goes around a dose of psilocybin. And the way I see it working in the future, if it ever gets licensed, is that that package can be embedded into a longer process of psychotherapy. But it helps to delineate the psilocybin plus the support around it, which I think is critical from the underlying psychotherapy that might go alongside with it.
James, there's a question online, I think you touch upon this, but saying, do you consider substance use disorder and previous frequent use of psychedelics as a contraindication, or is this the consensus in the trials that have been constructed so far?
So in the most rigorous trial to date, we would exclude people with prior psychedelic use in the past year, and we matched the number of people with prior psilocybin use with the demographic population use of psilocybin to try and account for, you know, these sort of word of mouth effects in early phase trials that are clearly going to bias the data.
Thank you.
Nonetheless, you can't force people who don't want to volunteer for a clinical trial and who have negative perceptions of psilocybin to then volunteer for a clinical trial. So there's always going to be that element.
Thank you.
Just a little bit more on the psychological support. In the trial that you did, was what you really offered really just a structure of support with helping with anxiety or difficult experience that, you know, potentially any type of therapist could do?
Yeah.
Or was it really making an effort to look at what their issues were beforehand and doing any form of guided psychotherapeutic work with them through that period of time that they were under the influence of the drug?
So it's primarily a psychological support package that emphasized psychoeducation around the drug, so preparing people for the potential effects of the result of the drug, familiarizing them with the environment, so it wasn't, you know, they weren't going into a new place, establishing rapport between the therapists so that the participants felt comfortable with the people who were sitting with them on the dosing day. And then really being informed by what happened on the dosing day to provide 3 sessions of integration support. And what that looked like was, what happened to you? How does this inform upon your experience of depression and the drivers of it? What plan can you make going forwards to help compound positive change? So quite structured and manualized in that sense.
Hi, Jakob Spüth from Switzerland, Zurich. I may sound like an echo of myself from the last session because I'm training to become a psychiatrist for the elderly at the moment. Is there any research done on the specific population of people over 50, 65, and does the data differ in that regard?
Not clear yet. The commercial trials tend to follow the established dogma of excluding people over the age of 65, and obviously there's the problem of emergent dementia in people with depression over the age of about 55. I have a trial that we're running at the moment where we are stratifying between people who are 55 and under and above 55 and up to 80. So that should give us a little bit of data surrounding the older adult groups, but otherwise not aware that many people are looking at that. I think it's a shame because some of the data that we have from the phase 1 trial, I haven't showed this, but one of my PhD students looked at the predictors of negative experience within the healthy participants, and a negative predictor of negative experience is age, as in you're more likely to trip better if you're older. And given the physiological safety profile of these drugs, you know, physiologically they're very benign. I sort of wonder if this group actually might respond quite well to psychedelics, but we will see.
Question here?
I'm just curious about the support package and what that actually kind of looks like in terms of like number of hours that a patient spends with like a therapist, and in terms of like what are the ratios? Is it 1-to-1? Is it one therapist to multiple patients?
Sure. So originally it was 2 therapists to 1 participant. It's now 1 therapist to 1 participant. We had to do 2 to start off with to satisfy the safety concerns of the ethics committees. In terms of the number of hours, we have up to 3 90-minute sessions before the experience, and then a full dosing day, which is about 8 hours, and then another 3 90-minute sessions after the experience.
Have the regulatory authorities in any way taken into account the difficulties with the blinding? Have there been any kind of adaptation in line with that? Will it move forward as planned? Maybe this is not a question for you, but for the company.
I mean, the trial that I showed you was designed in collaboration with regulators. So the 3-pronged, 3-dose design plus the geographic independent primary outcome collectors, I was the advice for how to mitigate blinding as much as possible. Beyond that, it's hard to know what one does.
Thank you, James. James, before we conclude, one question I had for you, and I was thinking more about the proportion of hallucinatory experiences. So when you look at that, how much of it is visual and what is the contribution of the other sensory modality? And the reason I'm asking you this, because I have worked my early days of psychiatry with people with visual impairment. And I was wondering if this is a population where, say, you succeed with the stage 3 trial, this might still be a useful compound, or we're looking at people who have been able to store images.
I think the vast majority of people who experience these effects experience them visually. I don't know whether that reflects the fact that we are predominantly visual beings, or it reflects a biological effect of the drug. Probably the
Bit
latter.
of both.
Yeah, but a bit of both, but the latter. Certainly, I've observed many people who've had auditory synesthesia, changes in their sense of smell and touch, but they tend to be less pronounced than the visual effects. Yeah.
Thank you very much. So let's say thank you once again to James, and again, all of you for your great questions. We don't have psychedelics on the menu at lunch, but there is a nice Sicilian food that is waiting for you in the usual place. And I'll come and summon you if you don't remember exactly how long the lunch is. One little, so this afternoon we have at the end the poster session, which is really 3 of your colleagues who are going to present on the screen and discuss the poster. And this is important because then you will vote tomorrow, and on your vote depends who gets the prize, which is a very special prize I won't reveal yet. So I would recommend you stay. At the end of the afternoon, for those of you like, I will walk you to the venue doing an add-on historical, artistic, and anecdotal tour of whatever is the distance between here and the aperitif, which is not huge, including this wonderful square that you all seen this morning. So if you like to join me after the poster session, wait and we can walk together. Otherwise, you have the details of the aperitif venue in your email. In this wonderful building, there is also in a separate room a very famous painting, which is the painting of the Vucceria. For those of you who have looked guide tour of Palermo would have seen that the Vucceria is one of the famous markets of Palermo that we will walk by. We won't go in, but by when we do the historical tour. And this painting is by Guttuso, who is a neo-realism famous Italian, and I would say Sicilian painter. And he depicts this extraordinary market. And I'm thinking of that because I don't know if you've seen it, James, but if you do see it, or if you do take psychedelic after seeing it, I think it's a kind of imagery, a stimulation that well sort of suits some of the experiences on psychedelics. And you'll see what I mean if you have a chance to see it. It's in this building. It requires a ticket. We couldn't allow you all to go in. But if you are in Palermo the next few days, I recommend you look online. And if you like art, you might consider to visit it because it's a spectacular piece of art. Anyway, enough of chat and time for food. See you all soon downstairs. Have you seen it? I'll show it to you on. I mean, it is an enormous.
Microglia are a major inflammatory cell type in the brain and respond to infection or injury by becoming activated, migrating to the site of injury and removing damaged cells. Experts now believe in schizophrenia sufferers the microglia attacks the good connections between the cells, meaning they are unable to communicate with one another. Microglia Microglia are a major inflammatory cell type. Microglia are a major inflammatory cell type in the brain. Microglia micro.
Okay, everybody, you can find a seat. So thanks very much for coming back. I have the pleasure of introducing my boss, because Oliver House has taken over as the head of the Department of Psychosis at the Institute of Psychiatry. So I have to be very nice to him. But I would be nice anyway, because Oliver is currently the most cited and influential person at the Institute of Psychiatry. And really over the last 12, 15 years, he's produced a whole succession of wonderful work on the molecular pathology of particularly psychosis, but also, as we heard this morning, had a look also at serotonin and depression. So lots of studies on dopamine and glutamate, and more recently also on inflammation and synaptic pruning. So I guess from Oliver's point of view, the difficult task may be deciding which study to talk about. But you have quite a lot of so we have you before and then after the break. So yes, sir.
Thank you very much for a kind invitation, Robin. Remember, it's appraisal season, so no difficult questions. So it's a great pleasure to be here in the room of the Spanish Inquisition. Slightly nervous. I'm going to talk in the first half about a bit about the pathophysiology of schizophrenia and psychosis. And as you heard from Robin, I've done a lot of work on dopamine. Actually, it's not there, but my middle initial is D, and some people say that my middle name is actually dopamine, although I'm not going to reveal what my real middle name is. So I want to start with a few disclosures. As you know, as you've heard, I work at the Institute of Psychiatry in the Maudsley Hospital. I've just finished a stint as vice president of well, that's actually translational. It's not trans as in transgender neuropsychiatry at Lumbeck, and I've worked with a number of companies. But I'm not talking particularly about treatments in the first half, but bear that in mind for the second half, of course. I don't have any shares or any investments in any of these, sadly. So the other thing I need to disclose is that I come from a country that votes people like this in as our prime minister. And why is that relevant? Well, of course, his government in the run-up to Brexit said they don't believe in experts. So maybe you shouldn't bother listening to me at all. Or I'm sure Boris would say that. But that's the other disclosure. Then something else I want to highlight right at the beginning is lots of people that have worked with me on the studies that I'm going to talk about today, or this particular session, really want to highlight Stefan Brugger, Samir Jauhar, Rob McCutcheon, Ellison Wordy, Michelle Coquinu, as having done a particular contribution. And of course, the patients and volunteers who've taken part in our studies. So I want to ask you a few questions as we go along, because I know you've had lunch and that can put people to sleep. So I need to keep at least the upper part of your body moving. So I've got a very high-tech question and answer system, and it's something that we need to check now. So that involves putting your hands up. Very high-tech, as you can see. And I'm going to start it with a nice uncontroversial question to begin with, to see if your arms are working. So who should have won the Eurovision Song Contest this year? And your choices are Sweden, Italy. No, it's good that you're responding, but wait, I'll give you the choices. UK, Silvio Berlusconi, don't care. So who wants to vote for number one? Oh, some Swedes. And Robin? Italy. Oh, lots of Italians. I heard it was good. 3, the UK. Some UK. I have to say, I didn't understand the UK's entry. Silvio Berlusconi. Oh, there's one person. Don't care. There's lots of people. Okay, we'll come back to Eurovision, actually. There's a little theme in my talk. So I'm glad the Q&A system is working. Now a proper question. So this is something that we've just been looking at. So how many drugs have been licensed for psychiatry by the FDA, which is the regulator in the USA, in the most recent decade that you can get information for? So this is a question for you all. I'm not expecting you really to know the answer, but what do you think is the right, what sort of ballpark? So in 10 years across the whole of psychiatry, how many new drugs have we had? First choice is 87, second is 12, third is 52, and the fourth is 28. So who thinks 87? First hand, be brave. Yes, yes, okay. One person. Number 2, who votes number 2? There's a few people. Number 3, 52. One person. And number 4, 28. There's a few more. So I would say actually number 12 probably shades it, followed by 28. Right. Do you want to see what the answer is? So this is something that we just published. Luke Baxter did this with me. We looked at the FDA database. So first of all, in oncology, how many do you think? Whole cancer in 10 years? Yeah, well over 100, nearly 140, 138, I think it was. What about neurology? Neurology doesn't do so well, but still a pretty respectable 52. Psychiatry, 12. So some of you already knew the answer, even though perhaps you've read my paper, but yes, it's very sad really, isn't it? 10 years, and we've only had basically one drug a year across the whole of psychiatry. I'm not just talking about psychosis, so this is depression, everything else. Of course, sometimes people say, well, perhaps the last decade was a bad decade. But actually, we looked back over the previous 2 decades as well, and it was the best decade. This is as good as it gets. So why am I telling you all this? Well, I'm telling you this because this is why I think we need to care about the pathophysiology, because we need to understand what's going on to try and develop more and better treatments. As I think we can all agree that the lack of treatments is not because there's not a need for things that work and work better. So that's my intro. So now we get on to a bit about dopamine. The dopamine, of course, has been around as a hypothesis of schizophrenia for many, many years. I think this is probably the oldest and proper account of a dopamine hypothesis, written by Stephen Stahl and Herb Meltzer. We'll come back to that. Robin's nodding his head, but I'll discuss that later. We'll come back to Stephen Stahl in a bit. Now, I think of this as a bit like, the dopamine hypothesis is a bit like ABBA, because just like ABBA, it came on strong in the 70s and hasn't gone away. But I think the big difference is that the dopamine hypothesis has got some new material, whereas ABBA just recycles the same hits. And of course, this is relevant for the Eurovision contest because they won Eurovision in 1974, which has led them to their later success. So, question for you now, where is the major dopamine abnormality in the brain of people with schizophrenia? And Robin's not allowed to answer because he's probably seen this before. But the choices are, is it increased D2 receptor levels, increased D2 receptor density, reduced dopamine transporter levels, an elevated dopamine synthesis capacity, or increased D3 receptor levels? So a moment or two to think about it, and please think about it online. I won't be able to see your arms going up or down, but you can still do it. Marta's going to check. So if you think 1 is the right answer, please put your hands up now. No one. What about 2, increased dopamine D2 receptor density? No one. Oh, the Q&A system, maybe it's broken. 3, reduced dopamine transporter levels. There's a hand, 2 hands, 3 hands, 4 hands, 5 hands. The Q&A system is working. 4, elevated dopamine synthesis capacity. Few hands going up there. And 5, increased D3 receptor levels. There's 1 or 2 hands. So I think I should have had another option, which is don't know or don't care. So how many wants to put their hand up for don't know or don't care? I won't ask you which. So there's a few of those as well. So that's interesting. So I'd say 4 and don't know or don't care are probably the ones that got the most votes. Well, I'm going to just walk you through quickly the data that we now have, because we now have lots and lots of studies, more than 60 studies that have looked at different aspects of the dopamine system in people with schizophrenia using imaging. This is showing you what PET imaging does. You don't actually explode something in someone's brain, but that's showing that there's a release of a gamma ray, which allows you to localize receptors and proteins and enzymes. And with the dopamine system, we have lots of different approaches to measuring it. So we're very lucky. We can measure receptors, can measure the synthesis of dopamine, its conversion from tyrosine and dopa to dopamine. We can measure transporter levels, etc. So this has been done extensively. And in fact, people first started looking at the postsynaptic receptor, the D2 receptor levels. And actually, I said that the dopamine hypothesis went back to the 1970s. Well, you could argue that it goes back a lot longer than this, because this guy, Shakespeare, wrote about it. Did you know he was a schizophreniologist? Did anyone know that? No? Well, I'm going to try a joke in Italy, which only really works in English. But of course, he famously wrote, D2 or not D2? That is the question. You have to laugh now because the jokes don't get any better. So what is the answer then? Was Shakespeare right that D2 is the answer to schizophrenia? Well, sadly, he was wrong. He got a lot of things right, but on this it's wrong. This is a meta-analysis, all the studies. You can see lots of studies done over the years. 0 means there's no difference between people with schizophrenia and healthy individuals. And you can see that with the exception of 1 or 2 studies, it's pretty much on 0. P-value is 0.05. So there might be a small increase. It's not significant. And Shakespeare had to change his famous saying to probably not D2 is the answer to the question. But as I hinted, there are perhaps 1 or 2 studies that do show higher levels. So is there a subgroup of people that have higher D2 levels? Well, I think the jury is out there, but this is potentially very clinically relevant, because if you do give antipsychotics to people, to rats, you see an upregulation in D2 receptors. Now, no one's actually tried to measure this in people taking antipsychotics, but there is a study that looked at levels of D2 receptors in people who had been taking antipsychotics for a long time and then stopped them, and compared those to people with schizophrenia who had never taken an antipsychotic, who you see here in the see-through bars. So this is the level of D2 receptor availability in those people prior to any antipsychotic treatment. And you see their levels around about 2.5, which is the sort of level you get in healthy people as well without schizophrenia. And then you see here this group who had taken antipsychotics for some time. And they'd not just taken antipsychotics, but they actually had either breakthrough psychosis or developed tardive dyskinesia and other side effects. So they're not representative of everyone who's taken an antipsychotic. I want to stress that. But what is interesting is that they had higher levels of D2 receptors than those who'd never taken an antipsychotic. That's the mean there. But something not commented on the paper, which I think is very interesting, is that even in this group, there's a big variation, and some people didn't show any real alteration, whereas 1 or 2 showed quite large elevations. This is double the average. So there's some variability in your D2 receptor system, and we just don't know if this is predating their treatment with antipsychotics or if it's linked to it. But I would guess it's linked to it because when you look at drug-naive patients, you don't see it. Now, I think this is really clinically important because I think it could underlie breakthrough psychosis that you get on people taking antipsychotics long-term. Unfortunately, it's not a very sexy area, so funding bodies are not interested in us doing the sort of study that would really test this. But bear it in mind when you think about patients who have started to getting breakthrough symptoms, that maybe you're chasing an effect of the drug. Because what we, of course, do is just put up the dose, but that doesn't tend to work. In the long term, they start to get breakthrough symptoms again on the higher dose, and then you put it up again, and then it just doesn't work. Maybe this is what's going on in some people. So D2 receptors not altered by and large in drug-naive patients. But one other thing you need to know about D2 receptors is that they change over age, which is all a bit sad for people like me who are beginning to get on and long in the tooth. And this is a study that's just come out that quantifies this in healthy people. So this is the D2 receptor levels in 20-year-olds, and then you see in 70-year-olds. And you can see that there's a decline over time in the striatum in men and women. I mean, interestingly, it looks like it's steeper in men, but actually that's because you've only got a few older men, and it's could be driven by that. So I think they need more data. I'm not accepting that men age more poorly, but what the take-home message, of course, is that there is a decline over time between around about 5% a decade. So by the time you're in your late 50s, early 60s, you've got quite substantially lower D2 receptor levels in your brain. Why does that matter? Well, it matters if either you develop your psychosis in your 50s or 60s and your doctor is choosing the dose to put you on, or if you've been on treatment long term, because of course you may not need the same dose that you had when you were in your 20s. And what's the evidence for that? Well, a colleague of mine who used to be at the IOP, now in North London, she's very interested in this. This is Suzanne Reeves' work. She's looked at D2 receptor occupancy on amisulpride in older adults. So this is the relationship. So you see this nice relationship between D2 occupancy and the concentration of amisulpride in the blood. That's what you would expect. What dose of amisulpride do you think you need to get 60 or 70% D2 occupancy in someone in their 60s or 70s? And anyone? 50 milligrams? Anyone? Well, how much do we give to someone in their 20s with amisulpride? 400 twice a day? 400 twice a day. Well, 25 milligrams is enough for some. Marta's very pleased because she was in the right range, and you were. So in these people in their 70s on average, you do not need high doses. And that's probably because their D2 receptor levels have declined so much, and you just do not need that high sort of dosing. Marta?
Oliver, I know you don't believe that men decline faster, but say this is actually true. Could you explain women's second peak of onset of psychosis or contribute to that?
That's a really interesting question, because women, of course, get that small second peak in the instance of psychosis perimenopausally, and estrogens do have effects on the dopamine system. So there is speculation that could be part of that. And yes, maybe women their risk remains a bit higher than men in the long term because they don't have quite the same drop. But as I said, look at the data. It is driven by one or two men. So it's declining in men and women, but I wouldn't read too much into that. But it's a good point. The basic message, though, is that we need to rethink what we're giving people over time, because what you had when you were in your 20s may not be needed when you're in your 40s, 50s, 60s. And if you start your illness in your 50s or 60s, you are unlikely to need it, the same dose as a 20-year-old. So we've talked about D2 receptors and that they're not altered. What else have people looked at? Well, this is a meta-analysis of all the receptor imaging of the dopamine system that Stefan did with me a couple of years ago, and this is the summary of it. So I've told you there's no alteration in D2 receptor levels. There's similarly, if you meta-analyze all the studies of dopamine transporter, there's no alteration there. So I think one or two people thought that might be altered, but it's not. It's a good thought, though. But where you see the major changes in this conversion of dopa to dopamine and the release of dopamine, and actually the levels of dopamine in the synapse, you can measure that, and they are higher in people with schizophrenia as well. What we've also done in this meta-analysis is look at the variability in the measures, and this is summarized here. So the yellow means the variability of the data, wider confidence interval, if you like, in the data in people with schizophrenia, and that reflects that there is heterogeneity in some of these measures, like the D2 receptor and the DAT, but you don't see that in some of the other measures. So the take-home message is the dopamine abnormality is upstream of the receptor. So this is about the nature of the molecular changes, but what about where in the brain is the dopamine abnormality? And the textbooks all tell us that it's in the mesolimbic system. Is that right? Yep. So here are a couple of textbooks. Stephen Stahl's is there. This is what Stephen Stahl's textbook says. There's dopamine overactivity in the projection from the ventral tegmental area to the limbic striatum, the ventral striatum, nucleus accumbens. And that leads to overactive dopamine and the psychosis. Question, of course, is, does the biology read the textbooks? So I'm going to ask you, are the textbooks right in terms of the mesolimbic system? So your choices are yes, no, don't care, I get all my answers from ChatGPT. So who thinks the textbooks are right? Put your hands up. No one? Oh, one, two? Who thinks no? A few more skeptics. And who gets all their answers from ChatGPT? Marta, and a few others there. Of course, ChatGPT, when it makes up things, they call that hallucinating, which is very interesting, isn't it? Why they set on that term. So are the textbooks right? Well, the other choice I forgot to give you is what's a textbook for the younger people, of course. So we looked at this, and this is Rob's work. He meta-analyzed all the studies. So the more recent PET scanners, you can look at the subdivisions of the striatum, and they're higher resolution. So you could have a look at that mesolimbic part of the striatum, and you can also look at the dorsal striatum, the caudate and putamen as well. And here is the result of the meta-analysis. So anything over 0 means it's higher in people with schizophrenia. And these are the subdivisions of the striatum. The red is the limbic, and you see that actually is not significantly elevated. Maybe there's a hint of something there, but it's not significant compared to healthy people. But the major elevation is in the dorsal part of the striatum, where you get large effect sizes. An effect size of around 0.7, 0.8 is considered pretty large in medicine. So does biology read the textbooks? Well, it seems not, because actually it's not the limbic system, but actually the mesostriatal, mesocaudate and putamen that is altered. And actually the biology doesn't read the textbooks in other ways as well, because our textbooks all tell us that bipolar disorder and schizophrenia are distinct disorders. But when you look at their dopamine systems, it doesn't seem to be the case. So this is a study that Samir Jauhar did with me, looking at dopamine synthesis capacity in the striatum in people with bipolar disorder, who you see in the black circles, and then also people with schizophrenia with the blue triangles. This is in first episode patients. And it was elevated in both of them, and actually you see that it was related to the severity of their positive symptoms, and the relationship looked pretty much the same in people with bipolar psychosis as it did in schizophreniform psychosis. Quite a strong positive relationship. The highest dopamine synthesis capacity, higher positive symptoms. So this seems to be the case that the dopamine system is linked to the psychosis, irrespective of whether the DSM tells you you've got bipolar disorder or whether you've got schizophrenia. And this wasn't driven by manic symptoms because we adjusted for it, and you still see that relationship. Actually, this issue of whether the biology reads the textbooks has been tested further, and this is something that Eric Chen, who's going to be talking to you later in the meeting, did with colleagues in Hong Kong, and that very nice study that I was also involved in, but they did all the hard work. They looked at dopamine synthesis capacity, again in the striatum, in healthy people in blue, and people with schizophrenia in orange, and you see, as I've told you, yet again, there's that elevation. But then they also looked at people that had a diagnosis of a delusional disorder. You know, this is a psychosis which is just delusions. I don't want to say just delusions because that sounds like it's diminishing it, but they don't have hallucinations and other symptoms. But you still see that elevation in the dopamine synthesis capacity. And then they looked at psychosis NOS, which again is quite a common diagnosis early in the disorder where we're not quite sure what's going on. And again, that elevation was there. So it seems that there is this transdiagnostic role for dopamine. And we've also looked from the prodromal phase to that first psychotic episode, rescanning people, and you see that the dopamine system increases further as people become psychotic. So it seems to change as well. And more recently, we've looked at genetic risk. So these are people that they're not in the prodrome, but they're carrying a genetic marker that means that they're at much higher risk of psychosis than healthy individuals. This is the deletion of some DNA on chromosome 22, which increases your risk of schizophrenia about 40-fold. These are the genes that are deleted. Quite a few genes, including one that we know is involved in dopamine metabolism. But what's very interesting about this deletion is that if you have a duplication of the same region of DNA, it seems that you have a lower risk of schizophrenia. This has just emerged in the last few years. So if you have less of this DNA, your risk is increased. If you have an extra copy of this, your risk of schizophrenia is reduced. So here you have a dose relationship in risk. What about the biology, the dopamine system? Well, we studied this. This is the work of Maria Rogdaki. And here you see, again, dopamine synthesis capacity, and you see healthy people in orange, the carriers of the deletion who have the highest risk of schizophrenia in red, elevated before they've developed the illness relative to healthies, and then carriers of the duplication that reduces your risk in blue. So there's a dose relationship in the dopamine response as well, it seems. So this is all very interesting because it's really all pointing towards a causal role of dopamine in the development and risk of psychosis. But clinically, of course, what do we do? Well, we give people D2, D3 blockers, which is how I think we should talk about antipsychotics. And in my second talk, I'll hopefully give you some reasons why after the break. But a big question then is, of course, well, what do these drugs do to the dopamine system? So I'm going to ask you again, to keep this interactive, what do you think giving someone a drug olanzapine, risperidone. What do you think it does to dopamine synthesis in the striatum to individuals? Does it do nothing? Does it increase it? Does it decrease it? So if you think one, put your hand up now. That's no one. 2, it increases it. Quite a few hands up for that. Number 3, reduce it. Nothing. So again, I should have put another option, which is don't know, don't care. But oh, there are some people on the chat who think it reduces it. Okay, so I think ideally you would think what we want it to do is reduce it, because as I've shown you, this seems to be elevated in at least the majority of people with schizophrenia to some degree, and we'd hope our treatments might correct that dopamine overactivity. Well, this is a study that we did in first episode people. This is what we did, is we scanned them prior to starting an antipsychotic when they were antipsychotic naive. They had the PET scan. You can see that you can measure the dopamine system there. They then went on to their antipsychotic treatment for at least 5 weeks, and then they were rescanned so that we could test whether there was a change. And I have to say, going into this study, I really had no idea. But actually, I would have, if you had asked me, if you forced me to bet, I would have said increased it, because of the consequence of blocking the autoreceptor, which is one of the regulatory mechanisms, and we know D2 receptors block that, and that's a feedback loop. So I thought it might maybe have increased it. But here are the data. Absolutely no change. So 20 patients taking an antipsychotic for 3 weeks and no effect. And now I think that's quite a reliable result. We've studied patients that have taken antipsychotics for years, and we also see that the elevation in their dopamine system is still there. So, you know, I think it's something that our current treatments don't seem to have much effect on.
Oliver, I understood Alan Young to say this morning that aripiprazole blocks the autoreceptor and increases dopamine release in bipolar disorder. Is that not correct then?
It's certainly, if you block autoreceptors, you do increase dopamine neuron firing. But those studies often are just give the animal a dose, a single dose, have a look at what's going on in the dopamine receptors, or usually it's cell recording, so it's not even an animal. What we don't know very much about is what happens long term. And actually, we have done these sorts of studies in animals, in rats, given them haloperidol as well, and we don't see any effect over days of treatment, because this is the difference between giving something acutely, a one-off dose, versus, in this case, doing what we do clinically, which is give it repeatedly. And repeatedly, it doesn't seem to have a big effect. Certainly in animals, if you give a single dose of an antipsychotic, the initial response, and this is the work of Tony Grace in the 80s, is that the dopamine neurons start firing a lot. So probably initially there is a response, but over the course of days and weeks, if you take it regularly, the system adapts, or certainly you don't see a change in that we can detect with these measures. So I've been telling you a lot about dopamine, but what does dopamine actually do in the brain, in all our brains? So I'm going to ask you a question. So what answer best captures what mesostriatal dopamine is signaling? So number 1 is rewarding experiences. Number 2, hedonic or pleasure experiences. Number 3, teaching signals. Number 4, alerting signals. So put your hand up if you think number 1. Couple of hands. Number 2. Couple of hands. Number 3. 3, 4 hands, 5 hands. Number 4. 6 or 7 hands. And I should again have given a don't know, don't care option. Put your hand up if you don't know or don't care. There's a few people. Right. Well, that's very interesting. So alerting was the top choice. Well, let's have a look at the data. And this is a study that Wolfram Schultz published in the late 90s. Because I think if you had said rewarding experiences, you would have been right, I think, in the 90s, when that was really very much the focus of understanding of the dopamine system. And it's still very much, I think, what the lay public think of as what the dopamine system does. But actually, starting with Wolfram's work in the late 90s, early 2000s, our understanding has become much more sophisticated. So what he showed in monkeys is that dopamine neurons fire when you are given a reward. So you get a little burst of firing. But actually, they don't reliably do that. If you repeatedly give them the reward and you paired that with a conditioned stimulus, the dopamine neurons don't fire at the reward, they switch to the stimulus. So that's why it's not really about reward. There's another reason why as well. In a minute, I'll show you. So now it's actually signaling something is happening that's important. And when you don't get the reward, you get a reduction in the dopamine neuron firing. Now, of course, this is reward. So you would have been right in thinking that dopamine was all about reward in the 90s and early 2000s. But later on, people looked at other things like aversive stimuli, in this case, foot shocks. And here you see there's a burst of dopamine neuron firing to a foot shock. So it's not just reward. It's about anything that's going on that's important to the animal. So actually, what we think of dopamine now is much more about signaling something, a teaching signal, that the animal needs to pay attention, something salient is happening. Now that's talking about what dopamine does in terms of learning about the environment, but it also does something else, which is it tells you about the precision of your sensory input. And this was tested in a study that's relatively recently come out in Science, where they tried to make hallucinating mice. And what they did is they had this paradigm where mice had to learn to do something on the cue of a signal. And they used very low intensity sounds. And the reason they did that was it was just at the edge of detection. And mice are very sensitive hearing, but they got the level so that it was just at the edge of it, and they manipulated it to the individual mouse. So then the mice were not sure whether they heard the sound. But what they looked at is the degree to which they then responded. So this is responding. So the mice learned that if they responded to the sound, they got a reward, so they worked for it. And when it was at a very low intensity, they were getting these false alarms. Sometimes the mouse thought there was a sound when there wasn't. This is the false alarm response, which is what they're looking at. And they call that hallucinations because the mouse thought it was hearing something, but it wasn't. Now, I'll let you decide whether that's what a hallucination is or not. But it's an interesting model. And they did some computational modeling around this as well. You know, what they were looking at is how long did the mouse spend trying to get the reward when it thought it had heard something when actually there wasn't. And so this was the measure of its confidence in its prediction about the sound having occurred. So I think an interesting study. We can debate whether it's a hallucination. But what they also did, which is very interesting, is that they then manipulated the dopamine system, and they stimulated the dopamine neurons in the striatum. And if you did that, which you can see in purple here, the mice were much more likely to think they'd heard a sound when there wasn't. So these, in quotes, hallucinating mice were made to hallucinate more when their dopamine system was more active. So why am I telling you all this? Well, I'm telling you this because this actually maybe helps us understand what's going on in our patients, because they've got this faulty teaching signal, and perhaps this faulty signal in terms of the confidence of stimuli, sensory inputs as well, when their dopamine system is overactive. So this is overactive dopamine system, more of them firing, and this leads to you thinking that things are going on and thinking that you're hearing things, misperceiving perhaps internal stimuli. So this is my model of how dopamine could lead to psychosis. And this dopamine dysregulation, I think, leads to something that is akin to the experience that a lot of the patients talked to me about when I was working in the prodromal clinic. So these were people that had early subclinical symptoms that we know put them at increased risk of developing schizophrenia in the next 1 to 2 years. And a lot of them would come to me and say, "Doctor, I feel that it's a bit like being in the Truman Show." So for those of you who haven't seen that film, the main character is living on the set of a soap opera, and his life is being broadcast around the world. But he doesn't know that at the beginning of the film. Everyone else on the set is an actor. And he gradually realizes that actually everyone is an actor. The set is just a set. It's not they're not real houses. And a lot of the patients that I saw in this prodromal clinic would say things like, I think that something is going on. I just don't know what it is. I have a strong sense that other people know what's going on, but I can't put my finger on it. And you could see from what I told you about what dopamine is doing in the brain, how that might be what this dopamine dysregulation is leading to. Because your teaching signal has gone awry, and your dopamine system is constantly firing and saying, look out, watch out, something's happening, something important is going on, or there's a sound there, there's something there. So you can see how that might be what's going on in the prodrome, but then of course, at some point, when trying to make sense of it all, it develops into the full-blown psychosis.
So, Oliver, I get really stuck at this point because if I was terrified, my dopamine would be high. And how do we know that it's not the terror of the illness that's driving the dopamine up?
That's a really good point. So what I did show you was that it's elevated in the prodrome, but it becomes more elevated as people develop the illness. So I think what is going on is that people are starting with a system that is sensitized, more active, but because of genetic environmental factors, that leads to altered processing of their stimuli. And there are, of course, other factors that contribute as well. It depends on how you look on the world, as how you interpret that. But if you have certain beliefs about the world and certain prior expectations, you can see how that might lead to paranoid interpretations and psychosis. But of course, what we often forget as doctors and nurses is that psychosis is intensely stressful. If you believe that you are being followed by the CIA or being watched constantly, that must be incredibly stressful. And that, of course, is feeding back on the system. And we know that stress releases dopamine. So you've potentially got a feedback loop here. So I think you're right, actually, that that potentially the experience of the emerging psychosis has biological effects that maybe worsen it, if you like, heighten it. Now, I can't tell you that ultimately, if you go far enough back, I can't say that that prior to that prodromal experience, what's going on, except that I can point to those people who were that study of people at genetic high risk, where many of those hadn't any symptoms at all and already showed some dopamine loading, so suggesting that you've got this sensitized dopamine system already. So that's the model, and I've shown you some of the data that supports it. But in the last few minutes before the break, I wanted just to talk about what might lead to this dopamine dysregulation. because this is, I think, downstream of what may be going on. So I've pointed out that the major change in the dopamine system is not in the limbic part, but actually in the dorsal striatum, particularly the part of the striatum called the associative striatum that's linked to the frontal cortex. Now, why is that interesting? Well, that's interesting because there's lots of data in animal models that shows that this frontal cortex in particular regulates subcortical dopamine. And we tested whether this might be the case in people with schizophrenia in a study where we looked at the volume of the frontal cortex measured on MRI and whether that was related to striatal dopamine, which is on the vertical axis here. And you can see that they're inversely related. So people with lower volumes in their frontal cortex had the highest striatal dopamine. So that suggests, of course it doesn't prove any connection, but it suggests that these two parts of the brain may be altered in schizophrenia in a way that's consistent with that model, that there's something going on in the frontal cortex that's driving the subcortical dopamine system that's suggested by the animal models. But what could cause that? What is going on that might lead to that lower brain volume? Well, this again goes back to an old hypothesis. This was put forward by Erwin Feinberg. This is a photo of Erwin Feinberg in his later years. He actually put it forward in 1983. This hypothesis that schizophrenia is caused by faulty synaptic elimination. So this was another hypothesis that came about quite a long time ago, not in the 70s this time, but the 80s. So I think of this more of a Madonna hypothesis. It's stayed around a long time. I'll let you judge whether it's got new legs. Erwin actually sadly died last year, but he was in time to see some of the new data. And I'm going to share with you some of the data that's just come out from a study that we did. But one of the most exciting things, I think, came out of a lab from Carl Sellgren, who's in Karolinska, where he looked at what a cell type called microglia do to synapses. So this in red are microglia from people with schizophrenia, and in black, microglia from healthy controls. And then he looked at the degree to which they were phagocytosing or eating synapses. And you can see that there is increased phagocytosis by the microglia derived from people with schizophrenia. So they're eating up synapses more, and that also translated into lower spine density in the neurons derived from people with schizophrenia. There you can see there's a lot of overlap with healthy people. So that's very interesting cellular work, that there is something going on with the genetics of risk of schizophrenia that carries over into cells that mean that they phagocytose synapses more. Now, how is that? How might you understand that? Well, this is a little clip from Sky News talking about one of the studies. So I'm just going to try and play that, and you can get the Sky News take on it.
Microglia are a major inflammatory cell type in the brain and respond to infection or injury by becoming activated, migrating to the site of injury and removing damaged cells. Experts now believe in schizophrenia sufferers, the microglia attacks the good connections between the cells, meaning they are unable to communicate with one another.
So that's the theory, and I think Sky News captured it quite well. But what evidence is there that there is synaptic density alterations in people with schizophrenia? Well, there's lots of evidence post-mortem, and you can see that there's lower spines, these little blobs, in samples from people with schizophrenia, and other markers of synapses are lower in people with schizophrenia on meta-analysis. But until recently, we couldn't actually measure synapses in the living brain. But in the last few years, PET ligands that bind to a protein that's expressed in our synapses have been developed. So this is a protein that's expressed in vesicles that actually are involved in release of neurotransmitters. So that means that we can actually mark the number and availability of these synapses in vivo in patients. So this is the first study that was done. We did this a couple of years ago, looking at this tracer binding in people with schizophrenia. So here in orange, you see the levels in healthy people, and in green, people with schizophrenia. Do you see lower uptake of this tracer, particularly in the frontal cortex? And here is the brain map showing this pattern. So again, you can see it's particularly in yellow, the reductions in schizophrenia in the frontal cortex. So I was very pleased, actually, that Erwin did get to see this before he sadly died, because this is first direct evidence in living people to support his hypothesis. It's now been replicated by a group in Yale, again in people with schizophrenia. So I think we'll see many more studies trying to understand this in the next few years. But I think this has taken the dopamine hypothesis and linked it up to the cortex. And now the model I'm proposing is a little bit more complicated, and it starts in the cortex with alterations in these immune cells and astrocytes that regulate our synapses, that lead to imbalance in glutamate and GABAergic neurons, potentially to lead to the cognitive symptoms and negative symptoms of the disorder, but also via the projections to the striatum, to the dopamine dysregulation and psychosis, which also feeds back on this system. So this is my updated model that incorporates the dopamine hypothesis as well. And I think it's interesting because it's new targets for treatment. And then after the break, I'm going to talk about some of these that potentially target the glutamate system as well. Just finally, I need to talk about Donald Rumsfeld. So you may be wondering what Donald Rumsfeld has to do with schizophrenia. Well, nothing, apart from the fact that he said there are known unknowns. And I think that's very useful to bear in mind. There are, of course, unknown unknowns as well, but we can't do anything about that. But there are known unknowns. And what we don't know yet is there aberrant synaptic pruning that leads to these dopamine changes? Is this really connected? And something else is whether D2, D3 blockers, they don't work for all people. Antipsychotics don't work for quite a proportion of people. And I think a big unknown is whether there are biological subtypes that are linked to that. So I want to leave you with those thoughts and then just summarize what I've told you about today. So the major dopamine abnormalities, those of you that said dorsal striatum or striatal dopamine synthesis and release, you were right, but it's the dorsal striatum, reliable little finding. It's linked to psychotic symptoms. It seems across disorders, although I'm not yet sure about psychosis in major depression. We've got a study ongoing on that. It's linked to lower frontal cortical volumes. So potentially, actually, it's these biological findings are linked in schizophrenia, and it's not altered by D2 blockers. Remember, D2 receptor levels decline with age, so we should use lower doses of antipsychotics in people over 50. And you may need to increase it if they don't respond, but it really says we should be starting lower than you think. Because, amisulpride at 25 milligrams might be enough if you're in your 70s. And then I've shown you evidence that there's something going on in synapses in people with schizophrenia. And this is really pointing to new upstream targets to treat and even prevent schizophrenia. Why do I think this is all important and interesting? Well, as I've talked about at the beginning, we have a problem in developing new treatments in psychiatry in general, and we need to bridge this translational gap. And I'm hoping that understanding more about the pathophysiology will help us and enable us to make the leap As you can see, I'm not a very good animator, but that's my attempt to show you what I think we need to do. And of course, I've also shown you that the dopamine hypothesis is still alive and evolving, unlike ABBA, who are now just avatars. So in London, you can go and see holograms of ABBA. You don't actually see the real people anymore, but they're just stuck in the 1970s. And in fact, I'm going in July with my daughter, so I'll tell you what it's like. Thank you very much for your attention. I don't know if we have time for any questions.
Well, yeah, we do. Shall we start with someone who hasn't asked any questions? Diego, actually. So this morning wasn't sufficiently interesting to ask this question. But I think we usually put the slides on the website. So unless there are particular slides that you...
No, I think I'm fine to share the slides.
Yeah. Diego. This is Diego Controni, who is a consultant and a senior lecturer at the Institute of Psychiatry, but has also been very involved in putting on the forum.
Thank you, Robin. Thank you, Oliver, for the fascinating talk. I just was wondering this theory of schizophrenia, of the nigrostriatal pathways, the primary dysfunction in schizophrenia, is also consistent with the classic theory of schizophrenia of a primary motor disorder.
That's a very interesting question. So I think we forget actually that people with psychosis in their first episode, even before antipsychotic treatment, a proportion of them present with motor signs as well. And there have been nice studies in countries where you're less likely to get antipsychotic treatments, you can do them. So in places like Africa, where you look at the rates of motor symptoms in first episode psychosis, so you know they haven't had an antipsychotic, and it's around 20-25% of patients presenting with motor signs and symptoms as well, dyskinesias, catatonic symptoms, posturing. What I showed you is that there is alteration in the dopamine system in that putamen part of the striatum as well. So it could well be that that is driving the motor problems that our patients present with. I think we tend to have forgotten this because we think of any motor problem as a consequence of the D2 blocker, but there may actually be something there due to the pathophysiology as well.
There's also these wonderful studies of Elaine Walker using videotapes, maybe before your time, Oliver. So she asked parents to send her videotapes of the child who became psychotic and a brother or sister, and the child who became psychotic even at age 2 or 3 had tics and was clumsy and showed motor abnormalities. And the people she showed it to had a high degree of accuracy in pinpointing who was the psychotic. Have I taught you something?
Yes. Well, I didn't know Elaine Walker had done those, but yes, I know there've been studies about these. So yes, again, fitting with this, there's perhaps the dopamine system is vulnerable because of genetic or early environmental factors, and it involves the motor part as well.
David, there is one online, first of all, congratulating for the super talk, and then saying, can you comment on supersensitivity of the receptor in patient in long-standing treatment? Is supersensitivity reversible?
It's a great question. As I hoped came across, I have to say, that the only data we have is that study that I showed you, the only data I'm aware of anyway. So I don't think we can say that there is definitely supersensitivity caused by antipsychotics. But I think clinically what it means is that if you might need to think in patients as they get older, look out for side effects more and think about trying to reduce the doses. And if you see that breakthrough psychosis emerging in people, it does say that putting up the dose in the long term is probably a waste of time. So maybe we need to think about alternative strategies to treat them. And clozapine is is the one that we know is effective. And I'm going to talk about that a little bit after the break when I talk about new treatments as well. The other one is the possibility is partial agonists. And we've just finished a study. You'll have to invite me back another year if you want to hear about the outcome. But all I can tell you is we compared amisulpride to aripiprazole in healthy volunteers, and there were differences, but big differences in their effect in the effects of those two drugs on dopaminergic measures. So I do think that is an interesting alternative approach as well.
And of course, tardive dyskinesia is thought to be a supersensitivity disorder, and if you stop the drug, eventually it can normalize, or clozapine might facilitate it.
Yes, and then treatment for tardive dyskinesia is valbenazine or tetrabenazine. These are dopamine depleters, but working presynaptically. The interesting thing with TD is we've just been doing a study on this, and actually the prevalence of TD, I think, has dropped markedly in the last. We can't find patients with TD by and large, and I think that probably is because we don't use the same high doses that we used to. So, which is good news, I think.
Hi, my name is Fatma. Thank you for the great presentation. I've actually been involved in a systematic review on this topic in Toronto. My colleagues and I are wondering if you're doing any work in measuring synaptic density in CHR populations or first episode psychosis populations?
We've just finished a study in first episode psychosis, which is under review at the moment. And the interesting thing there is we don't see the same degree of changes. We haven't looked in CHR, or that's the clinical high risk people, so prior to the onset of the first psychosis. So I think that's also very interesting because it's good news. I'm not saying, I mean, we need to watch this space, but it doesn't look like the synaptic changes are there from birth. At least in our studies so far, it seems that there's something that's different between the first episode and the multi-episode patients.
Hi, I'm Taran Bastin-Pillay from Adelaide, South Australia. Do you have a hypothesis why clozapine might work for supersensitivity psychosis and possibly TD, but counterintuitively also has a rebound psychosis? What would the mechanism from a dopamine hypothesis for that clozapine effectiveness?
So Robin's excited by this because he's been talking a lot about this. We have been looking at the how clozapine works. I've actually been focusing much more on the glutamate system, and we've got some data on treatment resistance and glutamate. I think you could speculate that what we do know is that clozapine doesn't block the D2 receptors to the same degree over time, and probably to the same level even acutely. And if you look at the PET, because it's binds at lower levels and is off the receptor very quickly. So, I think that the speculation is that might allow the receptors a chance to recover.
So we better not ask too many more questions, because Oliver will be using up the second part of his second talk. So shall we stop at that point and we have a 15-minute break, or?
Well, actually, Laura, would you like to come and tell us what the break is about? Because don't be shy. So I had actually abolished food for the coffee break, because I think you eat enough at this conference, and I was worried about your not just dopamine level, but glycemic level. But Laura, whose husband is actually the owner of one of the finest restaurants in Palermo, and certainly the best Argentinian restaurants outside of Argentina, has decided to send us lots of wonderful food, which is
just some biscuits, alfajores, and some hot mate.
And this is where, Laura, is it the same place?
Yes, the same place,
so
just a very short break.
You can, because you need you need to run down and burn 2 calories at least, get some of this lovely food. And the restaurant, actually, you see also some details about the restaurant, so if you wish to go. Yeah, so enjoy it, and then please be back. And thank you, Oliver, again.
So back in 15 minutes.
Hold on. Back. Let me look at the time. Yes, back in 15 minutes, please. I'm happy to bring you anything like coffee or tea. Drug abuse, who by definition often come.
That Weinberg never liked Danny Weinberg because he wrote his paper in 1983. We came out with the neurodevelopmental hypothesis. We never referenced him. So at any conference, he kept popping up and saying, well, you think you invented the neurodevelopmental hypothesis. But really, I said it in 1983. So it took about 10 years before we could have a civilized conversation. You know, he was just a clinician. You know, he did this in some spare time. He was a, what do they call it, an honorary clinical something or other. So it's fantastic. He did all that EEG work.
Did EEG work alongside it as well?
Yes.
Because I know it's basically about EEGs.
Yeah, that's how he started thinking about it. Okay, thanks very much for coming back. I know also
thanks for being nice to Oliver. I mentioned that you should be nice to him since he was my boss. It wasn't anything to do with the quality of the lecture. It was just you were being kind to him. So here he is back for more, and this time we're going to learn about, say, possible advances in treatment of psychosis.
So thank you very much. I obviously didn't do a good enough job in my first lecture, so I have to do a second lecture to try and redeem myself. So changing topic here, I'm talking now about treatments. You know my disclosures. This is the learning objectives. So I'm going to be talking much more about other people's data now, talking a bit about what we already have and using it better, talking about what has just arrived. And I've already told you that we have not had very many drugs licensed, so spoiler alert, there's nothing too exciting. And then what's coming, as Marta asked me to talk about what might be round the corner. It's in drug development. So of course this is very much my own perspective on things, and I am going to be talking about pharmacological treatments, not going to be talking about other treatments as well, because I've only been, I've got limited time, so I've even had to prune some of the pharmacological treatment stuff as well. So, course of schizophrenia. We know that it begins with cognitive and negative symptoms, which tend to continue throughout the course of the illness, and then there's psychotic symptoms that come and go, and are what usually lead to someone presenting to their doctor. This is taken from a review that clearly the last author was a bit of a fool, because he was talking about outcomes in schizophrenia, but he didn't talk about the most important one at all, which is mortality. And this is, I think, one of the areas that has been a big advance in recent years, is that we have finally, as a field, woken up to mortality in our patients and started to think about it. And now, in the last decade, there have been lots of studies looking at mortality in people with schizophrenia and other mental illnesses, and showing that time and again that our patients die earlier than you would expect. This is a meta-analysis published a few years ago that summarized them all and shows that on average people with schizophrenia die 15 years earlier than you would expect for their age and gender, etc. So this really is the most important outcome of all. And of course, a big question then is, well, does our treatment make any difference? And again, this is something where in the last few years, finally, in the last, I think, 3 or 4 years, we've woken up to trying to test this. And this is largely thanks to people in Scandinavia, where they have these excellent databases that they can look at it. So I know you've just had a coffee break, so I want to wake you up with a question again and use our sophisticated Q&A system. So the question for you is, in people with schizophrenia, relative to no antipsychotic treatment, is antipsychotic treatment associated with 10% higher mortality, 30% higher mortality, 50% lower mortality, no difference in mortality? So this is your question. Please put your hands up if you think 1 is the right answer. Antipsychotic treatment associated with higher mortality at 10%, 1. What about 2, 30% higher mortality? 2, 3, 4, 5, 6. What about 3, 50% lower mortality? 2, 3, 4, 5, 6. There's a few more, 7. No difference in mortality. So most of people, I think, would say no difference, but then perhaps a little more for lower and a few for higher at 30%. Interesting. So where has this been tested? Well, Finland is the country that has started this all off, and Jari Tahonen and Heidi Tapala in particular. And the advantage they have in Finland and other Scandinavian countries is that they have these databases that cover the whole population, because they have registries of everyone who's born there and their hospital admissions and treatments. So Heidi looked at this data. It's naturalistic data, and this is, of course, what you need, as good as it's going to get when you're looking at long-term outcomes like mortality. And she looked at everyone with schizophrenia in a defined period in Finland. So over 60,000 patients who'd had at least one admission with schizophrenia during this time period, and looked at what happened to them in terms of mortality over the next 14 years. And the interesting thing there is that they then looked at whether they were more likely to die when they were taking an antipsychotic or when they were not taking an antipsychotic. So reflecting the fact that people don't take their antipsychotic continuously. Sometimes they come off it through their own decisions. Sometimes the doctor stops it. But just looking at whether they were more likely to die during a period of treatment versus no treatment. And here are the data. So this is the survival probability. It starts at 1 because that's at the beginning when they are alive. And here you can see over time what happens if you are spending more time on an antipsychotic treatment in black, in the gray color at the top, or if you are not on an antipsychotic treatment in black. So you can see that the curves diverge. And the people that were not on antipsychotic treatment were more likely to die than those on an antipsychotic. So those of you that said 50% lower, you're right. Because actually, if you look at the odds ratios, this is actually the raw data, but the odds ratios, all-cause mortality, the hazard ratio if you're on an antipsychotic was 0.48, so about 50% reduction compared to not being on an antipsychotic. And you can see that in the raw data as well. Very interestingly, patients on clozapine had the lowest risk of dying, which is interesting, of course, because this is the drug that we associate with lots of side effects and risk of agranulocytosis. Now, you may wonder what underlies this. And risk of suicide is markedly reduced in those people taking treatment. So that's, again, about a 50% lower risk. So potentially some of that is associated with lower suicide rate. But then you might think, well, perhaps the treatment is helping reduce the risk of suicide, but that comes at a cost of side effects, and particularly cardiac side effects, which we know is the cardiovascular disease is the leading cause of mortality in our patients, higher than suicide, and is increased relative to healthy people. So what happens to the risk of cardiac death? Well, that is also lower in people taking antipsychotics, which I think is one of the most important findings in the last few years for our patients, because it's telling us that the treatments overall are not associated with higher mortality, but actually with lower mortality, and that includes the main physical causes of early death. But of course, it's naturalistic data, so you have to think, well, is there something different about people that take antipsychotics regularly versus those that don't? Now, some of the outcomes that you can look at and that they've looked at in these databases, you can control for that because the patients can be their own control. But that's difficult with death because you can't then re-enroll them in the study after they've died. They don't go and take antipsychotic again. But what they have done is something very clever, which is look at the relationship between taking an antipsychotic and whether they are more likely or less likely to take treatment for physical health problems, particularly cardiac medicines. So this is a study that again used the Finnish cohort, and what they did, which I think is clever but is a little complicated, is they looked at treatments with the antipsychotic. So you can see that at the top. In this case, the patient started olanzapine, took that for a period of time, then they stopped any antipsychotic, then they went on to clozapine, then they stopped. Now, all that time, they were taking a statin, and they stopped their statin at that point, and that is what they're using as the outcome measure. It's not starting the drug, because, of course, that might be confounded. You might start your olanzapine and your statin when you're admitted to hospital, so that wouldn't be telling you about whether you're more or less likely to take a statin, whether you're on antipsychotic treatment. Instead, they're looking at whether you're more or less likely to remain on your treatment, your statin or your other cardiovascular treatment, depending on whether you're taking an antipsychotic. So in this case, the person wasn't taking an antipsychotic, they stopped their statin, and that would be an increased risk of stopping your statin when you're not taking treatment. In this case, another patient on clozapine, then they're on polypharmacy, then they go on to risperidone, and they're on risperidone, and they're taking a statin for this period of time. They stop the statin when they're on risperidone. And that's an example where they stopped the statin when they were taking an antipsychotic. So that time, it's increased risk when they're taking an antipsychotic. Does that make sense? No, no. I'm not sure how I can explain it anymore, and perhaps we can talk about it in the coffee break. But yes, it's a complicated design, but what I think is neat is that they're looking at discontinuation of the cardiac treatment. So this is the data. So this is the different antipsychotics. This is your hazard ratio of stopping a statin, depending on whether you're taking your antipsychotic or not. Anything below 1 means you're less likely to stop it if you're taking the antipsychotic. And what you can probably just about see from the back, but I can point out, is that across all the different antipsychotics, actually the hazard ratio is if anything lower, but it's significantly lower for a number of these drugs here. Some of the others, it's lower but not significant. This is partly because of a power issue. Some of these drugs didn't have very much exposure at all. This is the number of patient years of follow-up they had. And you also see this with some this is first generation drugs. This is also true for some second generation drugs as well, like clozapine. In this case, about 60% lower risk of stopping your statin if you're taking clozapine, olanzapine about 60% as well, aripiprazole about 50%. So I don't think the individual drugs really matter. The message is that there's lower risk across a range of treatments for statins being stopped, but also other treatments like antihypertensives. So this doesn't prove, of course, that antipsychotics are in some way helping people take their statin or their antihypertensive. What it might point to, though, is that if people are well or better, then they are better able to engage in other treatments as well. That's a hypothesis. It doesn't prove that. These are naturalistic data, but it's certainly telling us that our drugs are not making things worse. So that, I think, is, if you remember one thing from this session, I think that is the most important thing, because I think that's the most important thing that's come out in terms of treatment. But I want to talk about something else now, which is atypical antipsychotics. So a question for you again: which of the following are atypical antipsychotics? So choice 1 is olanzapine, haloperidol, and risperidone. Choice 2 is amisulpride, olanzapine, and risperidone. 3 is none of them, and 4 is all of them. So if you think 1 is the right answer, put your hand up now. If you think 2 is the right answer, put your hand up now. Oh, about 20. Yep. If you think, oops. If you think none of them is the right answer, 2 or 3, 4. If you think all of them is the right answer, 1 person. Yep. I've learned, of course, that I need to put don't care on there as well, but because not everyone answered. So most of you said number 2, amisulpride, olanzapine, and risperidone. So this is an example where the majority is wrong, I think. And I'll tell you why. Because we looked at what are the definitions of atypical and typical antipsychotic. And this actually goes back to a paper that Jeff Lieberman wrote in the 90s. And the 3 criteria were higher prolactin, effect on prolactin, so higher prolactin in first generation antipsychotics, lower in second. Higher risk of extrapyramidal with first generation or typical, lower with atypical, and then efficacy. And here is a heat map that shows the risk of these things, grouped by whether they are considered to be typical or atypical. So the typicals at the bottom, atypicals at the top. This has just been published. And the darker color means the higher likelihood of this. Now, if there was really a grouping into typicals down the bottom and atypicals at the top, you should see uniform colors within the typical and a different color pattern in the atypical, and you just don't see that. The only drug that really seems to meet these criteria is this one here, which is clozapine. It shows light colors across the board. And of course, that's because that's what was used as the prototype. But in practice, how we actually classify them doesn't follow that at all. So I think we should just get rid of a classification term like typical, atypical. It implies something that just doesn't exist in reality. In fact, the drugs all have pros and cons in terms of these efficacy and extrapyramidal side effects and prolactin effects. And we need to think about the drugs individually rather than in terms of classification. Does this matter? Well, it does matter because guidelines and research often does this. And we talk about, we analyze the atypicals and separately from the typicals. Well, that's a bit of nonsense when you think that there's so much variation between these drugs. So that's my rant over. I think we just throw out this sort of classification. Now, what else I think is new about existing drugs? Well, something that's interesting in terms of long-acting injectables, and this is probably where we've had the most advances in terms of existing drugs, is that we're now getting drugs that really can be used very infrequently. So this is the table of depot drugs, drugs available as depots from the Maudsley guidelines. But now we have 2 new drugs that are just coming. So we've got aripiprazole 1 monthly already, but Otsuka and Lundbeck have just produced a 2-monthly version, which is about to be released. And of course, we also have paliperidone now available as a 6th monthly injection called biannually. Does anyone get what they've done there? Biannual injectable. I don't know what was going on with Otsuka and Lundbeck to come up with Asymptify. I have absolutely no idea how that's supposed to imply anything. But, and as I said, I was working for Lundbeck, but they didn't ask me about the name of this when they were coming up with it. But, you know, I think Janssen have done quite a nice job with this one. So this is really interesting because this gives us a partial agonist that we could potentially use only 6 times a year, and a D2 blocker that a patient could have just twice a year. So this is a real, I think, game changer for those patients that really don't engage, or those patients that are very well and don't want to keep coming to a clinic for an injection every 2 weeks or every 4 weeks. And for those people that don't want to have injection site abscesses and all that rigmarole. So it's not going to suit everyone, but I think these are, you know, real advances. Now, we have to think about whether it's possible to use these long-acting drugs. You know, what happens to the levels over time? Because there is a risk you have to give more of the drug for it to last. But Janssen have looked at the plasma levels of paliperidone and compared 6-monthly paliperidone to 3-monthly. So 3-monthly is in blue and 6-monthly is in red at different doses. So what you do see is that you get a slightly higher peak of the 6 monthly, but you also get a slightly lower trough. So that could be a concern because you've got a period of time down here towards the end of the last month or two where the levels of the 6 monthly are below or approaching low levels with the 3 monthly. Does that matter though? Well, they've looked at relapse risk and compared the 3 monthly and 6 monthly, and here's the study. And the 6 monthly is in red and the 3 monthly is in blue. And you basically see that the relapse rates were all very low and similar. So it doesn't seem that you get an increased risk of relapse with having the drug given less frequently. Of course, this study is just one study, and I think reality will come when it's used in clinical practice and we start to see what happens in the cut and thrust of the clinic. But it doesn't seem that our patients are at increased risk by going to less frequent injections. So that's about as good as it gets in terms of our, things that have happened with our current treatments that are available or just about to become available. And of course, there's a big elephant in the room, and that is treatment resistance, which is, I think, an area where, again, we're beginning to wake up to the fact that we haven't been doing enough about it. And treatment resistance is something that I've been looking at and been quite interested over the last few years. I actually wrote a paper about how to identify treatment resistance. And you might think, well, that the author list is almost as long as the paper, and perhaps the paper wasn't worth it because we came up with the conclusion that inadequate response to adequate treatment with at least 2 different antipsychotics each for 6 weeks is how you should define treatment resistance. But the reason that was worthwhile is because actually a lot of the clinical trials that have been used as the evidence base for treatment resistance have conflated patients that didn't take treatment or were not tolerating treatment with treatment resistance. So this was to try and get more rigorous approaches to studying it. But what can we do in practice? Well, this is a case of using what we already have better, because we know that clozapine works, particularly if you look at the more rigorous trials where you see the bigger effect sizes. But I think the big problem is that we don't recognize it. We often under-report it. So I'm going to ask you a question. What is the prevalence of treatment resistance in outpatient clinics? Choices are 1, 15%, 2, 55%, 3, 33%, and 4, 25%. So again, use your sophisticated Q&A system. If you think 1 is the right answer, put your hands up.
Outpatient clinic, are we talking about?
Just a general outpatient clinic. Actually, I'm going to give you data from South London, which represents the world as far as we think from Maudsley perspective. But yeah, actually, there have been studies in other settings as well. So just a general outpatient clinic. So I'm not talking about looking at treatment resistance in long stay wards, in rehabilitation services. I'm talking about your average community team with people that are out of hospital, stable, generally pretty stable. So one is 15%. Robin said that. 2 is 55%. Anyone? A couple of hands. 4 or 5 hands. 3 is 33%. That's about 5 or 6, 7 hands. 4 is 25%. More hands. I'd say probably more. There's a tie between 33 and 25%. Well, the data from South London are 56%. So 55% was the closest answer. So this is a study that we did looking at.
But my patients do much better.
Your patients do better than mine.
15%.
Okay. I did say just your average clinic. Yours is an exceptional clinic. And I think that's probably maybe that's part of the issue, that we often think that our patients are doing better than perhaps they are. And when you go and look and actually look at the patients, you see that there's much more treatment resistance than you think. Now, 33%, that's probably what the prevalence is amongst the entire population of people with schizophrenia from the epidemiological studies. But of course, the people that do very well get discharged from our outpatient clinics. So over time, we enrich our clinics for people that are not doing so well. So we should actually be thinking potentially of having 50, 60% of our patients on clozapine. That's what the guidelines say. And we use the guideline criteria to define treatment resistance when we did this study. But actually, when we looked, less than half of the patients with treatment resistance had ever tried clozapine. So there's a 25% of all our patients in community outpatient clinics who had never tried clozapine and should have been given the opportunity to try it based on the guidelines. So I think I'm holding up my hands here in terms of South London anyway, and my hospital trust, that we are not doing very well with what we've got. We need to do better. And it actually is a bit worse than that. So even amongst the people who had started clozapine, when we looked at those people, so these are those that got onto the drug, on average, it had taken 4 years from the point at which they met criteria for treatment resistance for them to start it. And this is in the Maudsley, and of course we like to think that we are much better than everyone else, but clearly we're not. So something's going wrong here, and there are lots of factors that contribute to it, but you might well say, well, does it matter? Does it matter having a long delay? And the last few years, there have been a few studies that have looked at this, and it's just been meta-analyzed. So anything on this side of 0 means that you had a poorer response if you started clozapine after a longer delay. Anything on this side means you had a better response. So overall, your chances of responding to clozapine when you got to it were 70% lower if you'd had a longer illness duration. Now, that's not the case in all of these studies, but these are all relatively small studies because people have only started to look at them. But it does seem to, when you put it all together, it's pretty clear. So this is telling us that we need to get on with things. We shouldn't be hanging around. Now, of course, there are issues with duration of illness. There's something called lead time bias, and we can discuss that, which complicates interpreting these sorts of data. But I think from a clinical perspective, all things being equal, this tells us that we should get on with clozapine, because the chances of someone responding is better if they've had a shorter illness. How to do that in practice? Well, as I said, I'm holding up my hands about our trust. We're not doing it particularly well. So one thing we did was set up a service to try and help that. And I think it does take something like that, because guidelines, even though I've spent time writing them, don't really seem to make a difference to some of these things. We've had the NICE guidelines in the UK for over 20 years, and I still showed you that the delay in starting clozapine was about 4 years in our trust. So clearly guidelines don't work. And I think it's not fair to say to busy clinicians, you need to read the guidelines and get on with things, because clearly it's not as simple as that. There are barriers, and you need to help with that. So we set up this model, the TREAT model, to try and help with it. And I'm just going to share with you a little bit of data from our outcomes. And this is naturalistic data. So this is, firstly, people told me initially, you can't start clozapine in the community. It's not safe. And that's one of the findings we had, was actually that almost all the patients, 95% plus, were admitted to start clozapine in my trust. And there's actually a survey across the UK, and a large proportion of psychiatrists thought that you had to be admitted to start clozapine. I had a lot of my colleagues in South London and Maudsley telling me, you can't start clozapine in the community, it's dangerous, you need to be in a hospital and they need to be monitored closely. But that's not the case. We know in other parts of the world people do it. It just needs some system to do it. So this is part of what we did. And we found that actually you could start clozapine safely. We had no problems, and no significant problems, I should say, no lasting or serious problems. And it made a difference. I'm not going to show you the symptom changes, but I want to show you some of the hardest data. So this is hospital bed days. In the year before clozapine, in the first cohort we put it through, and then in the year after. So you can see the vast majority in the year after had absolutely no hospital admissions. There were one or two that went from 0 to being admitted. So clozapine doesn't work for everyone, and I'm not saying that at all, but particularly the ones who had been more unwell, had been in hospital longer before they started clozapine. And remember, they were in hospital at some point, but not in hospital when we started clozapine, which is another story. You've got to wonder why they didn't start it when they were in hospital, when there was a good opportunity, but they were all started in the community. But the vast majority did well in terms of hospital admissions. But my colleagues also said to me, yes, well, you might do that, but you're going to end up having to do much more outpatient work with them, and there'll be more resources required for that. But that's not the case either. So this is the number of outpatient contacts on average in the year before clozapine, and then in the year after. So again, a significant reduction, about half as many, because they were better. And this also factors in that sometimes they got better and were then able to engage with their psychological treatment that they'd never had before because they couldn't engage with it. So sometimes they were actually having a lot more outpatient contacts because they were having CBT or occupational therapy. But overall, they didn't need as many appointments with their psychiatrist or their psychiatric nurse. So you can do it, and it can make a difference. And it can save money as well. We calculated about £800 per patient per year. So that's about using what we've got better. I want to spend the last part of my talk talking about what's on the horizon to give you some idea of why things might be, what might be coming. And if you'd asked me to talk last year, I think it would have been a bit depressing. In fact, the last few years, because there hasn't been very much. But I think this year is very exciting because we are on the cusp of some really interesting and exciting new treatments. And this is a review we wrote looking at some of them. And here's the receptor binding profiles of drugs that we've already got, aripiprazole, clozapine, etc. And then these are the drugs that are in development. And what this really I want to point out is that they are quite different. These are not, this is where D2 is. You can see all the old drugs blocking D2 receptors. But some of these new drugs do not act on D2 receptors at all. Now, this is why I think it's so exciting, because we are on the cusp of potentially a different mechanism of action for the first time in 60 years. So I'm going to talk particularly about these two in the first bit of this section, which is this drug CEP and this drug xanolamine. And then I'm going to talk about a glutamate drug if I've got time as well. So starting with CEP, has anyone heard of this drug? Just a few of you. So this is a traceamine receptor agonist. And if you haven't heard of CEP, you probably won't have heard of traceamine receptors. They were only cloned about 20 years ago. And they are highly expressed in monoaminergic neurons, including the dopamine neuron. And activating them reduces the firing of the receptor. So this is potentially a way of tuning down that overactive dopamine system that I was talking about before the break. By activating the receptor, you are reducing the firing. They do some other things as well. Now, we tested this actually in a mouse model of the dopamine overactivity that we see in patients. So this study, we gave mice subchronic ketamine releases dopamine. And after you've washed them out of ketamine, that dopamine overactivity persists. So we're talking about ketamine this morning as a treatment for depression. Well, I'd like to tell you one thing that it does do is cause dopamine changes. So maybe that's part of its mechanism. So they've been washed out of their ketamine, but they still have this elevation in dopamine activity. This is synthesis capacity, the same measure that we use in patients. So this is mice treated with ketamine. This is our model of that dopamine overactivity. What happens when you give a TAR1 agonist? Well, here are the data. And Michelle did this. So this is in red, the ketamine-treated mice. Again, you get that overactivity in the dopamine system compared to controls. But if you have treated them with a TAR1 agonist, it's back at control levels. So that's really exciting. You can imagine my excitement. Here we've got something that does normalize the dopamine abnormality. Now, it has been tested in the clinic. This is being developed by Synovian. And they did a phase 2 trial, which was published recently. And here are the data from it. So this is the change in the PANSS positive score. Gray is the placebo group. Green is the the CEP group, the TAR1 agonist group. And you can see over the course of the 4-week trial, there is a separation. And the patients treated with the TAR1 agonist showed an improvement, significant improvement over placebo. So that's exciting, interesting. It's the first proof that this might actually work in clinic. They also looked at negative symptoms. And there I think you didn't see such a dramatic effect. But again, separation by 4 weeks. So potentially a benefit for negative symptoms as well. But I think there is one little caveat that I want to point out, which is that the placebo response is tailing off, and it's relatively modest placebo response compared to other recent trials with antipsychotics. Not compared to older studies, but compared to more recent ones. So this, I think this is encouraging, but I think we need to see the phase 3 trials before we really know this is going to work. So those phase 3 trials are currently in progress. They're going to read out later this year. So look out for this. If these are positive, then we will have a whole new approach potentially to treating psychosis. So that's the TAR1 mechanism. What about other mechanisms? Well, another approach is again upstream, is to target muscarinic receptors, which regulate, some of them regulate dopamine neurons. And a drug that has been developed for this is a combination of xanomeline and trospium. And the reason that they have to have this combination is shown by this study. So this was a study published many years ago in the American Journal of Psychiatry, and it was just using xanomeline in patients with schizophrenia. And they showed a positive benefit for the drug compared to placebo over the course of 3.5 weeks, but lots of side effects. So this drug was developed by Lilly, and Lilly actually were also testing it for other indications, and they didn't proceed with it because it was not very well tolerated. So here are the rates of nausea, vomiting, and other gastrointestinal problems. And you can see that it's a small study, only 10 per group. 7 out of the 10 patients got nausea and vomiting. So these are really high rates. So they didn't continue with this drug, and that's of course because muscarinic agonists, muscarinic receptors are in the GI tract, and muscarinic agonists are causing these problems. But what's happened more recently, and what's breathed new life into this, is that the combination of this drug with trospium, which blocks peripheral muscarinic receptors, means that you have the potential to block the side effects. And trospium doesn't cross the blood-brain barrier very well, So then you've got a way of blocking the peripheral effects, but allowing the central effects. Now, this has been tested in a phase 2 trial. Here are the data. So again, this is the improvement in the PANSS symptom ratings. This is the placebo in black, and then this combination in blue. This was published in the New England Journal a couple of years ago. And this is the first data that shows, again, a benefit for this combination, this drug, by 5 weeks. Again, this is interesting because the placebo response is relatively small. So you've got to be a little bit cautious. Now, this may be like the Synovian study because this is a quite small phase 2 trial. But what we already know from the company website is the data from the phase 3 trials. And here you see a much more robust placebo response, more typical of what we see these days in trials, but you're still seeing separation. 20 points improvement in the PANSS total in the group treated with the combination of xanomeline and trospium. This is a really healthy improvement. Effect size is 0.6. And they've also seen that in their second phase 2 trial. So this, I think, is really exciting. And they, as I understand it, are now going to the FDA for licensing later this year. So this is pending what the FDA say, something that may well come to your clinics next year. Now, that was total symptoms. They saw improvement on positive symptoms as well, but less improvement in the negative symptoms. Potentially, there was an improvement, but if you look at the placebo group, the negative symptoms sort of uptick there makes you wonder whether that's just a sort of statistical effort. So we've talked about 2 new mechanisms. And how much longer have I got, Marta? 5 minutes? So I want to talk about one further new mechanism and a different target, and that's targeting the NMDA receptor, which is on which is a glutamatergic receptor. And this is of interest because although I've been talking earlier about dopamine and synapses, there's evidence that NMDA receptors and the glutamate system is perhaps a consequence of this synaptic pruning is altered in people with schizophrenia. This is a SPECT study that looked at this, looked at NMDA receptor levels. It was done by Lim Palowski quite a few years ago now, showing lower levels in drug-free people with schizophrenia, antipsychotic-free people with schizophrenia. It took quite a few years for us to try and replicate this, but we've now done that. This is a SPECT study that Katie Beck has done at the Institute, using a PET tracer this time, that looked at NMDA receptor availability in schizophrenia. And again, in the drug, first episode, antipsychotic-free patients, lower levels. And actually, you get the hint that there are lower levels across the brain in people with schizophrenia. So this means this is consistent with the idea that there is NMDA receptor hypofunction in the illness. What does that mean for treatment? Well, directly activating NMDA receptors is a bit risky because you might be these are excitatory, you might be overactivating the brain and you can cause fits. But this system relies on cofactors such as glycine. So this is glutamate in blue that binds the receptor. It will only activate the receptor if certain cofactors also bind. And one of those is glycine, which you can see in light blue binding there. So one way of potentially boosting normal, if you like, or physiological NMDA signaling is to block the reuptake of glycine. So there's more glycine around. So you block it, and then that potentially boosts the levels and increases signaling. So that's the theory. A couple of companies have been developing these glycine transporter inhibitors. Roche developed bitopertin, And they tried it in negative symptoms, people with schizophrenia with negative symptoms, and it wasn't successful. And they've discontinued that program, as I understand it. But Boehringer Ingelheim have got another program with a different drug that's a glycine transporter inhibitor. And this time they are targeting cognitive symptoms. And they have a very complicated trial that was published a couple of years ago now in the Lancet Psychiatry. It's complicated because they used multiple doses. It's also complicated because it's probably got the longest statistical section of a trial. And here it is. So I want you to read that. Starts there, goes on, and then carries on onto the further page. But the bottom line is they did something that actually I think is quite clever, because quite often when companies do these phase 2 trials, they need to do several doses because they're dose finding. But then, of course, you have a multiple comparisons problem because you've got lots of different arms. And it's a phase 2 trial, so it can't be very big. You don't want to give lots of patients a drug that, we don't know that it works. So what they did here is they said, well, we've got a hypothesis here. We're going to pool all the arms, and we're going to test models based on the fact that there are dose-response relationships in the cognitive outcomes. And the null hypothesis is that there is no dose-response curve. And that allows them to look at all the data from all the arms without making lots of tests. And if you do that, you see this response rate. So 5 out of the 6 different dose-response models they tested were significant. And the overall omnibus test, which is there a dose-response relationship of any sort compared to no response, was significant. So that's encouraging, but it's of course a phase 2 trial, and we need to test that in a further trial. But nevertheless, based on that, the FDA have given it breakthrough designation because it would be the first drug for cognitive impairment in schizophrenia. And they are now testing this in phase 3 trials. I perhaps need to skip over this and we'll get on to questions. This is about dementia psychosis, where pimavanserin is being tested. But I think I'm going to summarize now by just telling you, I've told you what I think is the most exciting and interesting finding, which is that contrary to what we might think, antipsychotic treatment actually is associated with lower all-cause mortality and lower likelihood of stopping cardiac treatments. We've got longer-acting injectables now available up to twice a year. We need to think more about treatment resistance. It's more common in the patients that we see than the textbooks would tell us because there's an ascertainment bias. And clozapine initiation is possible in the community. And then on the horizon, we have these new modes of action, which look very interesting. Thank you very much for your attention.
Thank you, Oliver. Time for a few questions.
Thanks, that was fantastic, Oliver. Can I just ask, you do think though that it is possible that the people who adhere to antipsychotic medications are also of a different type to those who don't, right? And that this is a very important confounder, right? That's a possibility as well, right?
In terms of the naturalistic data, yes. I mean, these are naturalistic data, so we don't know. We can't control for all these variables. What is interesting, though, is that if we actually have a look at the data, so who are the patients that are less likely to adhere amongst our patients? Who do you think? What would you say? Just shout out. All of them. Well, I don't know that's true. But is it someone who's taking? If someone's on an oral medication, are they more or less likely? Are they the kind of group that are more likely to be adherent compared to someone who's being put on a depot? Do we use depots for people that are adherent?
Yes.
Sometimes, but in general, generally it's the patient that's not able to take their medication reliably. I think it's not just that they don't want to take it, but many patients struggle and they end up on depots. That helps them take it regularly. But what they did in these studies is if you actually look at the effects of being on treatment, it's the long-acting injectables and clozapine which did best. And these, if you think about the patients that we think are going to be less adherent in general and the ones that have the more severe illness, those are the groups. So, you know, we can't rule that out, of course, but I think it suggests that this isn't completely driven by that sort of effect, because the ones where you saw the effect most clearly were those patients that have ended up on LAIs and those that are on clozapine.
So, Oliver, diabetes, obesity, metabolic syndrome, cardiovascular risk with antipsychotics, they don't kill you?
Not at all. That's that's another area of our research. But what I think is so interesting about these naturalistic data is that in the all things taken together, despite the fact that some of our drugs might increase your risk of diabetes, hypertension, and these other things, all things taken together, we can see that they are not overall killing people. So maybe the fact that you are mentally better, you're less likely to commit suicide, you're better able to engage with physical health care. These things outweigh the consequences of the metabolic effects of antipsychotics. But I'm not saying at all that we should ignore those. We need to also think about choosing the best medication for our patient in front of us and using ones with the lowest risk.
Okay, one last quick question. And then tomorrow we have an entire morning on treatment of psychosis, so don't worry.
Just a question on the aging process and schizophrenia. Do you think there's a biological clock problem, not just cardiac or cancer risk, that the schizophrenia increases the aging process leading to overall mortality?
I think the jury's out about that, but there is this idea that there's a kind of premature aging going on in people with schizophrenia. Perhaps that some of the brain changes as well are linked to that. And you do see this telomere effect, which is associated with aging, and that's greater in people with schizophrenia. I think it's difficult to know whether that's part of the illness or the consequence of the illness at this stage.
Or a consequence of the adverse childhood that many of these people had, which is associated with increased brain age and telomere shortening.
Could be.
So to avoid a fight on this topic, I think we should thank Professor Oliver House. And now I hope your dopamine level are still up and running, because we are switching age group. We have heard a lot about adult population, a little bit about, we had question on the older group, but it's my pleasure to introduce Professor Giri Stringaris, who is the chair of Child and Adolescent Psychiatry at UCL, has been awarded several prizes, but is not only a clinician, he's also a neuroscientist and a computational psychiatrist. But he's promised me that at this time of the day, he's not going to be heavy on statistics, but he's bringing us into the world of younger people. Welcome. Your microphone.
Thank you very much. It's a great pleasure, an honor to be here. I presume I'm the first Greek since Alcibiades to, you know who I'm talking about?
Actually,
to enter Sicily.
Yeah,
No, I'm not.
You were never too strong in Palermo, I have to say.
No, we were never too strong in Palermo. We were warded off very strongly. That
Exactly.
is true. That is true. Yeah, but it's still a Greek name, which is always very nice to hear. But then, of course, perhaps the affinities with England are greater. I was thinking this morning and telling some other people, because of course, what Sicily and Britain have in common is that both were invaded by the Normans, right? So there's shared risks there. And I'll come back to that in a minute because it has some relationship to the talk I'm
Actually,
going to do.
this is a proof, because, you know, for people that know the flag of the Isle of Wight, it's very similar to this, and this is the Trinacria, which is the flag, in fact, of Sicily, which is the woman with the 3 legs, which is a Norman flag. Sorry, I won't interfere.
No problem at all. So, so we're going to move away from that era, 1066, around that time and all that. But and I'll try to talk to you about depression and its treatment today. I shan't talk too much about. Actually, I won't talk at all about. I'm just funded by the Wellcome Trust at the moment. I'm not going to talk much about mechanisms today, which is most of the work we do, and most of the funding we have is for that at the moment. But I will be trying to take a deep dive into the available data about the treatment of child and adolescent depression, and try to figure out with you what is going on. What is the dream of any psychiatrist, I guess, of my generation? It must be to have the same rates of success as oncologists do. There's no doubt. I mean, oncology has transformed everything, right? In some areas. So I have written a paper, actually, with my wife, who's a hematologist, called "Should Child and Adolescent Psychiatry Be More Like Pediatric Oncology?" And it's kind of a review of what's been going on. It's amazing. But it all started, of course, as you know, with chronic myeloid leukemia. They discovered a genetic defect back in the 50s, 60s, right, under the microscope. It was a translocation, Philadelphia chromosome. The translocation gave rise to a protein. It was an anti-apoptotic protein, so a protein that prevented cell death, right? Which means that there was, you know, it allowed clonal expansion. It prevented the stopping of clonal expansion, and they created a drug called imatinib. It's amazing. It's amazing. It was licensed, I think, just the year I was finishing medical school. It was just transformative. It changed lives. And ever since, of course, other big developments have happened, right? So the most recent one is CAR T cells in children, in acute lymphoblastic leukemia in children. Up until 15, 20 years ago, if a child had ALL, you know, you could mainly pray and do some horrid chemotherapies. No longer. So we do want to get there. That's amazing, right? The development, it's it's genetically very simple, and it took decades to achieve, right? Must remember that. Now, what happens with depression, though? Well, our phenotypes are messier, and I'll talk a lot about that, right? So what exactly is depression? Is it like leukemia or the leukemias? I don't think so. The key tissues are unavailable, which is an important argument. What we called in our article the tissue issue. So we don't have access to the brain as we have to blood or the bone marrow. But that's not a great argument, because I don't know if people who... I used to do neurology before I did psychiatry. And one of the great pleasures of neurology, of course, is to recognize eponymous syndromes, remember them, and just point them out, you know. And that was kind of great bravado, and, you know, you could show off by doing this, except you didn't have any treatments. So all you could do is prescribe anti-epileptics and steroids. This has changed, of course, and people will have heard of nusinersen, an antisense RNA probe that people use for one type of spinal muscular atrophy, right? So the tissue issue is not that strong a reason. Obviously, our disorders are multi-genetic, right? They're different. It's not just a chromosomal translocation, as far as we can tell. Common disorders are a little bit like diabetes and hypertension. You know, the kind of liability threshold type models, small effects that are small effects from multiple genes. And environments play a role in a way that you don't see in leukemias, right? What sorts of environments are we talking about? Loads. You just heard about horrid childhoods, right? Horrid childhood is unlikely to unless you were growing up in Chernobyl. or near the area where the nuclear accident happened in Japan. It won't really affect you. And there's the issue of normativity, and we talk a lot about that. I've written recently more about this. It's a very important issue. It's what are the boundaries to normality? What are we prepared to call depression? This is a very important question. And of course it varies. It varies by historical epoch, how we define it. It varies by the context in the family and the context of the person. This is not unique to psychiatry and certainly not unique to depression within psychiatry. It's true also of other areas of medicine, but it's very prominent in our case. As we say in that review that we've written, in that editorial opinion piece we've written, it will be very hard to find a person who has cancer who would tell you, I don't want you to cure my cancer. But all of you who work clinically will have come across patients who will not want treatment or who will be skeptical about treatment because they consider some of the manifestations of what we call an illness a part of themselves, right? So there are those kind of very fundamental issues. Plus, this is connected to other things that, and this has to do with what I'm going to talk about in a minute, the increase in the incidence or prevalence of disorders, of psychiatric disorders, particularly amongst young people. The concepts we use in psychiatry, much more so than in oncology, we are interactive kinds, we human beings. So if I tell someone that they have depression, or that there is the possibility out there that they could have depression, that has an effect, most likely, on the people who could have depression. This is not some sort of weird metaphysics, right? I mean, you can do behavioral experiments of this sort about how much you can influence the general population by the availability of concepts. Ian Hacking, who recently died, had a lot to say about that, and it's very much worth revisiting some of his work about that, specifically about mental illness. Okay, but this is an overview of my talk. All this was kind of preliminary stuff. So the first question is, should we treat depression? The GMC, at some point at least, when I was training, had a very nice kind of benchmark, and it said, if you're a doctor, you should always be thinking about whether you would want that treatment either for yourself or, more importantly, perhaps, for a member of your family, right? So should we treat depression, and to make it more concrete, in our children, our own, our nephews, whatever there might be, the children we see in the playground? It's a very important question because, of course, it is early in age. You expose them to something early on, and we should have firm answers for this. And of course, most people, including myself, will say, yeah, of course we should treat depression. So let's see why. Young people with depression have a higher risk of suicidality and suicide. I'll come back to that. They're far more likely to have depression in the future. They're likely to die younger and are more likely to, this is from kind of the, this odds ratio here comes from one of the British cohorts, the 1946, I think it is. We'll discuss it in a minute. And they're more likely to have a physical illness. They have a lot of disability. This is kind of this is unipolar depression here at the top, right? This is the disability adjusted years lost. These are all sorts of other illnesses and disorders. Unipolar depressive disorders in adolescence is top, right, according to the World Health Organization, and is kind of, sorry, this should be different here, the title. This is basically showing that between, in the last decade or so, the prevalence of emotional or internalizing problems and or depression has been increasing in various countries in the West, right? This is pre-corona. These are studies that are difficult to do, but it's an important kind of thing in relation to what we were talking about before, in thinking about, are these true increases in prevalence? Would we see them in a physical illness? What do they mean exactly? Where do they come from? Adolescent depression does increase the risk for adult depression, but it's not as massive as you would think. So you can see here that the odds ratio is 2 something. It's obviously high, right? But it's not an inevitability, obviously. And depression is also associated with premature death by close to 70 years. About 19-20% of the severe group with depression had died, compared with about 11% in the mild or no problem age group. And this is where the adjusted odds ratio of about 1.6 comes from. So this all kind of looks, gosh, yeah, I mean, it's bad, right? We should treat it, right, so far? No? Concurrent depression associated with greatly increased risk of self-harm, but the associations with adult suicidality are less clear, with studies showing mixed results. There's heterogeneity in depression, though. If you just sit down and just do combinatorics, if you had this kind of inclination when you were in your secondary school, kind of to do, you know, to try to go to maths Olympiad or something like that, and playing with those sorts of things, you will remember that you can get very quickly to very high numbers. So those 9 symptoms, especially the way they're phrased in the DSM, can give rise to about 10,000 potential types of depression. Right, literally, and this is just the theoretical. This is the theoretical possibilities. I think Eike Fried did something very nice where he looked at I think it was the STAR-D data, where he actually looked at how many subtypes there were there empirically rather than just theoretically, and there were about 500, 600 or something like that. Now, I'm not saying this is a specific problem to depression. If you try to classify SLE, lupus, right, with the criteria of the American Rheumatological Association, you might end up with similarly big numbers, but it's important to bear in mind. But what is more important is to bear in mind, and I think in his great talk this morning, Professor Alan Young mentioned this, is the fact that there is a lot of spontaneous remission. Again, this is very different to acute myeloid leukemia, chronic myeloid leukemia, and all that. There just isn't spontaneous remission, right? Which is, of course, fantastic for the people who are doing trials, because you can try pretty much anything because the outcome is death otherwise, right? So that's the counterfactual, which is not the case with us. Okay, so what you have here is that 53% of adults with untreated depression show improvement in 12 months. And the rate is even higher in children. Well, you would say, well, I guess okay, but it's a relapsing remitting disorder, potentially. So maybe, you know, 12 months is not good. But as you saw this morning in what you got from, you saw that, I think Alan showed this, it's the proportion, this is a survival analysis, right? And it's time on the x-axis, the proportion with no recurrent episode. And you can see that, and on average, it's about 50% who had a first episode won't go on to have another episode for many, many, many years, right? So if you had a child, think about it in this way, kind of a Bayesian way. Given a child with a first episode, how likely is it that they won't have depression ever again? Right? You could infer it from this. Given that a child is in their first episode, how likely is it that treatment will be beneficial? And we'll come to that. There's another fundamental problem, though, which is, and I know this is very unorthodox of me to go to this, but I want you to think about it, which is, if you think about, so we love disorders, right? As we've you know, that's how we grew up medically, and it's great. But immediately when we think about disorder, we have settled the etiological question, i.e., well, it's bad for you, innit? Gotta be. But is it? Like, how do you know that it is bad? Obviously, it's very annoying to have it. It's very bad to have it. But can you distinguish between two models? The model whereby there is a liability which leads to depression, and depression leads to a negative outcome. The liability can be genetic or environmental, it doesn't matter. Versus a model where the liability is common to depression and the negative outcome. The negative outcome could be suicidality, for example. Can you see the distinction? This is very hard to resolve. And you heard from Professor House just now that you know, naturalistic studies are an attempt to do this, but with the obvious problems that we have. And actually, this slide is a very strong argument why we need treatment studies, or natural experiments for that matter. So a treatment study would be an answer to this. If you could treat depression and show that you wouldn't have and wouldn't have the negative outcomes, that would be pretty good, wouldn't it? I mean, it wouldn't be exactly proof of causality, but it would get you pretty close to it, right? It would be reassuring. Well, let me tell you, I don't want to speak for adult depression, but I'm sure that it's pretty similar, that we don't have data that this is the case. We don't even have data, strong data, that we can influence quality of life or that we make a big impact on suicidality. Should we therefore believe that? No, we shouldn't, but we should do the trials, right? We should do the work, and this is exactly why treatment work is so important. Even if this is in the short run, right? Obviously, it's very hard to do RCTs for 15 years. Well, okay, but do it for do it for 3 months, do it for 6 months. Just measure quality of life or what matters to patients. Measure suicidality and see how it goes. And I'll come to that more. So this is a very fundamental question. One way of thinking about these things is to look at Mendelian randomization, but it doesn't bypass the problem. Now, Mendelian randomization makes use of the fact that it's all a natural experiment who we are in some way, genetically speaking, at least, right? Which alleles we're going to end up with, right? And what they show is that, at least for some outcomes, like suicidality, a higher polygenic risk score for depression is associated with a higher risk of suicidality, okay? Which is, you can see it here. And you can see that the predicted risk of self-harm, right, in percentage, expressed in percentage, increases ever so slightly. This is MDD, the mean it's polygenic risk score on the x-axis. And you can see that there is a slight increase across the MDD polygenic risk score quantiles in terms of predicted risk of self-harm. But again, this does not resolve the question between the two models. Model number one, the top, right, which is essentially a mediation model, and model number two, which is a shared risk factors type model. So with that in mind, we need to do more work, right? This would be what we would be saying. So what does the National Institute for Clinical Excellence recommend? What do they tell us to do? You may know this already, that they say watchful waiting, or if it's mild depression, right, do one of these things, okay, and then maybe offer individuals CBT or attachment-based family therapy. Now, I think family therapy is great, but there's very little evidence in depression. There's only, at least the last time I looked, there was one trial. It does depend a little bit on how you define family therapy as well. But there isn't terribly much, yet they say that. So it's kind of psychological treatment first. Bear that in mind, I'll come back to that. Then the moderate to severe depression is family-based interpersonal therapy, family therapy or CBT for the 5 to 11-year-olds, maybe fluoxetine for 12 to 18-year-olds. Again, lots of CBT first, plus minus fluoxetine, and maybe IPT or again family therapy. You can find all this online. It's nothing kind of that's what NICE say. And you know how NICE are done. They do say it's great that we have NICE in Britain. It's really fantastic. I worked and practiced in America. I don't think that it is great that they don't have it. I don't think it's great how medicine is done overall in many places. They have pockets of excellence, obviously. So it's great, but of course, it's far from infallible. In fact, it's a very human activity with all the sociological baggage that comes with it, right? So we have a love in Britain for psychological therapies. Great love. And we even want to scale it for people, right? So that everyone can have access to it, should they want to. Which is it sounds like a very noble thing to do, right? So, and certainly in depression, That's the idea in child and adolescent depression. Do CBT first, essentially, or do IPT or whatever. Okay, well, that's great. Is there a trial that shows that you should do CBT? No, there isn't. It's based on the presumption that it is at least as efficacious and that it has fewer side effects. Okay? So, why then not just do psychological therapies? Why don't we just stop here? Right? Why don't you say, guys, just do psychological therapies. Go on train if you haven't trained yet in CBT or IPT or both. Just do psychological therapies. Well, let's take a dive into psychological therapies. So this is a meta-analysis that was published by someone who I have a lot of respect for, Pim Kuipers. And it's in psychological therapies. And you might not be able to see it here, but you know, the pooled risk ratio, the effect size, is very much in favor of psychological therapies. Between the various meta-analyses, the extent, the magnitude of this effect size varies. Okay, it doesn't matter that much. Let's just take it at face value. So, has anyone here conducted a psychological therapy trial? Has anyone done a pharmacological therapy trial? Okay, so pharmacological therapy trials typically have a placebo arm, right? They have a placebo arm. Placebo. What is the equivalent of placebo in a psychological therapy trial? Waitlist control or treatment as usual. Well, I wasn't the PI of psychological treatment studies, but I have helped out, and I think they're very difficult to do. They cost a lot, right? Absolutely no doubt. But sorry, if I randomize you to, well, you can just carry on in our fantastic child and adolescent mental health service, right? We'll see you every 3 months. That's our treatment as usual. Or if you tell someone, you're just going to wait. You all right with that? Okay. Now you're coming for the treatment. And by the way, it's a brand new one. It's a new kind of way of doing, you know, treating depression. Like, what do you, is this a fair comparison? You know, I don't know. Does anyone think this is a fair comparison? No, right? When we talk about fairness, we talk about the thing you do when you flip a coin, right? You obviously, you know, the stuff that gets in the way, you know, it's deterministic randomness in a way, right? But you flip a coin, you can't control it, right? So it's biased. And I think that the results are inflated, in fact. There are some people who say, hang on a minute, but there are trials where there have been control arms. Okay, well, let's look at a couple of them. This was one from 2020. The experimental group had an 8 weekly 1 hour session versus, as far as I could tell at least, and I'd be very happy to be corrected, you know, a psychoeducation leaflet and the possibility of being called by the person you've been allocated to. This is another one. This is what you get: 8 ICBT modules, 8 individual therapist sessions delivered via chat, modules, text materials, cognitive restructuring, the whole lot. And I'm reading out what the controls got. Controls were assigned to a therapist and received an introductory personal platform in mail from their therapist, informing them that there would be weekly assessments and that their assessments were to be viewed by their therapist to monitor their mental health state. They were informed that their therapist might contact them to follow up on their well-being. Like, sorry, but is this like flipping a coin? It isn't, right? It isn't fair in that sense. I'm not saying it's bad. I'm not saying that I necessarily can tell you how to do it better and what comparator you should seek, but I would have thought that at least having people doing 8 sessions with someone face-to-face would be a good comparator. Like, okay, well, you don't want to do the therapy because the therapy is your active ingredient. Well, why don't you take some bloke or, you know, woman or whatever and put them there and just have them talk for the same amount of time? That would be fair-ish. No. Okay, well, okay, you can't do that, and it costs a lot of money, perhaps. Why don't you just do a placebo? Oh, it's been done. What did it show? Okay, this is the famous TADS study, Have people heard of the TAD study? Well, the TAD study shows that there was no separation between CBT and placebo, and adding CBT to fluoxetine did not do anything. Okay, so the only trial where the same rigor was applied to CBT as it does for pharmacological treatments did not lead to separation. And it was not badly powered. I mean, it's probably, I think it's the biggest. I can't remember for sure, but it's pretty big, the study, right? And you can see the graphs here. This is placebo, the open circles, the white circles. This is fluoxetine alone, the black circles. The triangles are CBT alone. This is fluoxetine with CBT, right? And you can just see that no matter what depression outcome you look at, this is the equivalent to the Madras here, to the HAM-D, what you can see here is that there's no separation, right, between CBT alone and placebo when you use placebo. So, you know, I'm prepared to believe, and I want to believe because I like CBT, and I'm actually right now studying the active ingredients of cognitive therapy, and I grew up in this tradition. I'm very interested in this, and I think it's very important, and I do think it has potential. But somehow for depression, we haven't got the evidence yet, I think, where we want it to be. Yes?
What about the difference between the ability, what about the differences between the ability of cognitive ability of a child who probably wouldn't get CBT and all of this? Because that's what I find. I mean, I'm a psychologist and I work with children with depression, and I find that sometimes it's very hard to actually look at studies and really, find the true findings of them in terms of, because there's so many different levels. And
yeah, well, that may very well be true, but what argues against this is what happens in other complex disorders like social phobia. Like in social phobia, the results we have so far from Eleanor Lee's trials are, that it's equivalent to what you get from, what you get in adult cognitive therapy. And in adult cognitive therapy for social anxiety, we have some very nice trials where they have an active comparator, which is exposure. That was a really, these are really kind of brave comparisons, and this is what you want in science, right? So it could be, but I don't think that it is the case. I think that there's so much non-specificity in depression, even in adults, right? I mean, the adult depression people here can correct me, but my understanding is that the modality of the therapy, the psychotherapy, doesn't make much of a difference. Does it? Okay. So, yes, yes.
Sorry, wasn't there a bit more separation later on? Because the follow-ups for TADS went on for quite a long time, and then later on they found that there was added benefit from the CBT.
We can come back to that. These are interesting questions. You do realize, though, that these are very far away, and people make these claims. And I think that they're very hard to substantiate. There was a similar claim that was made for psychodynamic psychotherapy in the recent ADAPT trial about latent and sleeper effects. But I think given the time that has lapsed, I would have difficulties interpreting them, to be honest. So are SRIs efficacious then? And if so, for whom? Okay, so we're going to go to another meta-analysis of someone, again, I respect a lot, which is Andrea Cipriani. And this is the network meta-analysis. All people will know what a meta-analysis does, right? I mean, you basically take the effect sizes and you pull them and you weight them by the inverse of the variance, right? So kind of the standard error, right? Now, this is for the fixed effects. If it's a random effect, you just make assumptions about what these studies, where they were pulled from. You don't assume in the random effects that there is one true effect size, but you expect that there will be heterogeneity, and that's what the random effect is. A network meta-analysis, don't worry too much about it, because I'm not going to go into the inferences of the network meta-analysis. It's basically an attempt to overcome the problem of not having done head-to-head comparisons and create them post hoc a posteriori. Does that make sense, roughly? You all know that, sorry. Okay, so what you see here is that fluoxetine and placebo have the biggest circles, So most studies have included, as you might expect, placebo, and most studies, or many, the majority, or many studies, I should say, have included fluoxetine, which is no surprise, right? You probably know that. And then there are several others scattered around here, right? This was published in the Lancet in 2016, I believe. I'm going to magnify this very nice table that allows you to compare each with each. That's the point of the network meta-analysis. But for the moment, we're just going to compare placebo, this row, with with all the other drugs that have been used here, like sertraline, citalopram, escitalopram, paroxetine, nifazodone, imipramine, and all that, and fluoxetine. And to cut a long story short, the only drug that shows separation is fluoxetine. And it shows, this is a standardized mean difference. You remember how the standardized mean difference is derived, right? You take the difference between placebo and drug, and then you standardize it by a pooled standard deviation, right? It's usually some sort of sum of the squared standard errors, standard deviations, and yeah, I think I have it here actually. Yeah, you can see it here. So it doesn't matter you can see the formalisms here, but does anyone remember kind of Cohen's D rules of thumb? If you saw a 0.5, you'd say, well, it's not too bad. 0.5, it's good. Okay, but you need to look at what? The confidence intervals, right? What is a confidence interval? This is very important whenever you interpret a paper. And people can get it wrong. I'm worried that I might get it wrong now. So frequentist confidence intervals. So if someone doesn't tell you that these are Bayesian confidence intervals, in which case you can interpret them as degrees of belief, we can talk about that as well. But if you take them as frequentist, standard confidence intervals, you could think about it this way. It's like I'm going to repeat the same experiment and sample again and again and again, And in the long run, a very important concept in statistics and a very nebulous one. In the long run, right, 95% of the true value will be in the 95% confidence intervals 95% of the time. Okay, that's what it means. So the width of the confidence intervals tells you something about the precision of your estimate. So can you see what the precision of the estimate is here? So it ranges from 0.03 to 1. 1 is a whopping effect size. If you have an effect size of 1, you can just, book your tickets for Stockholm if you can replicate it. So far, insulin and methylphenidate only have reached those effect sizes. And methylphenidate is probably a bit lower, the true one's about 0.8, but it's quite substantial. So this is pretty wide, right? And it doesn't fill you with confidence that the truth is actually not below 0. It doesn't cross the 0 line, does it? So we need to kind of now start decomposing this, right? This estimate is significant, of course, at the 0.05 level, and it hides a lot of possibilities. If I tell you it's 0.5, right, you take it at face value, it could mean all sorts of things. It could mean 0 minus 0.5, or it could be 0.5 minus 1. And these are important things. So always when you see kind of parameters and things that you arrive at after lots of subtractions, and particularly divisions. Divisions are really, really naughty because they can hide a lot of information. Just go back and try to see what that means, right? How would you do that? Okay, let's just focus on these two things here, which is the response rate, right? How many people respond to a drug? And it is, and you can take these as representative for most of the stuff. About 65% respond to the medication group, let's say placebo, and 53% to the placebo. Okay. What does that mean? What are the two things that you notice here? If I told you I'm going to give you a drug that in 2/3 of the people does a good job, would you say, thank you, doctor? You probably would, right? You'd say, oh, that's amazing. 2/3, that's cool. Of course, you're trained and you're going to ask, compared to what? Like 2/3 as compared to what exactly? Like if I sat and did nothing, how would it be? Like the placebo is meant to do that, right? Sort of. And it tells you, the placebo, that you would go to 53%. So how big is the difference? It's about 10 to 12% difference between the two. Is that huge? It's hard to get an intuition for these things. If these were to be scaled across the whole population, then that would be quite a thing. That 10% scales up, it becomes a lot if you do it in millions. I'm not suggesting you should, okay? Because there are side effects, all sorts of things. My God, this is my conscience speaking to me. Sorry. Was this directed at me or?
Is this a man's contribution online or?
Oh.
I think it's somebody that must have muted themselves.
Okay,
online.
okay. Maybe I've exasperated people so much with what I'm saying.
Actually, it sounded like a child, Arjiri, so maybe it was directed to you.
Well, one should listen to children. I'm a child psychiatrist. Yeah. Okay, so one intuition that people have for this is the numbers needed to treat. Do people remember how to arrive at numbers needed to treat? Who wants to say? Basically, you take the inverse of the absolute risk reduction, right? Which is the difference. So if you take the inverse of this difference, 60 odd to 50 odd, you arrive at 1 by 12, 1 by 11, 1 by 10, somewhere there, right? Depending on which ones you do the difference for, right? So what does the numbers needed to treat mean? It means the number of people you would have to treat so that one person responds over those whom you would have expected to respond because of placebo. Does that make sense? I hope I said it right. So, okay, so the numbers needed to treat are about 1 in 10, 1 in 12, something like that. Okay, so this is not great, but what you can see is when people tell you SRIs don't work, well, that's not strictly speaking true. It's just that placebo works pretty well as well for some reason, right? Okay, so, this is what I just told you. Fine. So, and that's across the board. This is the norm, with some exceptions, which I'll come to in a minute. Okay, so the response to antidepressants isn't bad, but so is the response to placebo. What explains responses to placebo? So one meta-analysis that was done back in 2007 said, look, guys, it's like with the adults. And if you had read Irvin Kersh's analyses, Irvin Kersh had already said years ago, it's your baseline severity, right? If you're severe enough, you're going to respond. If you're not severe, you're less likely to respond, right? For those who remember, there was a big controversy. There was reanalysis of the data, what have you. I'm going to come back to something from Irvin Kersh from more recently, which is very pertinent to what we're discussing. But people found that in children and adolescents as well. Okay, that was one thing. The CGI severity score at baseline, you can see the placebo response is higher the lower the severity is. The other thing is the number of study sites, which also correlates with something else which is very interesting that I'm going to come to. The more study sites you have, the more problems you have, in the sense that you have a bigger placebo response. Why would that be? Sorry? Look, variety of prescribers in this case, I guess, possibly, but why would you have a bigger placebo response? This kind of may give us some clues about the nature. They're not giving different placebos here and there. Maybe in some ways, what is it exactly? These findings, some of these findings were replicated, I think this was last year, I should say 2022 here, by the group of Johannes Hebebrand, that showed that, again, odds of response to placebo arm is higher the more number of study sites you have. Study duration didn't play a role. So it seems to be a replicated finding, right? Has anyone done a pharmacological trial in children and adolescents that was drug company sponsored? They tend to have lots of sites, typically. We'll come back to that. Okay, so placebo response. I just wanted, what did I want to show you here? I think I better come back to that later because there's a particular reason. Yeah, yeah, exactly. So the placebo response in young people is higher than it is in adults, than the equivalent one in adults, right? And you can see the figures here, 45% versus 36%, and non-overlapping confidence intervals. Why would that be? See what I mean? That difference of about 10 to 11% could be all the rage, right? In terms of separating from placebo. Now, oops, let's come to something else. This table here is very interesting because if I had told you, let me just go back. If I had told you which studies are more likely to show that drugs work well, pharma funded or publicly funded, which ones will show a bigger drug effect? Pharma, right? Everyone says that. Well, it's exactly the opposite in children and adolescents. In fact, the better separation from placebo comes from the two well-conducted, particularly this March one, well-conducted pharmacological study. Publicly funded pharmacological study. Rather than don't get me wrong, I'm not saying that this is the truth and this is false, but I'm just saying, right? And look at the sites, right? It's 1 and 13, and there you have up to 65 sites. What people have argued is that it is very hard to control the quality of the recruitment if you have 65 sites that are typically scattered around the world. But why would that matter in terms of the placebo response? How would that affect the placebo response? Well, spontaneous remission might be one explanation, right? So there could be a placebo response, and what could be hidden in what we think is placebo response could be what? Oh, it just got better. Anyway, right? Thank you very much. Within the next 8 weeks, I was going to get better anyway. Which goes back to the ethical problem of prescribing drugs. Okay, particularly to people who are not very severe. So it may be because of that. Okay, and I'm coming back to these people here. They used it's the FDA and Irving Kirsch joining forces, and they took the FDA data from the last, several decades, and they pulled all the data together, all the individual study actual data, which is really great, right? And just looked at what's happening, right? People have read this, haven't they? Most of you will have seen this. It was a big news in the BMJ. It's published earlier in the summer of 22, right? So there were two findings that were quite interesting here. Most of you will have heard about the mixture model that they applied. So a non-parametric approach to the data they had, or an approach to the non-parametrically distributed data they had. I'll come to that. But there was another interesting finding, which was the following. And I'm putting the text here because the figures are more difficult to figure out. So I'm just going to start here. Comparing pediatric, which is what the Americans call it, under age 18, participants directly with adults, the unadjusted difference between drug and placebo was 1.12 points, greater for adults. But if you adjust it for baseline severity, the difference between drug and placebo was greater by only 0.64. So it was nearly halved, which means, I'm translating this, that child and adolescent studies have in general recruited less severe cases. This is predicated on the harmonization they did between the adult instrument and the child instrument, which is another big story, but let's take that, at face value. Does that make sense? Great. I'm not going to, it's too late for that in the day. But this is how the data are distributed, right? So if you look at this histogram here, right, this is how the data look for responses. What you see here is change in the HAM-D, right? The main outcome measure for depression, which has been harmonized for children and adolescents as well. But this is everyone adults and children and adolescents and everything. And what they came up with was this mixture model. I don't know how many of you, people often do growth mixture models or longitudinal data to come up with latent classes and say, this is a highly rising one, this is a flat one, this is one that goes down. You come across that sort of stuff, right? It's a way of assigning posterior probabilities to individuals and therefore put them into groups by virtue of those posterior probabilities. So they came up with an optimal solution of 3 groups: a large response group, a minimal response group, and a non-specific group. And the large response group showed a mean change from baseline of 16 points, the minimal just 2 points, and the non-specific 0.894. But what was more important is that in the large group, the active drug response was 24%, whereas the placebo was 10%. So a difference for 14%. Whereas for the other groups, these were much smaller differences, like the non-specific was 63% and 69%. Does that make sense? So there was a wow, and people said, okay, so if we then took, if we know this, then we know that there is a subgroup of people whom we can really help. This is really good stuff. Now, there have been concerns about the way this has been interpreted. And now, this looks here at the cumulative distribution of responses, right? And the y-axis shows the probability that a participant would achieve a result that is at least as good a reduction, a change in HAM-D that you see here on the x-axis. And what you can see is that drug and placebo are not different very much. You see what I mean? That the cumulative distributions are nearly overlapping. Maybe there is a difference here at around 11, 12 points of change in HAM-D score, but nothing like those big clusters. One thing that happens is, and I'm grateful to someone who I don't know, it's Dr. Plödel, and I don't know the person, but I'm thanking him because he pointed that out. And he very kindly, clearly used our plots here to show us, to translate this into difference from baseline, and you can see that you achieve a difference of about 10% between drug and placebo at a difference from baseline about 10 points. But in general, on average, they don't differentiate terribly much, would be his argument. Okay. So just in case you read this paper, bear that in mind, right? There's been an ongoing discussion, but it's important to bear in mind that when you categorize data, you may lose crucial information. Right? So it's worth going back to kind of the raw-ish data. Okay, now are SRIs ineffective across the board? Are they just, stupid? We shouldn't even start with them. And you will hear people say, don't even think about it. Just don't even think about it. Well, a more nuanced approach would be to say, well, do they do anything for anything else? And the answer is yes. Like the placebo response for anxiety disorders is much lower. So the separation between active drug and placebo is much better. Right? This is a meta-analysis of those studies, and you can see here the total for SRIs is a Hedges G. Again, think of it as a corrected version of the Cohen's D. Right? It has a little correction, as I recall. Which is 0.2, and here you have SSRIs for anxiety disorders, a pooled one of 0.71. Always look at the confidence intervals. They don't even overlap, right, between the two. So you could say that they are really different between each other. If that makes sense, right? Non-overlapping confidence intervals means they're different at the 95% confidence interval level, right? So they do work for anxiety. Why don't they work for depression? Or what happens in depression and we have this situation, right? And spontaneous recovery is a favorite explanation at the moment, right? Particularly in young people, which seems to be possibly higher. Okay, what about suicidality? And this is a very important question, because if you were to put your child or your sister's or brother's child, your nephew or any child on an antidepressant, and someone told you that you increased their risk for suicidality, you wouldn't like that, would you? But the FDA told you so and put a black box warning on it. Do you remember? So you should be concerned about this, and this is something that we must, of course, tell the patient when we prescribe them antidepressants and their children and adolescents. You must tell the patient, you must tell the family. You can't just pretend this hasn't been there. Luckily, we have, again, there's been several meta-analyses, and I'll come to Andreas because I think it's really great, and I don't think that people have disputed it very much. I think both kind of camps, if you think about it in terms of people for and against drugs in children and adolescents, were kind of, I don't think they were equally happy or equally unhappy about it, and generally quite high quality. So I just want to say here that in the trials, and I'll qualify this in a minute, but in the trials that have been conducted with fluoxetine, which have included about 800 people, according to my counting, there have been 0 suicides. Okay, as we were saying this morning, one very handy way that if you don't know it, you can just have it in your pocket for interpreting 0 numerators for any sample size above 30 is that you can always say that it is a 1, the upper confidence interval of the risk is 1 by n. Right? So if you do 1 by n for this, you will find, 3 by n, what am I talking about? Sorry, it's too late in the day. No coffee, it's 3 by n, right? And anyone who wants to see the derivation of that, I can send them, we did it recently with our lab. It's very nice, so 3 by 800, and that gets you to about, it should say here 0.4%, I'm sorry, rather than 4%. So if you have a 0 numerator in those 800, you have an upper bound of the 95% confidence interval, right, of 0.4%, which is very low. And indeed, there haven't been completed suicides in those 800 people. Okay, so you shouldn't say the risk for suicide, according to these data, but I'll come to qualify them in a minute. However, there has been an increase in here we are. There has been an increase in suicidality potentially with some drugs, like venlafaxine wasn't great, but for fluoxetine, which is what NICE tells you to use, right? If you compare fluoxetine to placebo, you'll see that it's 0.9 with confidence interval stretching from 0.049 to 1.49, right? And these are odds ratios, right? This here, the question is whether it crosses not the 0, right? But right? Does that make sense? Yeah. Okay. So, can you see that? Right. So, fluoxetine doesn't seem to, according to these data, be particularly problematic if you accept this as the level of inference, right? The 95% confidence intervals. Now, however, I being me, I went back and I looked at the individual studies, right? And I said, how many of these studies had children who were really suicidal? How many do you think? I don't think many. We exclude them. Anything with significant suicidality is excluded, right? So I went back to the studies that have used fluoxetine. Some of them I couldn't find, this is the NAs, I couldn't find the mention. And in some of them, and in the rest of them, the ones here, they have been excluded. So whom do they exclude? People who have significant suicidality, have been recently hospitalized. Who do you prescribe for, though? Do you prescribe for the people who come and walk into your clinic and say, I would really like to have an antidepressant? If you have been suicidal, nah. You probably just wouldn't, right? You might even say, let's just wait, maybe have some psychotherapy, maybe just come back next week, right? So this is a trial that begs to be done. So I'm going to go to NIHR and tell them, I'm going to take a little pause from doing mechanisms. I'm going to do you this trial. Would you please fund it? I'm sure they won't, but anyway. So because we need that, right? You need to do a trial in those whom you're supposed to be doing it, do it with great care, of course, because you might be increasing the risk for suicidality if you're doing it in those patients, or you might be benefiting them, you never know. But it's a very important question. Okay, now what do you do if SRIs don't work? Have I come to the end? I have lost sense of time. 5 minutes. So the answer is there isn't much evidence except for one very brave and good trial, which was the Tordia trial. So I'm going to summarize everything now, and anyone who once more, I can send them my talk. And the Tordia trial said if you have given one SRI, well, just give another if people haven't responded. And indeed, it seems to be good for you to increase, the probability that you might respond the second SRI. Okay. Bottom line is, don't give venlafaxine to children and adolescents, probably, unless you're really desperate. You've tried everything else. There's been a recent trial of ketamine, very small effect size, a very small sample size, 17 people, crossover design, effect size of 0.7, wide-ish confidence intervals. The control was midazolam. I'm pretty sure they were all unblinded, like we're talking about this morning. But it was tolerated okay. But 17 people, if it's a zero, what did we say? If it's a zero numerator, 3 by 17 doesn't sound very good, right? The upper bound of the confidence interval. So, ketamine is a possibility though, if you're really desperate. What about TMS? Because people usually ask me about TMS. Well, if you read this is where RCTs are so interesting. If you read all the open label trials, right? It's amazing. It's like, best thing since sliced bread, like effect size up to 2, extraordinary stuff. Now, if the one RCT that has been done in children and adolescents showed essentially an effect size of 0. So pretty much nothing. Now, there could be several reasons for that, and more needs to be done with TMS and all that, but just so that you know. Okay. There are obviously other possibilities, like you could, and we have written a whole paper about this, what to do with treatment-resistant depression. By the way, often treatment-resistant depression isn't treatment-resistant depression, it's the depression that hasn't been actually treated. So people say, you ask your patient, have you had fluoxetine? Yes. How much? 10 milligrams. For how long? 1 week. What happened then? Oh, I felt a bit energized and was discontinued. Okay, this is quite common. So obviously that is not an adequate therapeutic trial. Or you think, have you had therapy? Yeah, I did. What exactly were you doing in therapy? And it ends up, well, it's not exactly what NICE recommends. So you need to bear that in mind when someone tells you they've had 2 antidepressants and 1 psychological therapy, which is what often the current definition is in child. And I mean, that's how we define it, at least. That was the working definition. So bear that in mind. You can obviously do what the adults do in weeks. We extrapolate the evidence backwards. So we use quetiapine, in desperate cases, particularly where there is bipolar depression, right? So we have used in very desperate cases, and other antipsychotics, like we might use aripiprazole. So you just, do whatever you can after a certain point. But these are rare, and they should be rare. And most people who work with children and adolescents in non-hugely specialist settings probably will come across this quite rarely. Right? If I have to tell you one thing that I would like you to take as a take-home message is treat the comorbidities first, particularly the anxiety. It is very rare in the clinic to see a child who doesn't have anxiety disorders. Typically GAD and social anxiety disorder. These are crippling problems and they're treatable, right? And these are very, particularly social anxiety disorder is a very circumspect problem that you can kind of, as opposed to kind of depression, which can be very diffuse. And you can target the avoidance. And in fact, you can do some behavioral activation on the side, because modern behavioral activation, as some of you will know, targets the avoidance. So it's actually quite good to do that. And you might achieve, and we're doing a meta-analysis actually on that now, trying to show that if you target social anxiety disorder, you might have quite big benefits for depression. Does that make sense? But so do that. A forgotten disorder in depression is very often body dysmorphic disorder. This is not uncommon in adolescents, concerns about how they look. It's often kind of comes together with some eating concerns and people focus on those and not the BDD, or some social anxiety concerns and they don't focus on the BDD. Again, it's worth taking these into account. So good assessment is important. And I'm not going to show you any more slides, and I think I've come to the end of my presentation now. Thank you very much.
Thank you very much, Argyris. I know it's very difficult to talk at this time of the day, especially after everything people have eaten. But
I'll ask you a simple one, just to remind you.
So I'm going to ask you a really simple one then. So well for MDD in
Well,
adolescence.
It's a very interesting question. The only the difference is in the placebo response, right? So if you look at the response rates, the actual response rates are the same for the active drug, but they differ for the placebo. So it must be something in what comes under placebo response. So it may be that you don't have the rate of spontaneous remission. That'll be one explanation in my mind. But you may have a better one.
So my follow-up, if I may be permitted, is because we don't see that pattern in adults.
You don't?
I don't think so. So any thoughts why? Or is that?
Well, the rates, as we've said, the rates of placebo response in depression in children are higher than the rates of placebo response in adults, right? So maybe the anxiety, the nature of the anxiety disorder is the same, whatever. Anxiety disorders are the same and have this, or at least have the same placebo response in both, but depression doesn't. And we know that depression has a higher placebo response in children. By the way, the higher placebo response is not unique to depression in children and adolescents. You get it, for example, in treatment refractory epilepsy, right? So you get it in other areas as well. And of course, the placebo response is not unique to psychiatry, in case someone comes and tells you that. My favorite one is, I don't know how many of you lift weights, but my favorite one is one from the 70s, the era before ethics committees, where you could tell people, I'm going to give you steroids, anabolic steroids, and you actually gave them saline, and people put on both mass and their bench press and their squat increased dramatically, just by telling them that they were going to get. So those were the times when people were permitted to do these sorts of things. So there is placebo response across the board in hypertension. And in another talk, I have kind of gathered some of the evidence from the rest of medicine, not as pronounced usually. Thank you. It's a good question.
Also, this is not actually, I thought it was an online question, but it's a wonderful talk, very interesting. Can I have your slides? Okay, well, that's a different story.
Yes, it is technically speaking a question. And the answer is to the affirmative, yes.
Hello.
Hi.
I was wondering if there's any evidence in young people related to the gut-brain axis and depression.
Yeah, I mean, there is, but it's not great evidence, is my understanding. But we are doing now with the obstetricians in Liverpool. I forgot to say, this is another welcome project that I'm involved in. That I'm advising. I'm not the PI. It's the famous seagull study, where they have 10,000 Liverpoolians to they're being mothers who fall pregnant, and they're being followed up for years after that, scans and everything in utero, everything, and all the samples you can imagine, which I can't name. And so, this will be obviously an observational study. It will be very interesting to see what happens. And I'm kind of part of the team for the mental health outcomes. Now, we are hoping that Wellcome and others will kind of fund us to do the proper big longitudinal study, because, of course, the age of risk for depression, for example, is adolescence, right? That's when it shoots up. So we'll need to take a few years, but they're recruiting the mothers now. So it's quite exciting, actually. Yeah.
Thanks. I have a question. Thank you for your talk. I really enjoyed it. I just wonder if you have any comments on, I guess, an evolutionary perspective for, I guess, emotions such as low mood and anxiety, and whether we are overdiagnosing, overtreating, and whether the seemingly universality of these, I guess, emotions are we overfixate and try and overtreat.
Yeah, I have a whole talk devoted to this, which I was going to give tomorrow, but then I thought that because it is aimed at clinicians, I should talk more about irritability and emotion dysregulation, because people see that in their clinic, whereas the evolutionary stuff, but I have whole talks and we're writing papers on this. It's a very important question. In fact, the whole theory of emotions, or the theories of emotions, and whether emotions are or aren't, is central to psychiatry, because most of our disorders have to do with emotions, right? And what people don't realize is people treat emotions as if they were kind of natural entities. They use a very antiquated model, pre-Platonic even, that you are kind of being stricken by emotions. It's very romantic. I fell in love. And, my life changed and all that, which does happen, as we all know. But emotions have other functions as well, right? So you throw emotions at others, and society expects you to have certain emotions. They're very interactive emotions. And the way we regulate them is not just hedonic, it's also instrumental. So there's a huge amount of it. And if that's true, for which there's experimental evidence also from our group, then it seems that it wouldn't be far-fetched to think that it could easily, you know, a disorder that is based on some thresholds for something emotional could easily lead to, I don't want to say it's over-labeling, but to pretty big fluctuations across time in terms of what is a disorder. So if you ask me personally, but I have to adduce the evidence for that, yes, I do think that the prevalence is inflated, provided there is a true prevalence. But, you know, there's quite a lot that is being diagnosed, and I don't think this is necessarily good. But also imagine something else from sociology. What does it mean to have a disorder these days, right? It's become very medicalized, and I'm, you know, very medical. Not some sort of, you know, just, you know, come from neurology. I'm kind of very, very, very medical. But is it good to say, you know, to someone you have a medical illness? In some cases, it's probably very good. It's liberating. In some cases, it's probably not good, right? Because people act, because we're interactive kinds, people act out the label that is given to them, probably, right? Because you become that person who has that thing. And we've written an article on this, and we're trying to test this now. The notion that one of the most difficult things, I think, is to be inconsistent with yourself. So if the image you have about yourself is of a particular kind, even if that kind is negative, I think you will find it very difficult to change. Now, one of the key things is that in child and adolescent psychiatry, our illnesses are early onset and they're chronic. These are not the things like, oh my God, I just, you know, had a manic episode. It's like, oh, I've been depressed and, you know, and I've had an awful life with all sorts of bad life events happening to me. I am that sort of person. Telling a person, well, you can be someone else, you know, well, that may be a dissonance with who they want to be and who they've learned to be. I'm not saying that it is fate or anything like that, but we need to take that into account. I think this is fundamentally different to what happens when you have acute myeloid leukemia, for example. You say, well, I didn't have it yesterday, I have it today, please take it away from me. Like when my father had acute myeloid leukemia, it wasn't even a second thought. He just rushed to the hospital and said, just treat me. Right? That's not always the case with the stuff that we're dealing with, particularly with young people.
Hi, I was just wondering if you would use bupropion as a primary antidepressant in someone with comorbid ADHD?
No, I don't. Which, I mean, maybe we should do the trials, you know, the proper trials. But the way I treat ADHD and comorbidity is I first treat the ADHD, just because it makes sense. Because the treatment effect you can achieve for ADHD is massive and quick. And you know, within a week, maybe two, oh my God, this is working, right? So I would just use the regular methylphenidate. And very often what happens is that ADHD, you know, creates depressogenic environments, right? So no one likes you. And at some point you do start to care about the fact. So this is from an old football motto, but you know what I mean, right? People at some point think, oh gosh, no one really likes me. Okay, so if you could revert that by treating the ADHD, I think very often you don't need to treat the depression, in my experience, but we need to do those trials. The other thing is, someone talked about modafinil this morning. There have also been trials with methylphenidate in old age depression and some with regular depression. It's quite an interesting thing to use in anhedonia, obviously, right? And again, anecdotally, I've used it based on my interest in reward processing and all the mechanistic work that I do. And because I was desperate and didn't have anything else, again, to good effect, but this is very anecdotal. So, but I would go rationally and first treat the ADHD, unless someone is catatonic, of course, which is then a different matter. ADHD is also probably slightly inflated at the moment, but that's a whole different talk. Yeah.
This was great. You might actually have the pleasure to chat to Argyris over the aperitif. So please join me in thanking him once again.
Thank you very much. Thank you.
And now, given that we have reduce the age group of the talk of the topic, we're also going to reduce the age group of the speakers, because we're going to conclude with 3 short poster presentation. And please pay attention, because you need to vote. And if you don't vote, tomorrow you won't eat. I will count who has voted, because I get your name when you send the email. And we're going to have Marco, Eleonora, and Fatima, who represent Milano, Palermo, and Canada. Fatima, what about in Canada are you from? Say again? Toronto, okay. So Marco, usually it's ladies first, but in this case it's gentlemen first. And I think your poster is up. So the rule is you have 5 minutes, and so we will, I was going to say judge, is not very politically correct. We will rate your performance on keeping time, clarity, and of course the content and the presentation of the poster. So be all ready to send your email to Jada and to Brian. And you know the order will be Marco is number 1, Eleonora is number 2, and Fatima is number 3. So you can give a score 0 to 10 to each of them, sending it to Brian and Jada, please. The first score goes, am I able to have my poster on the slide? Gianpaolo, what's happening to the poster? Oh, there we go. Great.
What?
Yes, you send the speakers, send an email to me.
Hello, I'm Marco Paolini. I'm a PhD student from San Raffaele University in Milan. And my poster is on neutrophil to lymphocyte ratio and antidepressant treatment response, the effect of sex and of hippocampal volume. In recent years, much focus has been put on the role of immune inflammatory mechanism in affective major depression development and also in affecting treatment response. Among inflammatory markers, neutrophil to lymphocyte ratio can be easily obtained from a routine blood count. It has been originally developed in oncology as a prognostic marker, but it has since been investigated in several fields of medicine, including in psychiatry, where it has been associated where higher levels have been found in patients with major depression and in large population studies, actually, specifically in women. Among brain structural predictor of treatment response, one of the few consistently reported are lower hippocampal volumes that seem to predict a worse treatment response. Therefore, the aim of our study was to investigate first the relation between neutrophil to lymphocyte ratio and treatment response, which is much less clear, and then to investigate the effect of neutrophil to lymphocyte ratio on hippocampal volume and testing a possible mediating effect. Our study was conducted on a sample of 124 patients suffering from a major depressive episode with a diagnosis of major depression, which were admitted to our psychiatric ward. The level of depression symptomatology was assessed at baseline and at discharge through Hamilton Depression Rating Score, and the two scores were subtracted to obtain a measure of treatment response. NLR was calculated from a routine venous blood sampling performed at admission, and all patients underwent 3 Tesla MRI scanning, and bilateral hippocampal volumes were then estimated. So what we found was first that there was a significant moderating effect of sex on the relation between NLR and treatment response, with a negative association in women and a positive one in men. NLR levels negatively affected hippocampal volumes, only left hippocampal volume on the whole sample, and both hippocampal volumes in women, with no effect in men. It has to be kept in mind, though, as in line with major depression epidemiology, the male sample was much smaller, almost half. Hippocampal volumes, as expected, had a negative association with treatment response. Lower hippocampal meant worse treatment response. And finally, we identified a significant indirect effect of NLR on treatment response through left hippocampal volumes in women. We then perform a moderated mediation analysis, but we identified no moderating effect of sex in the indirect part of the model, and therefore the index of moderated mediation was not significant. On the other hand, the direct part of the model continued to exhibit a significant moderating effect of sex, again with opposite direction. Therefore, sex was found to moderate the relation between NLR and treatment response. The detrimental effect in women is in line with previous research showing an unhampered antidepressant response in patients exhibiting signs of subclinical inflammation. The positive effect in men is less expected. However, to date, the only 2 studies investigating the effect of NLR on treatment response report a positive association in patients with psychotic depression. In women, NLR affected treatment response partially through its effect on left hippocampal volumes, providing a mechanistical but incomplete explanation for the relation between the two. And finally, sex moderated the direct but not the indirect part of the model, suggesting the divergent effect in males and females to be independent from the effect of NLR on hippocampal volumes.
Anybody would like to ask a question? Robin?
I didn't expect to have questions, so I've not thought of one.
Okay.
So,
what were the treatments?
These were the real world studies. So these were patients admitted to our hospital that received preferentially as a first line SSRIs, but then later on switched to those who have had the worst response rates switched to SNRIs and also add-on treatments for depression, such as low dosage aripiprazole or add-on mirtazapine or add-on bupropion. We try to control for the dosage of prescribed antidepressants through imipramine equivalents, but we couldn't control for the whole complexity of the prescribed pharmacotherapies.
Thank you, Marco. Thank you very much. They've been mentioned to Eurovision Song Contest, so if you like to vote for Marco, the number is 1. And now we have Eleonora, who is playing at home because is from the University of Palermo. Eleonora, to you. Hold on, hold on.
All right. Good evening, everyone. We are going to talk about mental health in Sicilian medical students. We know that college students are at higher risk for psychological distress, and that seems to be even more true for medical students. Of course, many reasons have been investigated. For example, an interesting one is that in the last years, some studies suggested that medical students sometimes might possess a specific personality profile that make them at risk for psychological distress. Maybe those students are more competitive, reaching for perfection. Of course, that could be stressful. Lately, and besides that, the pandemic had a role in increasing mental health, mental distress, and that, of course, for the aforementioned reasons, even in medical students. So help. Thank you. So we made a web-based cross-sectional survey, and we collect a sample of 1,866 records of Sicilian medical students. About these records, we asked our students questions about anxiety, stress and depression, also eating disorders and suicidal ideation. First, we found a score for both stress, anxiety, and depression that were higher than expected compared to another study conducted in the center of Italy during the pandemic. In particular, we found severe to extremely severe score for 33% of students for stress, 53% for anxiety, and 40% for depression. More deeply, looking at DAS scale, DAS 21 scale, we found some specific factors that were predicting a higher risk for both stress, anxiety, and depression. For example, being female, perceiving the pandemic as a negative impact on their study, using drugs and supplements as a strategy for facing negative emotions, and also asking for tutoring and supporting for her psychological distress. So maybe those students know that they need help. Looking at suicidal ideation, first 26.4% of students declared to have had at least once in the last 6 months at the time of the survey suicidal thought. Also, adjusted score for both stress, anxiety, and depression increasingly predicted a higher risk for suicidal thought when above the sample mean. Finally, looking at the EAT26, you can see that our students also had a risk for eating disorder, both for pathological dieting, bulimia, anorexia. And as you can see here, according to the cutoff of EAT26, those students were at risk for eating disorder and especially for consulting a specialist. That's because 26.7% of students were either having a score of 20 or using laxative and vomiting or a BMI under 18. Finally, and that could be a good point of view, we asked our students if there were something that the university could do for them in order to help them with their mental health. And actually, students with stress and anxiety asked for more tutoring and psychological support, and also for the developing of an app that could help them to monitoring their mental health. We know that med students are undertreated. We think that this should be more easy to access to psychological support, but they are not. So probably in the future, our point and goal point should be to provide a preventive approach. So maybe developing an app or also helping them with psychological support. Finally, our results confirm that the DAS 21 could be a good way for assessing the risk for mental health in our students. Thank you for your attention.
You did hear the Palermo fan club. Eleonora, while we have the poster up for Fatima, two quick things. We were very surprised with Professor House about the 28% using laxatives. Okay, fair enough. So it was not just... And the other thing is that, did you ask about substance misuse? Okay, thank you very much. Sorry, Robin, you can ask Eleonora over aperitif. Fatima, to you. You've been very good at keeping on time, I have to say.
Hello.
Hello. You already deserve a prize for a very long journey.
I did. How does this work? What do I press?
Although I don't know, Alessandro is
Oh,
putting it on. There it is.
That's the biggest.
Perfect.
Hi, everybody. I'm Dr. Ahmed. I just finished residency in Canada. I'm about to start my big girl job soon at the Center of Addiction and Mental Health, but this was my senior research project, so I thought I would present it for you guys. So we focused on exploring the mediating and moderating effects of sexual orientation and childhood sexual abuse, and how that can impact mental health outcomes in adulthood. Where is the clicker? Yes. This? Oh, there we go. Got it. Sorry about that. So the background is that we're well aware that individuals that identify as a sexual minority have higher rates of mental illness. So those can be individuals that feel they're completely identifying as homosexual or partly identifying as such, or bisexual. So there is known to be an increased risk of mood disorders, anxiety disorders, OCD, substance use disorders, as well as an increased risk of suicide, particularly increased suicidality, self-harm, and suicide attempts. They also have an increased prevalence of sexual and physical abuse, and previously studied to be 1.6 to 4 times increased risk compared to their heterosexual counterparts. So it's unclear how the childhood sexual abuse and minority status interact, and that was the purpose of this project. So we had 2 hypotheses here, a mediating effect and a moderating effect. I won't go into too much of that because I feel like other presenters have talked a little bit about that. There's some definitions there. But here, the sexual minority status, I'll refer to that as SMS, and that being the independent variable, and the poor mental health outcomes being the dependent variable, and then childhood sexual abuse being the mediating variable. The second one being the moderating effect, and seeing if a sexual minority status is going to moderate the relationship between childhood sexual abuse and poor mental health outcomes. So we actually used a survey that was done, it was an adult psychiatric morbidity survey from the UK in 2007. And it was people living in like private households, anyone over the age of 16 was included, risk factors identified as identifying as a sexual minority, as well as exposure to childhood sexual abuse, which was defined as non-consensual touching or intercourse before the age of 16. There were some people in this survey that said that they didn't know or they weren't sure if that occurred, and I feel like that could definitely impact our results here. Primary outcomes identified as non-psychotic psychiatric disorders, which includes depressive disorders, GAD, social phobia, OCD, panic disorder, and agoraphobia, as well as a recent suicide attempt, which would be in the last year. We ran logistic regressions with effect decompositions to be able to break down the effect here. So the results were that out of this 7,332 people, 251 identified as SMS. The mean age wasn't exactly the same in the 2 groups, 46 in the SMS group and 51 in non-SMS. But gender-wise, equal representation, and you can see here that exposure to childhood sexual abuse in a sexual minority population is a lot higher than non-minority population, 16.9 compared to 8.6. Same with neurotic disorders, 26% compared to 16%, and a recent suicide attempt, which is 3.2% versus 0.61%. So running the mediation models here, if you look at the direct effect of belonging to a sexual minority status, the risk of developing a non-psychotic disorder, the odds ratio is about 1.7 with significant p-values. And CSA does not really mediate a whole lot, just 15%. Same with suicide attempts. Odds ratio of direct effect of 4.49, so very significant here. And then and when you account for childhood sexual abuse, it maybe accounts for 7%. So our findings were that the mediation effects weren't very high in terms of childhood sexual abuse affecting a sexual minority status. This was to look at the moderating effects. So I don't know if you guys can see here. I wish this could be bigger for you, but this is the sexual minority status. Anyways, both of the factors increase the prevalence of psychiatric disorders and risk of suicide. We should further look into moderating effects. That's all I got. Thank you.
You're very welcome. Thank you very much. And so a question, just one question from Argyris.
Thank you. Very important topic and very well presented. If you go back to that slide, can you explain to me, please, the causal pathway in your mediation model? Because it goes from sexual abuse to, it goes from, sorry, from being a sexual minority to childhood sexual abuse to the outcome.
Yeah.
Right. So how would that work causally? I don't like you know, I know you probably have them cross-sectionally, the data, but this would assume that the SMS is prior. So I was just wondering about the causal implication.
So I'll try my best to answer that question. This SMS here is considered to be an independent variable, and this is its direct effect. And then CSA here is being presented as a mediating variable. And so then you break down with decompensation to see what are the direct and indirect effects to see if there is a mediating effect here. I don't know if that answers your question, but let me know if you have any other questions. Thank you.
Over the aperitif. Thank you very much for all of you that have stayed so long. So you can make your way to the aperitif, which is via Vittorio Emanuele 291 or the roof terrace of the Quattro Canti Hotel. You should all have in my email. Or you can follow me. I just have to pop to the ladies, I should say. So don't follow me there, but meet me downstairs outside the entrance of the palace, and we can go there together. Otherwise, thank you everybody for your question, the great presentation from the speakers and the poster. And don't forget to vote. So Marco is 1, Eleonora is 2, and Fatima is 3. Thank you very much. Oh, and tomorrow, remember, the venue is not this one. You come here, you're in the wrong place. So look at the email you have received for direction and instructions.
Recording stopped.